Morning, everybody. I'd like to welcome you again at Saudi Society Bariatric and Metabolic Surgery meeting, fourth one at Jeddah. Thank you all for coming. I'd like to thank you all our national, international, and local speakers for being with us today. So we're gonna start our first session today around 8:30. The session will be moderated by Dr. Helmut Bailey, Dr. Adnan Sabahi, and Dr. Ayad, if they can come to the stage. So we have 3 announcements. We'll repeat this announcement every time. The first announcement regarding the social activity today. There will be Jeddah tour bus at 5 p.m. Around 5, they will be waiting outside the main entrance. They will take you 3 hours tour. They will take you to Old Jeddah, Old Town, and then we'll come back to start gala dinner at 8 p.m. There will be folklore band. There will be Hijazi, we call it Hijazi, dancing, and there will be also, it will be in the swimming pool area in the main hotel, down the stair outside. That's the gala dinner tonight. Everybody is welcome. The last announcement, there will be General Assembly for Saudi Society and Bariatric Surgery Society. For all members, registered member has to attend. We'll be here in the main hall at 5 p.m. So all Saudi Society members has to stay at 5 p.m. We have General Assembly. Those going for the tour, the bus will be waiting outside after we finish the last session. And then we will bring you back to the hotel at 8 o'clock, before 8, so we can start our gala dinner, inshallah, at 8 o'clock. So that's the announcement. We'll repeat this announcement through the day. Now we can welcome our great moderators, Dr. Helmut Bailey, and Dr. Adnan Sabahi, and Prof. Ayad Al-Qahtani. And they're gonna start the first session, inshallah. Good morning. Can everybody take your seats? We're starting, guys. Talk a lot. Go ahead. The side mic, please. The mic there is not working. Check the other mic. Mic not working there.
السلام عليكم ورحمة الله وبركاته. السلام عليكم ورحمة الله وبركاته. Good morning, everybody, and welcome to Jeddah to start our SASMBS meeting. We'll start our presentation today by one of the pioneers in the bariatric surgery. He's working in St. John's Regional Medical Center. It's one of the bariatric center of excellence, and he's one of the member of the SASMBS, and he's coming all the way from the USA to visit us for the first time in Jeddah, and to present to us and talk about the role of bariatric surgery in class 1 obesity. I would like to welcome Prof. Helmut Pili to the stage and to present his talk. Yeah, thanks.
Do we have something to advance the slides? Do we have a clicker? A button? Do we have a clicker? Because oh, here it comes. Here we go. Perfect. Okay, after that little slowdown, which is to be expected at almost every meeting I've ever been to, I really want to thank everyone for inviting me. This is my second time to the SASMBS. The last one was in Abha, and it was a really well-run meeting. I'm very happy to be here. I'm going to talk about the role of bariatric surgery in class 1 obesity, and in many programs and practices, you simply don't operate on anyone whose BMI is 34. Many people get turned away, and we're going to explore the reasons why and really if those are valid reasons anymore. So it really, is there a problem? All of my experiences in the United States, and things are a little different there because we have insurance companies and we have cash patients. If we look in the United States between 2000 and 2002 and 2011 and 2014, the percentage of adults with class 1 obesity has increased from 17.9% to 20%, and this probably continues to increase. In the US, more than half of those who are obese fall into class 1 obesity range, so it's a significant number of patients that we may just be turning away. With respect to men and women, women make up 35% of the obese people in the US and 31% are men, so a full 1/3 or more. Why even should we look at class 1 obesity? Well, it's really a problem in the US and in many other countries that use insurance or national standards. In the US, we have private health insurance, we have Medicare, which follow basically the same standards. And the problem is they follow a baseline BMI. They rely on an old 1991 consensus statement that set a baseline BMI that somebody needed to cross with which to become a favorable patient with respect to risks and benefits. And really the time has come to address whether the appropriateness of bariatric surgery for the treatment of patients should be limited to a BMI and rather than looking at their comorbidities and how obesity surgery could help them. So is class 1 obesity really a clinically relevant problem? And it is. Is it adequately managed by non-surgical means? We have this habit of making people go to the dietitian, exercise, do all this stuff for an unknown period of time, and most of us would agree that this is not going to be effective therapy. Is there any evidence that bariatric surgery procedures provide well-tolerated and cost-effective treatments for class 1 obesity versus these non-surgical treatments? So when we look at the impact of class 1 obesity, which is a BMI of 30 to 35, on health, it's associated across the board with increased medical and psychological comorbidities. There's diabetes, there's high blood pressure, there's dyslipidemias, non-alcoholic steatohepatitis, obstructive sleep apnea, polycystic ovaries, infertility, bone and joint diseases. All of those are significant health problems that we simply accept. What about cancer? Well, we know there's an increased risk of cancer with morbid obesity, but what about class 1? And something as small as a 5 kg per meter squared increase is associated with an increase in esophageal, thyroid, colon, and renal cancers. And similarly, in women, we see endometrial, gallbladder, esophageal. Many cancers are affected by this, and maybe weight loss should be something we look at a little more aggressively than we're currently doing. I think the most important thing in this talk is that it's going to reveal that BMI is really a poor indicator of determining whether somebody should be a candidate for an operation or not when trying to improve their health. And we can really conclude that class 1 obesity is a chronic disease that clearly leads to other additional comorbidities and could possibly shorten the life expectancy of these patients. It deserves effective and durable treatment, and BMI alone being the poor indicator when we look at other factors with respect to health like adiposity, metabolic disease, cardiovascular risk, we see that the health risk of somebody with a BMI of 35 with visceral and internal fat is actually at higher risk for these cardiovascular and other medical problems than someone with a BMI of 37, yet the person with a BMI of 37 will be the candidate for surgery. What are our options? Well, everyone will agree that we should start with non-surgical treatments for class 1. And really what we should be focusing on is a treatment that is the effective, best treatment, and that should be the preferred option. So is this the most effective treatment? Well, the dogma that we have is we should begin with non-surgical therapy and consider bariatric surgery only if they are unable to achieve sufficient long-term weight loss and comorbidity. This sounds good. This sounds responsible. This sounds like a very good treatment plan. Why is this a good plan? For how long? Do we do it for 2 months, a year? How long do we let somebody prove that they are not able to do this? And finally, if we're looking for the patient to fail this before we actually operate on them, we're giving them the responsibility to failure. It's easy to fail. It's difficult to achieve what all of you have achieved in your careers, but imagine if you were asked to fail something in order to get something. So it makes no sense to me that a patient who's not motivated to do any of these things is going to be made to wait a year to prove that they fail. So class 1 obesity is not really set up in order to have the best interests of the patient. If we look at lifestyle modification programs, they're all done differently by everybody. Pharmacotherapy, we all have access to the same medications, and the problem is they only provide modest weight loss, they're high cost, they have adverse events, and all of these things have to pretty much be taken for a long time, so they're set up to fail. Endoscopic intraluminal procedures, there's temporary balloons, there's ESG, there's gastrointestinal liners. Most of these other product-related treatments are really poorly proven as to their efficacy and their durability, and maybe they'll have a role in the future, and we welcome anything that's more aggressive and less aggressive than our more aggressive operations if they can provide results. Requiring non-surgical attempts. This is, I find, to be the most frustrating thing for me as a physician to understand. Non-surgical groups of therapies will not provide durable solutions to the disease of obesity, and the majority of patients that we take care of aren't going to lose substantial weight, and we wait and wait and wait until they prove that to us, and we know it's going to happen from the very beginning. And the majority of those who are successful will regain their weight in 1 to 2 years. So we can be delaying treatment of patients for 1 to 2 years while they prove that they can succeed and then fail, and we knew that was going to be the outcome from the beginning. What does the literature say? Well, there's lots of randomized controlled trials looking at exercise and behavior. The mean weight loss is 2 kg to 6 kg in the range of a year or less. There's poor maintenance of that. And some studies have reported 25 to 50% of individuals can actually sustain a good weight loss for up to a year. This is wonderful, but we forget that that means 50 to 75% of the patients we take care of are achieving absolutely nothing during that year, except the failure. There's cost, who pays for this, and why are we delaying treatment? I just don't understand why we have to prove this. What are the positions? Well, it all goes back to the NIH consensus statement. This is now a 29-year-old opinion. What do we do in surgery today that is still the same as it was 29 years ago? And why hasn't this been updated? Well, it considered the role of bariatric surgery, and the consensus panel got together, came up with an opinion in 1985, and then the second one in 1991 came together involving gastrointestinal surgical opinions, and the recommendations were the same. Bariatric surgery should be for class 2 and class 3 with a BMI greater than 35. So what have we learned over 29 years that warrants to be changed? We know there's new procedures. We argue all the time. The latest one everyone argued about is endoscopic sleeve gastroplasty. I don't know if it's going to work. Maybe it will. I welcome it if it does. But we have sleeve, we have bypass, we have SADI, we have DS, we have laparoscopic surgery that has replaced the open surgery that led to these opinions. There's a high level of scientific evidence now available that these health hazards from obesity are far better understood. They're far more dangerous, as far as we appreciate, than they were 29 years ago. And the risks of surgery have gone down, that many studies in the US will show that bariatric surgery has less risk now than having a gallbladder removed. So we get back to, we currently deny patients solely on the basis of a BMI level, regardless of their comorbidities. This just doesn't make sense. If we look at the IFSO statement, which came out in 2014, it starts to move us in a different direction. But the NIH statement stays the same. Access to bariatric surgery should not be denied on the basis of a BMI level. Bariatric surgery should be considered in patients with class 1 obesity on an individual basis. It's not going to be below the standard of care to operate on someone that you have considered should be somebody who can improve with weight loss. You should do your comprehensive evaluation. You should determine what the future risk for this patient is with respect to comorbidities, and there should be some kind of documentation of failure per the IFSO report. But how long, what kind of failure, that has yet to be agreed upon. Now, there was another one. A joint statement was issued by our medical colleagues at the International Diabetes Organizations, and it was published in 2016. It was the second diabetic summit, was an international consensus, and they convened to develop global guidelines on the benefits and limitations of bariatric surgery for type 2 diabetes. And their statement was endorsed by 45 worldwide medical societies, and the statement's as follows. Metabolic surgery should be considered an option to treat type 2 diabetes in patients with class 1 obesity that is inadequately controlled and has hyperglycemia despite optimal medical treatment. And we're not doing that. And those National Institutes of Health, so Harris is here as our esteemed guest from Great Britain, and he knows what the NICE opinions are. The NICE guidelines are evidence-based recommendations for healthcare in England. Most recent ones were published in 2014, and bariatric surgery in people with a BMI of 30 to 35 with recent onset, meaning less than 10 years, diabetes should be considered. But it also needs to be combined with some sort of weight management services. That's easy. I have no problem with that. I think it's a good idea, but at least we're now considering operating on patients who could benefit from it. And there's no mention of failing a one-year attempt at these medical treatments in order to qualify. Now, I'm not going to show much in the way of the data, but these slides are actually quite telling because the bottom two represent BMI of 35 and above and BMI of 35 and below that was treated surgically with respect to the change in hemoglobin A1C. And there's a huge statistical difference that goes out 60 months or 5 years as improvement in terms of the patient outcomes, and they're very similar. This is another study that showed the effect of bariatric surgery versus medical treatment on type 2 diabetics in patients with a BMI less than 35. And again, out to 60 months, you can see that the surgical group has a much better hemoglobin A1C across the board than the medically managed group. With respect to change in BMI, we all worry that if we operate on someone with a type 1 classification, their BMI is going to drop and they're going to get malnourished. But again, the surgical group doesn't seem to drop with respect to a BMI of 35 below those that had a BMI above 35. So there really should be no danger here. And the same thing was reproduced in this second study showing 5-year outcomes. With respect to the findings on different surgical procedures, there was a nice meta-analysis done, and I'll show some of the data a little later, but he looked at adjustable gastric banding, sleeve gastrectomy, Roux-Y, single anastomosis, gastric bypass, and biliopancreatic diversion. And again, across the board, there's an excellent weighted BMI change and a favorable weighted mean change in the hemoglobin A1C. All of these are in patients with a BMI less than 35. So why wouldn't we do this? And why would we make somebody wait 6 months or a year while they prove to us that they can fail at something? So this all goes back in the United States to an original ASMBS statement issued in 2012, and it summarized the data. But there were only 4 randomly controlled studies and 16 observational studies. From 2012 to 2020, we now have additional studies, 10 more reviews and meta-analysis, 8 randomized controlled trials, and all of these studies continuously and always demonstrate an improved comorbid conditions when compared to medical treatment of class 1 obesity. And with respect to type 2 diabetes, we always see improvement, and these patients all have significantly improved sustained weight loss. So some of these studies I'll run through really quickly, because you almost have to see them over and over again. We're seeing the same result. Lee was the first to publish the meta-analysis, 13 studies on various procedures, all of which looked at BMIs under 35. 80% of patients were able to achieve glycemic control, hemoglobin A1C less than 7% without medications, lower incidence of complications, and no mortalities. A literature review by Rice and the role of various surgeries in patients with type 2 diabetes and BMI under 35. 29 studies, all these different types of surgical procedures were looked at, and they found a mean 5 kg per meter squared decrease in BMI in these patients. The Roux had 70%, and the single anastomosis gastric bypass 72% better glycemic control compared to other listed medical modalities. The hemoglobin A1C was less than 6% without diabetic. A famous study published a large systematic review examining patients with type 2 diabetes in class 1. At 12 months, the rate of diabetes was at 55% for remission. Hemoglobin A1C, again, less than 6.5%, no medications. The adjustable gastric band had the lowest rate of diabetic remission, and the biliopancreatic diversion had the highest. But all of these were better than medical management. There's a low incidence of complication, 5.4%, and a 0.4% mortality. This is the study I call All You Have to Fear is Fear Itself. This is the one which published a large analysis. Hemoglobin A1C shows the same results. BMI less than 35 undergoing bariatric surgery is very similar to the results you see with BMI over 35, about 2.8% drop in hemoglobin A1C versus 2.7. But despite having similar reductions in hemoglobin A1C, we saw almost the same type of weight loss. The lower your BMI was, the less weight loss you got. And so fear of excessive weight loss and malnutrition seems to be unfounded. It just seems to be something we think will happen. But bariatric surgery in class 1 clearly does not result in excessive weight loss or unexpected malnutrition when the surgeries are done properly. The least effective, again, were the adjustable gastric band, and the mean rate of complications was 8.1% across all of the surgeries. These are all reasonable. 5 mortalities were reported across all these studies, giving a mortality rate of 0.02%. Another study, the Roux-Y on diabetes, solely in patients with a BMI under 35. Again, that 2.8% drop in hemoglobin A1C. We're starting to see the same numbers over and over and over again. 0 deaths, mean hospital stay 2 to 2.5 days. So meta-analysis, BMIs over 35, and diabetic patients, remission rates of over 35 was 71%, under 35, 72%. These are remission rates. BMI was not an independent factor. So if you were heavier, it didn't mean you were more likely to get a cure than the lighter weight patients. Improvement in hemoglobin A1C was independent of the preoperative BMI. So again, thinking that we have to only operate on the people whose BMI is over 35 seems misguided, or we're uninformed and we're not reading our own literature. And diabetic remission rates across the different procedures varied from 60% after sleeve gastrectomy to almost 90% after BPD.
1 minute.
Randomized controlled trials are showing the same thing. Iraq Mudin did a study of 120 patients, again showing the same thing. Schauer did the Stampede trial, 5-year outcomes, which again show the same thing. So overwhelming us with these papers, and I didn't even touch on all of them, shows safety that is acceptable, low morbidity, low mortality, 1,300 patients looked at, 4.2% morbidity, mortality of under 0.15%, and a reoperation rate that's very low. So as we conclude what role surgery plays for type 1, class 1, it doesn't play a big enough role. How many of us in the room can say we are turning people away because of their BMI? Non-surgical treatments are ineffective, we can agree on that. BMI inclusion criteria was established arbitrarily more than 25 years ago, and we still follow them. There's no evidence to suggest the clinical efficacy, cost effectiveness, or ethics that justify this group not being moved quickly to surgery. And access to bariatric surgery should not be denied solely on BMI. BMIs of 30 to 35 and obesity-related comorbidities are the patients that we should be considering to move along with this, even if insurances won't approve it, and even if the patients have to pay for their own surgeries. There's high-quality data, and we should strongly consider these patients to have more aggressive treatment when they have type 2 diabetes. Thank you.
Thank you very much, Dr. Bailey. Any questions? Mike, please.
Thank you for an excellent presentation on class 1 obesity. I'm a class 1 obesity surgeon, and I'd say in your talk you mentioned only one group, the group of class 1 with metabolic disease or metabolic syndrome diabetes. And I bring to your attention the recent SASMBS in 2017, in which I think if you look at, I think the fourth point when they mention is that they strongly recommend bariatric surgery for diabetes in class 1, but also they would prefer for non-diabetic metabolic syndrome, bariatric surgery. I think Kim was the one behind
Yes.
that paper. So that was one point, that the position has moved even for non-diabetes metabolic syndrome that they're advocating in class 1 obesity. That's an official position of the SMBS, and I think IFSOS has a similar paper. The other 2 points is, I've done patients where basically, what I call the false BMI you've mentioned. I'll give you an example, a patient with a lost limb, you have to add 10%
Sure.
for their weight,
Yep.
etc. Cases of this sort, polio patients, where they have cachectic small limbs. So you have to correct the BMI and central obesity. And then there is the third group of patients whom I call them, they come for other diseases. Like they'd come for a Nissen and their BMI 34. Or they've come and had a band and they came back to you at BMI 33. I think the revisional and those ones also are categories under class 1. So people are becoming more and more encouraged to do more class 1 obesity. Under, I call them non-metabolic disease as well. What's your experience with
No,
that?
I completely agree with that. I think when I get up and have to give a talk on it, I have to focus on the convincing things, and I tried to sneak in there with my charts that the weight loss is excellent. So if we just look at the weight loss alone, we're not subjecting them to weight loss risks of losing too much. And I think the take-home message from that is that you can operate on these patients just for weight loss alone if that's a significant problem in that patient's life.
Thank you. Thank you very much, Dr. Bailey. I think we have to move to next speaker. Our next speaker is one of our pioneers in Saudi Arabia. He had his basic medical study in Riyadh. Then he moved to Canada to finish his postgraduate. And he came back as one of our famous national, and he was specialized mainly in the endoscopic procedure. I will leave the talk now to my friend, Dr. Aid Qahtani. He will talk about the endoscopic treatment of obesity, primary or revisional.
Thank you so much, Adnan. It's really a pleasure to be with you here, and thanks for the society for their work. I think we'll be talking about an important topic. Nowadays, we have a group of patients who are not served, especially those who are not yet candidate for bariatric surgery. And we know, as has been also mentioned in the previous lecture, that other tools of weight management in terms of lifestyle changes and medical are not really successful in the long term. and at least in the intermediate also. And so we have a bridge which is bariatric, endobariatric, to bridge this gap. And we know if you look to different options, we are always aiming in nutrition and lifestyle in this level, very low achievement in terms of total weight loss and also durabilities. Medication is in this level still less than 5% total weight loss and here. And we go little bit in the balloon up to 10% weight loss. But between 10% and 20, this is where we are talking about endoscopic approach, which is different banding also lying in that level. And then we have about the bariatric surgery, sleeve and bypass and other tools. So we have this zone which is not yet achieved in terms of getting better weight loss and maybe a little bit more durable than other tools in the lower level here. If we look to a different option in endobariatric, we are really working either in the stomach or in the bowels, and there are a lot of tools, and we will go over some of them, mostly type of switching inside the stomach or manipulating the luminals in the small bowel. Balloons we know, and there are multiple balloons in the market, but overall you are aiming less than 10% total weight loss. Durabilities is really not that much as long term, and I'll show you some numbers. And this is where we talk about different types of endobariatric. So O balloon, really, this is where the level is below 5%. Endobarrier, here a little bit more. Reshape or Bera is going more. Ellipse somehow, maybe reaching. Aspire is going to give you a little bit more than 10%. SPATS, in fact, in the recent study, SPATS 3 is giving more, up to less than 15%, but we don't know how long, and the problem still maybe we don't know. ESG is really going to 15%, which is endoscopic gastroplasty. Pose initially in the first year, but now it's not maintaining, and now we have pose 2, so that might be resulting in some more. There are different balloon in terms of weight loss and FDA approval, but again, we are aiming for 10%, less than 10% total weight loss, and the durability is very short, depends on the balloon, but mostly they will not exceed 6 months to 1 year. This is where we aim 10% of total weight loss at 6 months interval. Then they will be regaining. And if you look to multiple also, because some people will say, well, I will do different multiple balloon. But this is a big numbers, 40,000 balloons from Brazilian studies. And you can see adaptations usually a problem where they have a 2.5%. Total weight loss in this group is really 18%, but overall it is really less than 10%. At first event is very low and deflation is very low, but that's the balloon. The balloon is really durability issue, and the total weight loss issue is not there. Some people will say, okay, we'll take the first balloon, we'll put another balloon, and then we'll sew, but overall, any multiple balloons after the first one, they are not very successful. If you look, you are putting it in 43 BMI, you will end by having 37, which is almost, if you have multiple balloons, which is almost the effect of one balloon. So eventually they will regain and they will go to the same effect of the first balloon. And then after maybe multiple time, they will regain their weight. So the people thought about other options. They thought trying to replicate and simulate surgery. And the initial one is to think about similar tools to VBG, where we switchers inside the stomach, as you can see here. And that is not really giving a long-term weight loss. And then they start doing like some sort of simulations for banding, where we enter and do switcherings from inside and little bit of plication, as you can see. Again, does not maintain. 3 months, median excess weight loss 22. It's not longer anymore in practice. Then we start to replicate plication from outside and inside with all different type of procedures, including overstitch and pose. So I think if we are really talking about endogastric procedure Nowadays, we'll be talking about these two, pose and overstitch or ESG. And that's replicating. There are a lot of studies in some, but this is the most important, I think, nowadays, that's really gaining momentum in bariatric surgery, and which is the overstitch endoscopic gastroplasty. And I will show you, this is where it looks eventually on X-ray after doing it, if it's really done somehow in a tight manner. And this is a video. Can you run the video, please? This is a video that will show. Can we dim the light, please? And you go inside. Sorry, go. Run it again, please. Go inside with the over tube. You put a helix. You screw it in the wall of the stomach. You bring the stomach towards you. You throw your switchers and replicate this manner, going from anterior wall, greater curvature, posterior wall, and coming back. So that will give you, can you dim the light in this area? Because you have more videos. This is what you will have. You'll have antrum, small antrum, as you can see. And then you will have this almost tight sleeve-like. So that is, to me, is a good endo sleeve where you really have very good small lumen, more than 50% reduction of the size. Now, the question, is it going to be durable? Is it going to maintain? These are questions still. We don't answer them yet. We don't have an answer yet, but at least it's working to some extent. Till today, we have done 2,450, reaching 2,500 nowadays. And this is what you get. In 18 months, 70% excess weight loss. In fact, overall, up to 3 years now, almost from 16 to 18 total weight loss. We have revised 31 patients to sleeve, and we have also redo it in some cases, in 24 cases, for either weight regain or not failing to lose significant weight. So the good things, it's in your hand. It's a bridge. You can remove it completely. You can reverse it. You can do it sleeve after that. You can redo it. So it's a tool that gives you better weight loss. I don't know about durability on long term, but that's what happened. Most importantly, you should know it's painful. It's even sometimes more painful than sleep, but it is short-lived, 2 to 3 days, and that's what we control them with. There are some of the complications. Some of the complication here. You have perigastric collection. Usually they can be just with antibiotic, they can go. Some people require drainage, and some people blood loss in 7 cases, which represent 0.4%. Some of them require transfusion, some of them just observation. And this is where, work the video, please. This is where you see if you're doing sleeve. Can you put the video? Yes. If you do sleeve, you will have some adhesions, and this is, you can see the needles here. They penetrate with time in the wall, so it should not disturb you when you are doing sleeve. Usually, we do it combined. Just release the adhesions. Do your routine mobilization of the stomach. And then this is our switcher, as you can see, going outside in the perigastric tissues. And with time, you can see here, we go from inside and check on the, we occlude the duodenum and go with the endoscopy from inside. You see the switcher here, you just cut them and they will open. I will show you how do they open really. When you cut them, people think there will be a bridge fibrosis, it will not open, it's not true. You just cut this one and you cut even this one, you see, and the stomach will open in between, and any bridge also will open. This is if you have some anchor, if you have some needles, you can remove them in your way, and then you, after removing all whatever in your way, you do routine sleeve. There are some adhesions, as I said, you will see it. This is some X-ray of somebody after endo sleeve when you want to do, like this is, yes, they're most likely the switchers in this area, and this area has released, so you can redo it. This is what we have. Revision after primary sleeve is another option, where it is really 12 months follow-up, and that will give you a good weight loss. We have a patient who had diabetes in our group in primary. This is 57% diabetic, underwent endoscopic gastroplasty, and this is the result. 14% weight loss total, and improvement, I'll show you. Resolution, 100% in those who are newly diagnosed, so getting them early will improve their diabetes and get resolution. When they are on single oral medication, 78% resolution and 22 improvement, and so on. So this is in pediatric, and we published the first group in pediatric. Again, after 1 year and a half, there is 17% total weight loss, which is, I think, is very important, especially in this age where we are debating should we do it or so. Give them a bridge, 3-4 years or whatever, so they lose weight, and then you decide later on. This is the outcome in this group. There is no significant comorbidities post-surgery. In terms of studies that has been published in ESG, there is systematic review with multiple number of patients, and the conclusion, the average weight loss around 15% total weight loss, was being safe and effective for the first at least 2 years. Is it durable? There is a study done by Rim Sharara on 5 years, and up to 70%, they will maintain the total 10% weight loss, 10% total weight, because that's usually in surgery, we are looking for success and failure. You know, less than 50% is a failure, maybe still more than excess weight loss. When we talk about total weight loss, medication and other intervention should be giving at least 5% total weight loss. When in endobariatric, we are looking for 10% total weight loss. So if I have something to give me 10% weight loss, total weight loss, it's really successful procedure, and that's by FDA criteria, and that's the standard of care nowadays. So 70% will still maintain this in 5 years. That's good numbers, and we need more patient, more number to decide. And this is some of other studies that have published at 6 months with also, it's some sort of replicable and can be done in different centers, and they are giving the same result. Those who really, we compared it to sleep, and I think this is a mistake to position ESG as some comparative to procedures to sleep. They are completely different. Even the name being endosleep, I think is not right. So it is something that's different. It's bridging. It's not replacing sleep. It's not going to be the same group of patient. But yes, just to have it some sort of non-inferiority results, at least 15% total weight loss in endosleep and 22 in sleep. We know that it's not going. How does it work only by restriction? No, there is physiological effect. Leaving little bit of fundus maybe will delay gastric emptying and result in better weight loss. So this is another concept, because we are debating should we get the fundus or leave the fundus. There are different patterns, and what we do nowadays, we do what is square patterns. We start here, we go this side, and then we go back, and there are different patterns. Then we are maturing the patterns, reinforcement or not. Pose is another tool, and it results in 50% excess weight loss at 6 months. This is the first pose. Second pose, or pose 2, is really maybe will result in better weight loss, but that's what we have in the first pose, which is almost in this number, about less than 15%. And this is the pose 2 different by having this type of configuration, suspend and belt, some sort of techniques where you really put the belt and the suspenders between them, and that will help you to reduce the size of the stomach, but also shorten the lumen. This is a video. You can run it quickly, but in any way, run the video, please. The video here. And anyway, that's what we will get. You try to shorten the diameter and also the lumen. So
1 minute.
Okay. These are some of the, there is another still tools in the way, which is EndoZip. There are the first human trial or human study, and I think it's still premature. Maybe it will take another 5 years or so to have it, where you really switch the stomach in an automatic way rather than manual way. I don't know if it will work or not. This is another tools, endobariatric, where it is really what you call endo-obesity, where it is really forming. There is another video there, but anyway, it let you feel satiety and feeling full. And also this shuttle, so it's another tools. I will go over them. Aspire, I think, is very important because it will give you significant weight loss, and you'll be surprised they are comparing it with bypass. And this is where it is from bypass, almost close to 18% total weight loss, and bypass is 30% total weight loss. And it's durable almost 3 years, so yes, but in our culture, I don't think it will work. Somebody having gastrostomy and emptying his stomach. Botox is not working. In terms of endoluminal in the bowel, the most important nowadays, I think, is duodenal resurfacing and endobarrier. Endobarrier is coming back, and I will show you just some numbers, but the endobarrier initially has some problem with liver abscess, but they are changing the clip, so it's coming back. In terms of resurfacing, you burn the lumen here and the mucosa, and that's mostly metabolic. Anyway, duodenal resurfacing is coming, and you will see more study in this for diabetes mostly, and I think it's very effective. There are this magnet, but I don't think it will work. Will become finishing. I don't think it will work. The reason time. They are spending almost 8 hours or so in the OR, and now they changed the protocol to have laparoscopic and endoscopic. It's not going to work. This is the result of that. There is polymers, there is gelicis, and they are still. So there are a lot of work in revisional. We can do it for sleep, and this is a study. I will show you just one slide. This is, we did it after sleep, regain weight, do it, and there is almost 14% total weight loss in, which is almost 70.
Sorry, but we need to sum
Done.
up
I'm
because
concluding
there are
now.
other lectures.
So, in conclusion, endoscopic bariatric therapy is another tool in the interventional weight loss options. I think it will form a bridge between medical management and bariatric surgery. Complement bariatric surgery in some areas where you really have somebody with weight regain or somebody who did not achieve the weight they are achieving. I think it will complement your options. And future study is required to tune it more and get better results and see what is durable, what is the duration of the weight loss, but also what is the best tool. Are we supposed to reinforce or not reinforce? Which option, BOS2 or EndoSleep or ESG? These are, so it's really a fresh area, and there are a lot of things coming in the field. Thank you.
Thank you, Dr. Aid, and sorry, we have to move to the next one because I don't think there is enough time.
The next topic is going to be endoscopic treatment of bariatric complications by Dr. Christine Steyer, University of Hospital Würzburg, Germany. She's the head of he's the head of the surgical endoscopy department, and she's the head of the Interdisciplinary Obesity Center. She's a participant in the German Society of Surgery, the German Society of Visceral Surgery, International Federation of Surgical Obesity and Metabolic Diseases, and she's quite accomplished, and we're very lucky to have her here as a speaker for us today.
Thanks for having me. Thanks for the kind invitation. And I will try to rush you through this topic within 15 minutes. Let's see whether I can make it. So I divided the topic into acute postoperative complications, namely sleeve gastrectomy leaks, and long-term complications, namely damping syndrome after Roux-en-Y gastric bypass. And let's begin with the sleeve leak. And for me, it's very important to understand anatomy and physiology of this big issue of the sleeve gastrectomy. And if you look at normal physiology of the stomach and anatomy, you see the main area of pushing forward the nutrition is the Magenstraße, which is a groove in the stomach along the lesser curve. And this is exactly what you leave with sleeve gastrectomy. And what is left are two really main vectors of contraction with this, as you all know, the antrum outside pushing to the duodenum, and the other one is along this sleeve tube. And as you all know, the linchpin is the diameter at the angulus fold. If it's too tight, you will face a problem. And from that it results that the sleeve is really a high pressure system. You can measure this with impedance manometry very, very well. And this you can also depict with a contrast swallowing. You see this is a patient that swallows contrast medium, and the sleeve was completely filled with contrast. And then after that, you see that at this linchpin, at the angulus fold, part of the contrast goes further to the duodenum, but another part was pushed backwards against the lower esophagus sphincter and even further into the esophagus. So what is the genesis of sleeve leaks? And the proposed genesis is that there is a stenosis, a functional stenosis at the angulus fold, generating a lot of pressure to the upper part of the stomach, and at least resulting in a burst of the staples, and the result is a leak. So thank God, these are the German numbers. We had a high rate of leaks of 7%, but is coming down now to 1.4 to 1.5%. These are the last publications of the German registry. So we are very well with that improving. And as you all know, there are several classifications for this leaks. There is type 1, which is just a leak itself without collection around the stomach, type 2 with a collection around the stomach, and type 3, which is really an embarrassing issue because there is a connection to another organ. It's mostly towards the lung, and this is a problem because this gives us another pressure component to this bad issue. As the SASMBS said, there are acute leaks, early leaks, and late leaks. And what we did historically, and which was the approved treatment, was like a reflex. We put a stent into these leaks. But if you see what kind of radial pressure these stents produce, you can see the lowest is nearly 60 millimeters mercury, and the highest is about 220 millimeters mercury. And you can imagine no single erythrocyte will find its way into the stomach wall with this high radial pressure. And so I always call it sealing if you are lucky, but because it does not seal in all cases, but it's not healing. And the problem of migration, of course, is also a very big one. So there was developed the mega stent, the Taewong mega stent, and this was for the first time with respect to these pressure problems, because this stent overstented the whole tube of the sleeve. It comes from the esophagus all through the sleeve and ends in the duodenum, so it was neutralizing the antrum pressure. But anyways, to put a mega stent in an emergency situation is really demanding. So what then came was the publication of the working group around Barham Abu Daif at the Mayo Clinic, and they, for the first time, they said there will be a paradigm shift in managing post-surgical leaks, and appreciated this very much, and they said keep calm under pressure. So they said the management must be grounded on sound physiological principles of wound healing, and they said it's very important to optimize the pressure gradients and the gradients, and this is what is absolutely my opinion too. And they said you can't seal the leak, but you have to wait till it closes it by itself secondarily. So they concluded the pressure is on for now, endoscopic drainage leads the pack, and this is absolutely my opinion. And what I do, in contrast to the French put in pigtails, which is a passive drainage. I'll put in an endovac system, which is an active drainage system with negative pressure. And you see there is an instant pack you can buy commercially from Braun Melsungen, which comes with an Obertube, which comes with a sponge that has a kind of red-on tube on it, and which has a mechanical pump but I prefer to use an electrical pump because you just can monitor the negative pressure. And you connect the pump to the tube of the sponge. And I'll give you some examples. This was a male patient, 50-year-old, who suffered from a sleeve leak. And as you can see in the first pictures, he had stands, stand migrated, stand was changed to another stand, migrated again, change of stand, and you see it never closed. The leak itself never closed. There was always a porous and recurrency of the leakage. And what we then did is we put in a sponge on a tube. The picture you see, the first sponge picture, is without any vacuum. It's just when I pushed it in. The second is with the vacuum, and you see it really sucks very well on the stomach wall, and this is a perfect drainage for the whole system. And after changing 3 times this sponge, the leak was completely closed. And the last picture shows you a control after 2 months, and what you clearly see is the scar from the top of the stand, of the former stand. And this is the lower scar, but it's also, they also have a scar in the esophagus that really destroyed the lower esophagus sphincter, and people that had a stand really suffer hardly from reflux after that. So again, you see the sponge in position without negative pressure, and here, and you see on the right side a picture after removing one of these sponges, and you see it's a sound wound ground, and you see there's granulation tissue coming into the pores of the sponge, and that is the way the leakages heal. And if you compare this to a stand, you can see it's the absolute contrary principle. It's not pressure against the wall, but it is negative pressure. It sucks at the wall and thus really improves even the blood supply of the gastric wall. So this leads to a stepwise healing of these leaks. This was a very, very, very bad situation here. You don't look into the sleeve, but you look into the cavity, into the abscess cavity. And this is a situation where you have to put a sponge into the abscess cavity itself. It's called an extra cavity sponge. You have to tailor this. You put it to a nasogastric tube, suture it, put a guidance suture on the bottom of the sponge, and you bring it in parallel to the endoscope. And here you see how it is placed. It's the same patient. After the second change of the sponge, you see already very nicely the granulation tissue. And this is the ongoing treatment, and at least it really was closed. So this is a film, but I think I skipped it due to time. You even can make these sponges to a trilumina tube so that you can parallel feed the patient during therapy. This is a very nice option if you have patients, for example, that are in not very good clinical condition. You see here the triluminas, the trilumina nasogastric tube, and you see the sponge adapted to the gastric part of this thing. So I think understanding the physiology is very important to make a good treatment for those patients, and Endovac really was a milestone in Germany, not only in esophageal surgery, but also in the treatment of sleeve leaks. And we're going to rush on to the long-term complication after gastric bypass, which is the dumping syndrome. And you know that the outlet is enlarging over time, and this leads to a loss of restriction, or I would say obstruction, and patients lost the satiety feeling because nutrition is emptying very quickly into the alimentary lymph, and some of them even develop dumping syndrome. You can provoke this in 75% with a stress test, carbohydrate stress test, but 5% of them really have a severe problem and they need treatment, which you primarily treat with diet, of course, small meals, a lot of fiber, a lot of protein and less carbohydrates. You can add medication, but a lot of them need really intervention. And before you do this, you have to confirm the damping syndrome with tests, and the Six-Start score is an evaluated score, and of course you have to do an endoscopy, and if you're lucky, you have a continuous glucose monitoring where you can monitor the levels for 7 days. And I did in the beginning a 3D volumetry as well as a pouch emptying to also keep the early damping into the diagnosis. So I'll show you the Six-Start score. This is a scoring system that rates the symptoms of a damping, and if it's above 7, you can suggest a damping syndrome. This is an endoscopy of a patient with an outlet that enlarges to over 5 centimeters. And this is a continuous glucose measuring in a patient with 59% of hypoglycemic values over 7 days, and this really makes a problem to the patients. And don't blame the patients if they are hyperglycemic, they are hungry, they starve for carbohydrates, they need to eat. So this means patients that damp also will regain weight automatically. I also did these 3D volumetries to depict the anastomosis. And I did a pouch emptying scintigraphy, and you see before intervention, the pouch empties within 1 minute completely. They won't feel satiety, as we all know that satiety is sensed by the stomach, the first level of satiety. So this is what I wanted to show you in diagnosis, and what we do is, what Dr. Akatani already showed you, is an overstitch. This is the video for it. I refresh the mucosa with APC. It's a large anastomosis, more than 4 centimeters, even nearly 5. You go in with the endoscope. You just catch the edges of the anastomosis. And this, in the first cases, I did no running sutures. Nowadays, I do running sutures. One running suture to nearly close all the outlet up to 90% closure. I'll show you the pictures afterwards. I don't do a purse string. I really only come from one side. That ensures me that I won't close it completely. I think we can go on. And this is one of the cases you see from this large outlet. I really close it to a very, very, very small diameter. And in the beginning, everybody was surprised because they said this is a stenosis, but it's not, because there's a lot of swelling from the APC during the intervention. And it will open up to an optimal diameter from about 2 centimeters. So this is the same patient 4 weeks later, and another one, and you can see the suturing lines. This is after 3 months. This is the scintigraphy. You see that it's really slower than before the intervention. This is the CGM after the intervention. The same patient, you see it's very much better with the hypoglycemic values. This, we published the results, the first 14 patients, just rush you through that. It's atraumatic, they don't move with the CRP, the Six-Start score is coming down, they lose additional weight. And this is a new publication together with the Mayo Group. These are my 105 patients. It's the same thing. It's atraumatic, really. They don't move with the inflammation signs. They lose weight after the intervention. And most important thing is that nearly all of them are completely free of damping symptoms. I had one adverse event where a colleague tries to push in a nasogastric tube after the intervention in the night. That's the only of 105 patients. You have to know that there is always free air in the abdomen after transluminal stitches. That's normal. And to conclude, Damping syndrome is a latest complication of Roux-en-Y, and the treatment, the endoluminal treatment, is very well working with that. And nowadays, the modern approach to complications after bariatric surgery is really endoscopy. Thank you so much.
We have one question, and then that'll be it, and we'll move ahead.
Thank you, Dr. Christie. Nice talk. Questions regarding the negative suction of leak after sleeve. Do you keep the patient inpatient?
Yes.
How long?
Depends on how long the treatment is necessary. Those patients are really sick. You can't discharge them from hospital.
Because really this is not cost effective. And number two, how frequent you change the sponge itself?
How big?
No, how frequent you change it?
The frequent of changing. I'll change it twice a week,
Okay.
every
Number-
third day.
Have you ever have an event of dislodgement of the sponge inside the cavity?
No.
Okay.
No, but if the problem is what you really have to take care for is if you put it extra cavity, you really have to take care for bleedings, because this may be on the pancreas, this may be close to the spleen, so there you have really take care for. But these are mostly such big cavities, and nowadays I'll do a CT scan before to see whether there are big vessels around before I push in the sponge. I didn't do this in the beginning, but I was lucky.
The other thing regarding the narrowing the stoma, post-gastric bypass, usually the dilatation is associated with enlargement of the pouch. So by laparoscopy, we solve both things when we do the revision. But by the endoscope, you only narrow the stoma itself. But still the pouch is big, and that will not solve the whole issue. Do you agree with me or not?
This is a big point to discuss, because I don't believe in pouch size. Absolutely, the pouch is small. If you compare it, even if it's a large pouch, if you compare it to a sleeve gastrectomy, it's small. The thing is that after Roux-en-Y gastric bypass, the only obstruction is the anastomosis, and it's more about obstruction than restriction, because the nutrition has to be kept in the pouch. This is what produces satiety. If it's dumping out of the pouch, they don't feel any satiety anymore. So it's much more about obstruction. And to be honest, I never do sutures on the pouch itself, because I don't believe in this principle.
Thank you so much. Thank you, Christine. We will move for the next presentation. And it's really a pleasure to have Haris Khawaja with us today. Haris is really well known in the field, and he's running, as you know, the International Bariatric Club. He's a consultant surgeon at Chelsea Westminster Hospital, London, honorary clinical lecturer at Imperial College, London, qualified, and he has also root here in Saudi Arabia, has been grown here initially in his career. So it's really a pleasure to have you with us, Haris, and thank you for coming. And he's going to present about GERD and sleeve in the search of truth.
Thank you very much, Ayad, and thank you to the SASMBS, specifically to Professor Adnan Mufti, to Ali Al-Montasheri for this very kind invitation. I actually grew up in Saudi Arabia. My parents worked here for 27 years, so I know this country very well, and it's been a great country to live in. Now, my talk is a controversial talk. This is an area which I've had a lot of interest for many years, and I've entitled it GERD and Sleeve Gastrectomy, The Search for the Truth. Before I start, I just want to make it clear I have no conflicts of interest and no disclosures. This is my surgical case mix over the last 10 years. The majority of my practice is laparoscopic Roux-en-Y gastric bypass. So the issue with patients with GERD and sleeve gastrectomy has been controversial ever since I started doing bariatric surgery. And certainly 10 years ago, when I was a fellow at the Cleveland Clinic, it was felt that patients who have reflux never offer them a sleeve because it just makes it worse. And then more and more publications came out in the peer-reviewed literature from very well-established units, high-volume units, showing actually reflux can be improved with a sleeve gastrectomy. And this always confused me because looking at this operation, it looks very simple compared to a Roux-en-Y or to a SADI or a BPDDS. And so why is there so much variation in the literature in terms of whether this operation promotes reflux or whether it actually can be used to help treat reflux? And so this is all the literature which I read 10, 15 years ago. A lot of famous names on this slide. I'm not going to go through each slide, just to say each paper, but just to show that all these studies showed that patients who had a sleeve gastrectomy had worsening or de novo reflux after the operation. And this formed the basis as to why many years ago that patients who have reflux were often steered away from sleeve gastrectomy. And what were the mechanisms that a lot of the authors proposed? Well, by resecting the stomach and creating a narrow sleeve, there was a lack of gastric compliance. We know that the intraluminal pressure increases after sleeve gastrectomy and therefore contributes to reflux. Disruption of the angle of His and the crural sling fibers, again, during the sleeve gastrectomy, resulting in a hypotonic lower esophageal sphincter, contributes to reflux. More importantly, this technical issue of narrowing at the junction of the vertical and horizontal firings when you make the sleeve was thought to cause an increased risk of increased pressure in the sleeve and therefore reflux. In addition, you've got issues such as twisting of the sleeve or corkscrewing, leaving a large fundus, and we know that the fundus is where a lot of the parietal cells are that produce acid, leaving a hiatus hernia, and some authors would suggest that if you do a very aggressive resection of the gastric antrum, that impairs gastric emptying and therefore increases the chance of reflux. So these are all very logical explanations as to why this operation increases reflux. And when you look at the literature, you can see that a lot of the papers show that patients who had reflux before surgery, they had a sleeve gastrectomy, up to 84% still had reflux, it even can become worse. A lot of the patients who had reflux after a sleeve were often converted to Roux-en-Y bypass as a treatment if medical treatment failed. And we know that patients who have a sleeve gastrectomy, a lot of them were put on PPI treatment, some of them for life, because of the very high incidence of reflux after sleeve gastrectomy. So these were all the papers I showed you just a few minutes ago. And I think the issue is, the real truth is actually in the detail of the studies. And it's important to not just read the literature, but actually analyze and be critical of the literature. And there are problems with a lot of these studies. They're all retrospective reviews of prospective data. The assessment of reflux or GERD was made on clinical symptoms and not using the established Montreal definition of reflux, which was published in 2006. Very rarely was esophageal manometry and pH studies used to diagnose reflux. And this, again, this is to summarize the Montreal definition, but very few of the bariatric surgery literature, except the one that I'll talk about at the end, have used to define reflux. And that basically involves clinical symptoms, esophageal findings such as esophagitis and stricture, as well as extraesophageal manifestations such as chronic cough, laryngitis, asthma, and dental erosion issues. So this is actually the definition of reflux, but all those studies did not use that definition. However, we do know that in the same period of time that all these studies were being produced showing a negative effect of sleeve gastrectomy, there were lots of studies being published showing that sleeve gastrectomy can improve reflux. So this is equally confusing. A lot of big names on this slide, a lot of big studies involving over 500 patients, some of them, showing improvements in reflux after sleeve gastrectomy. how is that? What is the mechanism? Well, with the weight loss after the sleeve operation, a reduction in intra-abdominal pressure, and therefore a decreased risk of reflux, that makes sense. By doing a resection, especially of the fundus, you reduce the amount of acid being produced. There's also certainly an increase in gastric emptying after after sleeve gastrectomy. That's been shown very nicely by John Melissus's group. You're using fluoroscopy, showing that gastric emptying increases after sleeve gastrectomy. There's a reduction in gastric volume. And what is the conclusions? Well, this is a large study by Dias in 2012 showing a resolution of reflux symptoms in over 382 patients. And what they emphasize, and I think this is really important, is that this is a very technical operation. It looks very simple, but really the more sleeves I do, the more I realize how meticulous one has to be. The importance of avoiding narrowing at the incisura cannot be overstated. The importance of preventing a corkscrewing of your sleeve is really important. The importance of adequately resecting the fundus is also very important. The importance of looking for a hiatus hernia is also of key significance. And again, there's other studies showing improvement in reflux after sleeve gastrectomy. Now, the issue about hiatal hernia, so often when we're doing a gastric bypass, we think, well, it's the best operation for reflux, so if there's a small hiatus hernia, we can leave it. With sleeve gastrectomy, my approach is very different, and there's a lot of good literature showing that if you do the hiatal hernia repair at the time of sleeve, you can help further reduce the risk of reflux. And I think this is very important. If we could just play this video. This is a patient who was scheduled for can we play the video, please? No? Okay. So this is a patient due to have a Roux-en-Y bypass. The patient turned out to have severe cirrhosis, and the surgeon decided instead to do a sleeve gastrectomy. She knew that the patient had reflux, and quite rightly decided to explore the hiatus. And this is exactly what I do. So patients who either clinically have reflux or endoscopically have a hiatus hernia, if I'm going to do a sleeve, I'm quite aggressive in dissecting out the hiatus and looking for a hiatal hernia and repairing it. And so this is something that is certainly something that I would recommend, not with all sleeve patients, but those where there's something in the history or endoscopic findings or surgical findings which could suggest a hiatus hernia. And then she goes on to do the sleeve gastrectomy. But what are the problems with that literature? A lot of those studies, again, did not use the Montreal criteria for defining reflux. A lot of the patients didn't have preoperative upper GI endoscopy or pH studies. But we do know there's a lot of recent literature showing that GERD is not a contraindication to sleeve gastrectomy. The top paper is from Scott Shikora's unit in Harvard, showing improvements in reflux after sleeve gastrectomy. And the other papers are also well-established, high-impact papers showing improvements in reflux after sleeve. Whenever there's discrepancy or uncertainty about whether a procedure causes or does not cause reflux or improves it, one looks towards systematic reviews and meta-analyses. And this meta-analysis that I found from the American Journal of Surgery as to whether sleeve gastrectomy improves or makes reflux worse really hasn't really helped me in my view, because what it said is a lot of the studies in the published literature are very different in terms of their heterogeneity, their quality, the numbers of patients in the studies, that it's still an unanswered question as to whether sleeve gastrectomy increases or decreases the risk of reflux. But what is important is that all surgeons should carefully evaluate those patients prior to doing a sleeve gastrectomy. But my talk is about the search for the truth, and why do we need to know the answer to this question? The reason we need to know is that a lot of the patients who have acid reflux after sleeve gastrectomy are, as a reflex, put on PPI therapy, because that's a very effective way to control reflux. We also know that there's a lot of research showing an increased incidence of Barrett's esophagus after sleeve gastrectomy, and that's received a lot of global interest worldwide, and some surgeons have stopped doing sleeve gastrectomy because of that. Now, this study from the British Medical Journal, this is a observational cohort study of over 340,000 US veterans, and all it did is they followed those veterans who were on PPI treatment and compared them to those patients not on PPI treatment. And just to summarize, what they found is that patients on PPI treatment, long-term, had a higher death rate compared to those not. And I'm not clear exactly the mechanism, but what this goes to show is that you cannot leave patients on PPI therapy long-term for 30, 40 years and just say that there may not be any implications of that, because this study clearly shows that there is some risk associated with long-term PPI. The other issue is the issue of Barrett's esophagus after sleeve gastrectomy, first highlighted in 2017 by Alfredo Jenko. This was a study of 110 patients who had an upper GI endoscopy an average of 60 months after sleeve gastrectomy, showing a 17% incidence of non-dysplastic Barrett's. This study was largely put to the side because none of the patients had a preoperative upper GI endoscopy, and there was a very high sleeve migration rate of 70%. So it didn't receive as much impact as this study here, which was published a year ago, which shows, this is a multi-center study involving 3 units in France, 2 in Italy, high-volume sleeve gastrectomy units. And what they did is they did a preoperative endoscopy on all the 90 patients in the study. 5 years later, they did another endoscopy, and what they found was a 19% incidence of non-dysplastic Barrett's, and that is worrying. What they also found is that prior to the sleeve gastrectomy, 22% of the patients had reflux, 10% had erosive esophagitis, and 22% were on PPI treatment. 5 years after their sleeve gastrectomy, 76% of the patients had reflux symptoms, 41% of patients on endoscopy had esophagitis, and 52% of the patients were on PPI. So in this study, they showed that the patients having sleeve had worsening acid reflux. So what could be the secret to explaining the risk of reflux after sleeve gastrectomy? I really do think it's the technique. It's how tight you make your sleeve. It's whether you are very aggressive, and also how close you go to the incisura. Resecting the antrum, some surgeons would suggest to avoid resecting too much of the antrum because it's important for gastric emptying. And also, they would advise doing a thorough fundal mobilization and resecting the fundus. So just to show you that this very simple operation in terms of this illustration is, I feel, a very technical operation. And so I'd just like to conclude my talk by saying that GERD is not a contraindication to sleeve gastrectomy. I really feel it's important to do a very meticulous surgical technique with emphasis on the thorough mobilization of the fundus, avoiding the incisura at all costs, because as the previous speaker, Christine, has shown, that narrowing at the incisura contributes to not just leaks, but I feel if you don't get a leak, you'll end up with bad reflux, or you may end up with both. There are many studies to show improvement in reflux after sleeve gastrectomy, but there are still real concerns over Barrett's esophagus, or by non-dysplastic Barrett's, which has a low rate of transformation to malignancy. But still, this is a worry that we still need to do more research, and there are still concerns about long-term PPI use. And I still feel that sleeve gastrectomy is still a technically challenging operation to do it well. Thank you.
Thank you so much, Harris. We'll take a question, please. While we are waiting, Harris, what do you think this different rate of prevalence of Barrett's after sleeve, and do you think it's genetics determined, regional related, or it's really reporting differently? What's going on here, do you think?
I think that the first paper by Alfredo Jenko, the problem with that paper, which showed a 17% incidence of Barrett's at 5 years after sleeve gastrectomy, is that none of those patients had a preoperative endoscopy. So we don't know the baseline. So that's why that study, it's useful to know such a high rate of Barrett's, existed, but I'm not sure how much weight you can put on it because you don't know what the issue was before the surgery, because all these patients are morbidly obese and they're probably getting reflux as well. And a lot of the patients had silent reflux. The other issue in that study was there was some concern about how they diagnosed the Barrett's in terms of the pathological diagnosis and where the biopsies were taken. The other important thing about the Genko study is that there was a 70% migration of the sleeve into the chest, which seems extremely high, and I hope 70% of my sleeves are not migrating into the chest. Then you have the other study by Gerhard Prager. This was 10-year data, 26 patients followed up for 10 years, 14% incidence of Barrett's. But again, none of those patients had preoperative endoscopy. The only study I'm aware of that patients had preoperative endoscopy was the Yanelli study, which I put at the end, which showed that at 5 years after surgery, there was a 19% incidence. So I think the surgical technique is important. How aggressive a sleeve you do, how tight you make it is really important. In the Yanelli study, they did use the Montreal criteria for defining reflux, which is very good. They were very meticulous in terms of the pathological diagnosis. It was a multi-centered study, 3 units in France, 2 in Italy, and that's also very good to involve big units in different countries to give credibility. So I think there is still an issue with Barrett's.
Question? Yes, please.
Thank you, Harris, for excellent review and your recommendation. I remember in EFSO in London in 2017, there were a consensus regarding sleeve with hiatus hernia, and the recommendation that size of the hernia is a matter. So if it is more than 5 centimeter defect, better not to go for sleeve. Still, do you consider this in your recommendation?
I think.
So the question is about the size, because I don't know if you hear the question. Okay, about the size of the hiatal hernia?
Yeah, exactly.
If it's more than 5 centimeter?
Better not to go for sleeve. Because even if you try to repair it, doing hiatoplasty, the defect is big enough that your suture will be under tension, and maybe that it will cut off or it will be recurred. What do you think?
Yeah, I think that's a very valid point. With a hernia that size, I think there's a lot of good research coming out from Germany, from Dieter Berg, showing patients with a large hiatus hernia using a mesh is useful at the time of bariatric surgery. And which operation to do, I agree with you that I would steer more towards doing a Roux-en-Y gastric bypass than a sleeve. I'm doing much less sleeves nowadays than I did 5 years ago, and that's because I actually let patients know about this data. And the last paper I'd also like to emphasize, one of their conclusions is that they recommend that patients after sleeve gastrectomy should have an endoscopy 5 years after their sleeve, which has huge resource implications, especially in countries where the majority of bariatric surgery is being done in public health systems. So with a patient like that with a large hiatus hernia, I would go for Roux-en-Y gastric bypass.
Last 2 questions. We'll take Christine, please.
Congratulations on this excellent talk, and this supports very much that it's all about technique. It's really a technical demanding operation. It's not simply, and we have to leave behind dogma that it is an easy beginner's operation. It's really a demanding operation, and this really supports that we have to know about physiology in sleeve, how the sleeve is functioning.
Okay, Abdullah, last question.
Thank you very much. I'd like to comment on the hiatal hernia on those patients and whether to go for sleeve or bypass, which I'm going to present in my presentation. I think one of the problems of reflux disease following gastric bypass is a hiatal hernia. So I think if there is a hiatal hernia, it should be repaired. Yes, I do agree. In one condition, if you make the pouch very small and anastomosing it close to the gastroesophageal junction, reducing the acid producing cells, doing bypass, that may reduce the chance of reflux disease following gastric bypass. Thank you.
Okay. Now, I will just take a survey quick. Who will do sleeve in somebody with history of reflux, with endoscopy, maybe no evidence of severe esophagitis, maybe grade A? Who will still do sleeve? So, good number, almost. So it's not contraindication, but still you have to follow up your patient and see. Thank you so much. Thank you, Harris.
Great. Thank you.
Thank you.
I think because we are short of time, so next speaker is a well-known figure. He was our president, EFSO president in 2011-12. I would like to call for Prof. Antonio Torres to present his talk about SADI, and I think he's the best one to talk about SADI.
Okay, so good morning, everyone. First, I'd like to thank, the chairman of the organizing committee, Dr. Mahmoud Safkabad, and also, the chairman of the scientific committee, Dr. SASMBS, and of course, the president of the conference, my friend Ali Al-Montasheri. And so, and all of you guys for allowing me to be here, sharing with you this so exciting meeting and talking about a very challenging title, I would say, the art of weight loss across the borders. Okay, so this is my disclosure, and finally the disclosure is going to be related to the what we do there in our department in Madrid. We do almost 45% sleeve gastrectomy as a primary of a step plan SADIS procedure. We do 24% Roux-en-Y gastric bypass, 22 SADIS procedure, very similar numbers regarding the Roux-en-Y at the SADIS procedure, and we are increasing having more revisional procedure as the time goes by. And here you can see the summary regarding the SADIS. This we started in 2007, and between 2007 and 2009 we performed 50 procedures with with the common channel of 200 centimeters. From September 2009, we changed for the SADIS 250 because we analyzed, very closely, and the rate of reoperation was higher. And in this year, we submitted our first patient to SADIS after failed sleeve. Then now we are operating more than 400 cases with SADIS procedure, changing, the length of the common channel between 200 to 300 at present time. There is no doubt that this SADIS procedure is not a new procedure, it's a modified duodenal switch. All of us, we know that duodenal switch is the champion. A lot of numbers, information we have here showing that, the SADIS procedure is going to be, do we have a pointer here? Okay, perfect. They're going to be the champion. A lot of data, showing that here. And one of the most important papers regarding this issue is the Scandinavian study comparing Roux-en-Y and gastric bypass, showing that, in a prospective randomized trial, duodenal switch works much better than the Roux-en-Y gastric bypass, especially in those patients very heavy at the beginning of the operation with a BMI between 50 and 60. There is no doubt about that. SADIS is a modification of this duodenal switch. It's one anastomosis duodenal switch. The idea of performing SADIS was not to add a lot of restriction. This is the idea. We perform a sleeve with a bougie, 54 French bougie. We maintain the anthropyloric area, going to be essential for maintaining more, for being more physiological. And as you see here, we start doing 200 from the iliocecal bypass, the common channel, and we changed 2009 to 250, and now we also operated some patient 300. So here it is a clip, showing how we do perform our sleeve. It's a 54 bougie, but we go very close to the bougie. It doesn't matter the extent you use a 38 and you go 1 centimeter away. The problem is, is to do the sleeve properly. And then we dissect the duodenum as far away as we can, as down as we can. Our limit is not the gastroduodenal artery. Our limit is the pancreas. We go down. We don't divide the right gastric artery. And, and finally we perform a hands-on anastomosis. At the beginning, at the first case, we also do a stapler and closing the defect. Sometimes we do now, but it's going to be very nice anastomosis. We are a 2-layer Sarians. From the esophagus to the anus, 2 layers always, I know some people it's 1 layer, we are 2 layers. But here you can see there is no tension. There is a very nice final result. And here you can see the aim was to get one effective surgical technique to treat, without jeopardizing the result of the standard duodenal switch, going to be much more easier with less complication. And so at the beginning, we're talking, how getting, a longer common limb going to be the same result as the studies. We were thinking about probably, if we are increasing by 5 the length of the common channel between 450 to 250, it would not work. But we were wrong. It was working. In our first publication, when we performed this paper in August 2010, showing 1 to 3 year follow-up regarding the weight loss in our patient. It's going to be interesting. You have to be aware that in this paper, we include our patient 200 from the ileocecal valve, right? So now we are more than 160 patients followed in a long-term follow-up between 5 and 10 years, with a percentage of follow-up of 71% of our patients are follow-up. We are under the national health system. The patient doesn't have to pay for follow-up. They go to the endocrinologist surgeon very nicely. And here you can see, a very old paper showing the BPDDS, under Rudolph Douglas Hess experience, long-term, 108 months after the operation, very stable data regarding the weight loss. And here you can see overimposed our experience 7 years after operation, mimicking the same result. So what about regarding the way that this approach, the one anastomosis donor-suite, the SASMBS procedure is working in obese diabetic patients? We also present our first data in 2015, 5 years ago, and here you can see, the first cases, showing how before surgery the patient was very ill, very metabolic ill, and after 5 years, with a very nice follow-up, 25 of over 32 patients, showing a nice amelioration of the glycemic profile, but also an important improvement in the dyslipidemic profile. Sometimes we don't talk about the dyslipidemic, and what the most important thing regarding the cardiovascular risk and the risk of death of those patients. So this is our present result regarding this patient. In those patients, we follow the patient closer. Our follow-up, long-term follow-up, is 84% of all these diabetic obese patients. And here you can see the present result regarding the remission. Remission means, not having no treatment, and only you can see less than 6%. And here you can see the patient that were initially under insulin, 47% now are with remission. 89%, the patient initially under medication or oral therapy, and all patients, a mean of 72%, 5 years with remission after this surgical approach. But it's not only with the quantity, it's also the quality, how the SASMBS procedure gets this result. Here you can see comparing, the SASMBS procedure with the Roux-en-Y gastric bypass. And the key is being more physiological, maintaining the antropyloric area, avoiding, the topic we'll talk tomorrow about hypoglycemic hyperinsulinemic syndrome that we discuss tomorrow during the IBC meeting. That's, Harris asked me about that. This is the first time we saw that. If it was our endocrinologist, we didn't realize that until he observed that. It was 2 patients, one after Roux-en-Y gastric bypass and one the SASMBS procedure, 5 years after total remission, both of them, and we submitted the patient with a meal test. And here you can see how, at the end of the day, both patients got, the same nice glycemic level, but the SASMBS procedure was very stable, and the Roux-en-Y gastric bypass up and down, up and down, up and down, up and down, hyperglycemic, going to be no very nice approach. So after this observation, we decided to perform a continuous glucose monitoring 1 week with the device, comparing the patient under remission after Roux-en-Y after SASMBS. And here you can see how the patient operated by SASMBS were, again, the percentage of time that the glucose level was less than 70, it means hyperglycemic. It was worse in the Roux-en-Y compared with the SASMBS. the percentage of time that the glucose level was in the normal range, between 70 and 140, was better in the studies compared with the wrong way. And the percentage of time that the patient had a glucose level higher than 140, it means hyperglycemia was worse in the wrong way compared with the study procedure. So again, it's not the quantity, it's also the quality. And these results have been reproducing all over the world. Here you can see, the experience or the group of Utah, the Dan Cotton group, showing in a large number of patients how, we put the limit of success in getting 50% of the say weight loss. Very few patients are under this level. So after 4 years outcome after the study procedure, in this case, anastomosis was performed 300 from the ileocecal valve. But also, in other countries, in Russia, for example, Yuri Yasov doing open studies procedure, they show a very nice result in a very huge number of patients, more than 500, with a very, very low level of complications. So what you compare the standard one way donor suite with the studies procedure, we are studying 2 clinical trials. One is, I would say, the Iberican trial, compared, including 2 hospitals from Spain, one from Barcelona, one from Madrid, and the other from Portugal. But the anastomosis in trial, we couldn't convince the other team to perform the anastomosis 250. So the trial was designed to do 300 from the ileocecal valve. And here you can see the result 4 years after the operation. We are now waiting for the 5 years for the publishing the result. And here you can see regarding the body mass index and the total weight loss, it seems that the standard duodenal switch, wrong way is better than SADIS, a little better. It's more malabsorptive, more hyperabsorptive, the standard duodenal switch than the SADIS procedure. And regarding, but it's going to be very interesting that in those patients with a BMI, a higher BMI, this difference is going to be regarding total weight loss, a BMI, much better, the standard duodenal switch with the SADIS procedure. So when we analyze, the differences between BMI less than 55, more than 55, you wanted to reconsider, but probably going to be much better to think in the higher BMI to do the anastomosis 250. This is the result regarding, the hyperabsorptive level, regarding the fat malabsorption and the bile versus malabsorption. A standard DS was more hyperabsorptive than the SADIS procedure. That is no way. And so the thoughts about our analysis 4 years after the clinical property study is that probably we have to consider to decrease the length of the common channel to 250 in patients with a higher BMI. The other trial, and here you can see the result, this trial, Dr. Mario Nora show us some differences between how, the standard BPDDS, Ruangway and SADIS is working, and probably, here you can see the difference in favor of SADIS procedure. Maybe this is going to be the physiology of that, Probably, this lengthening the common channel going to be increasing the metabolic effect of this surgery. So the other trial is going to be is coming from Canada. It's going to be from Laurent Berthaud. In this case, the trial is performed anastomosis 250. And, in this performance anastomosis 250, the results are going to be much more similar regarding SADIS and DS. So this is the courtesy of the Berthaud presented in the Madrid meeting last September, showing that patient with SADIS is going to be an increased quality of life, just one minute, and some other nutritional issue in this. So I think the SADIS is going to be a very safe operation. Regarding here, you can see, our result regarding the malnutrition, showing that we have some problem and some issue regarding, the comparison between SADIS 300 and gastric bypass. There is no huge differences regarding, there are non-published data in our experience comparing some micronutrient, copper, selenium, and zinc. It means we have to operate some patients. Yes, the total rate of operation is 3.7. When the anastomosis performed 200, very high, but we do 300 no patient, and here in the middle is our ideal length of the common channel. So I think, you know, the complications are very few. When we peak all experience in this publication in SOAR 2018, here you can see the very low rate of complication. Again, when we perform, you know, the IPSO endorsement paper, very low of the complication. So I am not a procedure proselytizer. You know, what you saw during my first slide of disclosure that we operated patient doing what the patient deserved. What do we learn regarding SASMBS in the last 10 years? You know, that this modification of the duodenal switch, you know, going to make sense. The 6 key points for successful result of SASMBS may be to select properly the candidate, to prepare before surgery, to high protein diet, very important, to early preventive supplementation of vitamins and minerals, and to follow up, you know, very closely all these patients. And so here you can see my couple of last slides. You know, you can see here even at the States. Here you can see the number of VPD is very low. But if you see very closely this data, here you can see a paper we revised. You know, this is the American guys revising. The total number of VPDDS going to be increasing 63%. But when we saw, you know, the number of increasing revisional after failure sleep, the increase of VPDDS is going to be increasing 114%. So it's like Dr. Scopirano say, the hyperabsorptive procedure, I like a sport car and what you perform extremely well when pretty managers are staying for an accident. So answering, you know, the question that the scientific committee asked me regarding the border, it's going to be the standard duodenal switch, going to be like after the first, during the First World War, it's going to be this, and the SASMBS is coming to, you know, to try to put between the borders the standard duodenal switch, the old malabsorptive procedure with the new hypoabsorptive procedure. A truth passed through 3 stages. First is ridiculized, second is violently opposed, and third is for being self-evident. So I think, you know, to fight the obesity is our aim, and probably, you know, in the next meeting in United States, you know, within our 25th meeting of ISO, going to be more than welcome. Thank you so much for your kind attention.
Thank you, Prof. Antonio. I think we'll take 1 or 2 questions. Okay. Dr. Abdurrahman.
Hi, Dr. Antonio. Thank you very much for this informative lecture, and welcome in Saudi Arabia. My question, it is easy to revise in case you will need to revise the SADI. It is easy to convert it. And the second question, you have any case with regain weight?
Okay. Answering the first question is very easy, very convenient to revise a SADI procedure. It's just one anastomosis, you know. So at the beginning, as we have some fear about, you know, the anastomosis between the duodenum and the ileum. But nowadays, if we have to operate the patient in terms of some nutritional problem, we dismantle the anastomosis, just you know, putting a stapler between the anastomosis in the ileum side, and we have enough duodenal stent for performing anastomosis higher on. Okay, so this is the reason at the beginning of the operation, this procedure and this change a little bit with the standard duodenal switcher regarding to go down as far away as we can to have a cuff, a duodenal cuff, for in case of revising the patient. And regarding some weight regain or not losing weight after SASMBS, yes, we have some patients. And but I think in those patients with some of these hyperabsorptive procedure fail, I think, you know, we have to take care of not operating the patient directly. We can, but I think when the patient has to be submitted to some counseling, medication, and some other issue. Of course, you can convert in some special case. We have experienced very few cases converting the SASMBS in a standard duodenal switch, lowering the length of the common channel, right? And we have a couple of patients where the sleeve was very huge, dilated, and we would sleeve the patient. But honestly, I have to say that the results are not very good. I think for those patients that an bypass surgery procedure fails, in my opinion, in humble opinion, surgery is not the solution. Probably a brain transplantation would be the solution. Yeah.
For just last things to ask, should the SADI be a primary option, secondary option as a revisional? Who should be the patient to be offered as primary or secondary? Just in a quick answer, just for us to put it in the algorithm of our approach.
Yeah, thank you. But this is, I waited for this question. The most important thing, in my opinion, is not to offer a Roux-en-Y in a no-proper patient. It's the opposite. If you see a patient with BMI 50-something and metabolic, don't offer Roux-en-Y. This patient will fail, in almost 40%. So I have a primary SASMBS, we do now in a very heavy patient, a very metabolic patient. Primary SASMBS. If I see a patient 44 BMI, diabetic, dyslipidemic, I am not thinking in Roux-en-Y. I'm thinking in SASMBS. But 1 step, 2 step, it doesn't matter. And for revisional SASMBS after a sleeve, except GERD, stenosis, some problem in the sleeve, SASMBS is ideal. It's ideal.
Thank you so much. I appreciate it. Thank you. We'll move to the next. Thank you.
Thank you.
Thanks also for your support always to Saudi society and our really work in the region. It's always appreciated.
My
Thank
honor
you.
and pleasure to be
Thank
here,
you.
sir.
Next speakers, Mohammed Al-Na'mi, Mohammed Abu Yahya. He's one of the leaders in bariatric and also in medical education, and has been really, I think we were almost in primary school when he is also in doing bariatric surgery and surgery as well. Thank you, Dr. Na'mi.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you all for attending, and thank you for the organizing committee to give me this opportunity to present this subject, which is also a mixture of medical and surgical as an endocrine problems. Thank you. So to start with, there is publications about metabolic surgery, but really it has to be added to bariatric surgery, metabolic bariatric surgery, because most of the guidelines don't recommend until this date patients who are not obese to be operated in as a metabolic. So we have to be careful about definitions. Next slide. Which one? Al-Akhdar? Okay. I have no disclosures for this presentation. Background for this metabolic bariatric surgery include the first paper that stirred up the discussion about metabolic surgery was published by Boris and his colleagues with this alarming title, "Who would have thought of it? An operation proves to be the most effective therapy for adult onset diabetes mellitus," published in the Annals of Surgery 1995. So that alarmed surgeons, but not the medical side. Most of the endocrinologists did not believe on this paper until Philip Schauer and his colleagues published another paper in 2003 saying that it is effective against diabetes mellitus, type 2 diabetes mellitus. Until 8 years later, they convened with the medical side in a consensus meeting in Rome, and they recommended that maybe yes, maybe no, let us do research on this subject. But still there was a resistance from the endocrine and the medical community about the effectiveness of bariatric surgery on diabetes mellitus. However, Starkloff and his colleagues published the first definition of what is metabolic intestinal surgery is, but it's mainly for complications, in 1975. So if we want to define metabolic bariatric surgery, I quoted this from the sages, and today the term metabolic surgery is used to describe weight loss treatment and procedures to treat metabolic diseases, especially type 2 diabetes mellitus, to be more precise. The mechanism how this works as a metabolic procedures, there is a recent review article published explaining this, and most of those who are interested to learn more about how these surgeries work go to this reference. And basically, the sleeve or the restrictive procedures work mainly by decreasing the ghrelin. The ghrelin is a hormone discovered recently in 2001 that increases the hunger center in the hypothalamus. So people would abolish this stimulus so they don't feel much hungry. And that's the most effective part of the sleeve, plus the hindgut theory of increasing GLP-1 and PYY. The malabsorptive procedure like biliopancreatic diversion, they work in both hypotheses. The foregut hypothesis, which states that diverting food and nutrients away from the duodenum and upper jejunum will inhibit the gastroinhibitory peptides that are claimed to make the insulin resistant. So if you abolish this signal, then there will be less insulin resistance. The hindgut theory or hypothesis states that diverting food and nutrients to the lower part of the small intestine will release lots of GLP-1 and PYY, and recently another hormone, oxyntomodulin. And these can affect the insulin sensitivity and decrease the resistance. Another stimuli from all operations is regulation of autonomic nervous system through the vagal system. And once the vagal system gets stimulated, it will increase the signals to the satiety center in the hypothalamus and make the weight loss is more. Recently, the modulation of bile acids, when they are more absorbed from the terminal ileum, they can also release high GLP-1 and PYY and oxymodulin. And more recently even, they found that the circulation of the gut microbiota. The gut microbiota is a new theory that states that the location of the bacterial commensals in the GI tract migrate down. So those which used to inhabitate the duodenum and upper jejunum will go to the lower jejunum, and those on the lower jejunum, they will go down to the terminal ileum, and those bacteria that used to be in the terminal ileum will move to the colon. So by doing this, there is also a modulation that favors the glycemic control. and make the insulin more sensitive and less resistant. So most of these theories concentrate on the insulin metabolism, how we can make insulin more sensitive and less resistant. So the bariatric procedures responsible for these changes include restrictive, malabsorptive, and combined. These are the list of the restrictive procedures reported in the literature, and these are considered malabsorptive, and these are combined. One can argue that some of these might not be restrictive, like SADI, etc. When we talk about sleeve gastrectomy, you know the history when Michel Gagne, how to go back? When Michel Gagne used to work with the Laval, with his colleagues at the Laval University in Quebec City, they used to do the duodenal switch in open technique. And when he came back to Montreal, he started to do them laparoscopically. But he noticed that there are lots of difficulties and complications with the duodenal switch to do it laparoscopically. So he started to do it as 2 stages, sleeve and then duodenal switch after 1 year. But he noticed that also that he will not need to do revisional in some patients. And they have a pretty good control for diabetes remission and dyslipidemia with high rate of remission, really. But these were noticed in the first 3 to 5 years. After that, this effect will decrease significantly. It has low complication rate. However, leaks from 1 to 2% is considered problematic and really very demanding management. GERD also is another concern with the sleeve that can be considered as well. When we go to Roux-en-Y gastric bypass, it is the first performed by Aito and Mason in 1967 with this excess weight loss and good remission rate, although it is less than the sleeve at the beginning, but it is longer lasting. And it's best option for patients with proven GERD. And it has a list of complications as well to consider. When we go to laparoscopic mini gastric bypass, one anastomosis gastric bypass, as developed by Rutledge in 1997, it has a very good weight loss as well as strong metabolic effects. However, there are no abundant data compared to sleeve and Roux-en-Y, and we have to wait longer time to see their results. And they are promising results, really. When we go to biliopancreatic diversion described by Scopinaro and the biliopancreatic diversion with duodenal switch described by Hiss and his colleagues, both are considered malabsorptive, and they have very strong, really, metabolic effects with good, very high rates of remission, as you can see, and long-lasting, very long-lasting. And you can see their results from day 1 post-op, actually. However, they have major side effects that made people switch and go for another less demanding procedure as described by Dr. Torres, which is the SADI procedure. And it has almost same remission rates and long durability, but less nutritional problems if patients are well followed up, as mentioned by Dr. Torres. When we go to banding, really they are less studied regarding the glycemic control, and few data proved that it is strong metabolic procedures. Similarly, the balloon and the endoluminal sleeve. The current guidelines for metabolic bariatric surgery are found and published. First is the European guidelines on metabolic and bariatric surgery, published in 2014, followed by Robino and his colleagues when they, in 2016, published this metabolic surgery in the treatment algorithm for type 2 diabetes, followed by the American Diabetes Association recommendations in 2017 for those who are interested to see the guidelines. And they have similar recommendations, almost similar recommendations. And if I may just summarize these recommendations, patients with type 2 diabetes, if we take the two extremes, those who are non-obese, okay, no surgery, okay? Those who are obese, class 3, with BMI 40 and above, don't waste your time, really. Go and control the hemoglobin A1C. Even if it's not controlled, admit the patient for IV insulin and go to surgery. The controversy lies here in this class 2 and class 1, as mentioned by Dr. Billy, that here, don't also waste much of the time to control diabetes and wait for a long time. Preferably, you go for surgery if they are not optimized. Class 1 obese, yes, you can consider waiting and see the results of medical management. If it failed, consider surgery. So in summary, metabolic bariatric surgery emerged over the last 2 decades or so as a new concept to treat diabetes and metabolic syndrome. Different results and outcomes of metabolic and glycemic control favoring the malabsorptive or combined malabsorptive and restrictive bariatric procedure over pure restrictive procedures. Choosing the ideal bariatric metabolic procedure depends on several factors, including age of the patient. So the elderly, we don't need really to do major metabolic and like biliopancreatic procedures because it's gonna harm them. So better to go for a lower procedures like sleep, for example. Duration of the metabolic disease, if it's more than 20 years, the effect still, even with the biliopancreatic and Roux-en-Y, might not be as good as sleep, for example. Medical control is important also to consider. So those who are poorly controlled, they are recommended for surgery. Surgical expertise, availability of ancillary facilities like endocrine facilities and nutritional facilities and resources, and patient decision and willingness is another factor that we should also consider. So best outcomes of metabolic bariatric surgery are achieved with multidisciplinary interprofessional care. Questions?
Thank you so much, Dr. Muhammad. Thank you. Maybe we'll take one question or two maximum because of the time. Dr. Khalid.
Thank you, Dr. Muhammad. I think from what you explained, and it's clear, there is a difference between metabolic surgery and bariatric surgery, based on what all the evidence. So we have to know there is a metabolic surgery and bariatric surgery. Metabolic surgery based, the outcome based on how much we interfere with the GI tract. As much as a complex procedure, as much you have outcome, better outcome. So non-metabolic surgery is based on weight loss. If you weight loss, the effect like diet. So it is bariatric surgery. Some of bariatric surgery is not metabolic. Yes. Because once you weight regain, all the pathophysiology and the diseases will come back.
Like sleep,
so,
yes.
Like sleep. So we have to differentiate metabolic surgery based on other procedures. So if we want something without side effect of metabolic surgery. Malabsorptive. Malabsorptive has a lot of date complication. We have to see the other side of the midnight of metabolic surgery. We have a lot of complication up to liver failure, liver transplant. So this is what I'm like to comment about it.
Thank you, Dr. Khaled. Thank you. We will move to the next speakers. Thank you, Dr. Nami. I appreciate the talk.
Our next speaker is Dr. Amir Al-Darazi, and the topic will be bariatric surgery and cancer risk. Dr. Garazi graduated from the University of Alexandria, did a fellowship in general surgery at McMaster in Canada, currently working as a consultant surgeon in bariatric and advanced laparoscopic surgery at the Salmanaya Medical Complex, Kingdom of Bahrain.
All right, thank you very much. Thank you for the organizing committee for asking me to speak about this topic. I've been fascinated about this topic for a while, and I'm going to talk about some of the controversies regarding this. So we all know that through this talk, I'm going to talk about the relationship between obesity and cancer, and then later on I'll talk about modifying this risk by weight loss, whether intentional or not, and some of the mechanisms that come into play. So we all know that obesity is a big burden on the community. I mean, the WHO has recognized it as a disease, and currently the WHO estimates that more than 1/3 of the population of the world is actually overweight or obese. One of the dichotomies about bariatric surgery and the risk of cancer is that whenever we talk about bariatric surgery, we always, as surgeons, focus on which procedure produces the best weight loss. Metabolic effects, I mean, as highlighted by my previous speakers, but we rarely talk about the effect of bariatric surgery on reducing risk, the risk of cancer. And if we ourselves don't talk about it, how do we expect the average person to know about it? So now talking about the relationship between obesity and cancer. Obesity has been established, for a long time as a risk factor to develop a number of metabolic diseases such as diabetes, hyperlipidemia. It also has been demonstrated through a plethora of studies to affect the cardiovascular disease risk. And a few studies looked into the overall mortality based on obesity. The reason investigators focused on these things is that they presented a big economic burden, whether on the state itself or the insurers or the patients. That's why they did not look into other things into more detail. I have to emphasize that not only is there a relationship between obesity and cancer, but there has been established a relationship between obesity and pre-malignant diseases. Two of which that come into play are the larger colonic adenomas and Barrett's esophagus. I mean, a number of studies demonstrated the increased risk of Barrett's esophagus with the increasing BMI. It's only recently that we started to look into how obesity affects cancer. So the story basically of the relationship between obesity and cancer have been slowly to develop. And just to interact with the panel, I'd like to pose this question to you, Dr. Ayad and Dr. Helmut. When do you think people started talking about increased weight, increasing the weight and the risk of developing cancer? Roughly, throw a ballpark figure. Last decade, 2 decades, when do you think? 2 decades, okay, fair enough. So let me put this slide to you. Insurance companies, and that shows you the power of insurance companies in the US, have demonstrated the relationship between obesity and cancer since the 50s. So in the US, there was a big study called the Build and Hypertension Study, in which insurance companies were trying to quantify the risk. And they took the details of 5 million insured patients, and they demonstrated in 1950 that with increasing BMI, there was an increased mortality and risk of cancer. In the medical literature, the first described account came in 1979, so almost 4 decades ago. So this is just to highlight, this paper looked into the history. So again, these are the 3 studies. So this is the Build and Pressure study in 59, the first one. The second one was in 79, and then the American Cancer Society, which is low and sixth-form. We're going to talk about it. And they demonstrated nicely if you see here, at that time, they were not counting on the BMI. They were counting on the actual weight and then the risk of dying. They demonstrated that nice curve that we all got used to with the SOS study later on. So this was mimicked by the later studies. So going to the Lou study, which was the first study that was published regarding this topic. So this was by the American Cancer Society. It was a long-term prospective study of almost 3/4 men and women between 59 and 72. So this is the main finding. So they looked into a number of things. So if you see here, one of the things they looked into total mortalities, but then they subclassified it by cancer. So this is the reference. So this is the normal body weight, and then these are the percentage of increase, and these are the percentage of decrease. It's worth to note that underweight carries the same risk as developing cancer as overweight. But then more importantly, you see that as the weight increases, so does the risk of developing cancer. So the so-called dose-dependent effect. And this was done in the 70s. So later on, a number of small studies came here and there. These studies were all gathered in this nice meta-analysis by Renahan. So this comprised of 28 studies of almost 300 cancers. So these are cancers, incident cases, that included more than 133 million years. So this study basically looked into all the risk of developing cancers, the different types of cancers. So this is the odds ratio of developing a cancer for each 5 BMI increase. So this is not even 40, 50, no. This is each 5 BMI increase above normal increases the risk of developing these different types of cancers by this much. So they always classify them into men and women. And this trend will carry on later because of the different cancers in men and women and the different hormonally mediated cancers. So later comes the International Agency of Research of Cancer and evaluates all the different papers in the literature. And they come out with this, nice list of 13 13 obesity-dependent cancers. So throughout the literature, you will see obesity-dependent cancers. These are the 13 cancers. So this was initially talked about by the WHO, and later was adopted by the American Institute for Cancer Research. So then comes the Cali paper, which was something I want to talk about because people always refer to it. So this was a prospective cohort in the US of almost 1 million patients with a 16-year follow-up. So these are the diagrams that you may be familiar with, probably seen presented more or less. Again, they looked into the different cancer and the odds of developing these cancers with each 5 BMI increase. Again, divided by men and women. So this paper basically estimated that for anyone with BMI above 40, men have 52% higher risk of developing cancer than a normal weight man. Women have a 62% chance of developing cancer than an average weight woman. So basically we can see that the effect in women is actually more than in men for developing cancer. Moreover, they looked into the cancer mortality. So they estimated that obesity is responsible for 4% of the cancer deaths in men and almost 20% of the cancer deaths in women. Finally, and this is starking, I mean, they claim that if they were to find a way to make all US citizens have a BMI of below 25, this would prevent 90,000 cancer deaths per year. So now talking about bariatric surgery. We've demonstrated that there is an increased risk of developing cancer as BMI increases. So what happens when we drop the weight back to normal? Does this risk disappear or is the effect there? So one of the first studies that talked about the effect of cancer is the SOS study from Sweden. So everybody's familiar with the study. It demonstrated that there is durable weight loss with the different procedures of between 14 to 25% versus 2% in the control group. In that same study, they looked into the risk of developing cancer in these patients. So what they found is that patients undergoing bariatric surgery, when they followed them up after 10 years, their risk dropped by 0.6%. So there was a demonstrable drop in the risk of developing cancer for those patients who had surgery. So after that study, a number of studies came along. So they looked into the different types of cancer. So some of the studies looked into the uterine cancers, others focused on cancers in general, while a lot of papers looked into cancer in women. So then comes the Casgrande, I hope I'm pronouncing this right, Casgrande paper, which was a systematic review that gathered 13 studies that are institutional in nature and comprised of almost 50,000 patients. So this study basically had the famous Adams study and the Swedish study. It demonstrated that there was a drop in the risk of developing cancer with an odds ratio of 0.4, which was statistically significant for those patients who had bariatric surgery versus the control, which are obese patients. However, again, these data was all of small institutions and small regions and cannot be generalized to the public. So hence comes the latest kid on the block, which is the Wiggins study, which was published, I think, last year. So this was a systematic review of 8 population-based studies. So they only included population-based studies that looked into the entire population. And as you can see, huge number, almost 700,000 patients. So these are different studies that participated. They had different types of surgeries because some might claim that a different procedure might produce different results. So when they looked at the overall cancer incidence, so this is the incidence of all cancers, they demonstrated a drop of an odds ratio of 0.7. So as you can see, the overall cancer, it's less pronounced than what we demonstrated earlier, which was 0.4 if you remember. However, when they looked into the obesity-related cancer, which is, if you remember, the list of 13 cancers I mentioned earlier, the risk was 0.5 to develop cancer. It dropped to 0.5, which again mimics the other studies. So there is a demonstrable drop in the risk of developing cancer when we perform bariatric surgery in overall cancer and in obesity-related cancers. The final slide, I'm going to talk about the mechanisms of obesity-related carcinogenesis. So this is how carcinogenesis is proposed to happen. So the end result is reduction of apoptosis, increased cell proliferation, and increased angiogenesis and cell motility. This is mediated by a change in the sex steroids, a change in the metabolism of insulin, the chronic inflammation, and adiponectins. So metabolic surgery has been demonstrated to have an inhibitory effect on every single factor that I mentioned. So in conclusion, I've demonstrated that obesity increases individual and population risk of developing malignant diseases. The mechanisms of obesity-related increase in cancer risk appear to be multifactorial, but probably includes a combination of metabolic and endocrine effects that adversely impact inflammation, cell repair, and tumor genesis. Finally, bariatric surgery appears to be associated with a reduced incidence of cancer at a population level. The overall cancer incidence is significantly reduced, and so is the obesity-related cancer incidence. With that, thank you very much.
Thank you for finishing in time today. I will leave just for one question.
Thank you, Dr. Amr. I would like to ask you regarding, have you come across role of bariatric surgery after a patient who had been already diagnosed as cancer and they are still morbidly obese?
Sure. So the effect of bariatric surgery on cancers, I just talked about the cancer risk. However, there are many things that come into play, one of which is the survival. So there has been a number of studies that looked into the survival of obese patients versus normal weight patients that are matched in stages. So there has been a demonstrable increase in survival, cancer survival rates for those patients who lost weight. So doing the surgery, dropping their weight, even intentional weight drop may help. Moreover, a lot of studies have started to come up out about the effect of chemotherapy. So chemotherapy effect, the effect of chemotherapy is different in obese patients than non-obese patients. Finally, there has been a couple of interesting studies that looked into the telomerase length, which is a big genetic thing that goes into play. So they looked into genetically modifiable cancers. So these are cancers that are determined by genetics. And when the subset of these patients underwent surgery, bariatric surgery, the risk of developing these cancers dropped, and there was a demonstrable change in the telomerase length. So yes, even if someone is diagnosed with cancer, there may still be a role for bariatric surgery. I mean, it's still, there isn't any clear guidelines, but the evidence out there looks very promising.
Thank you very much for the talks, and I think because we are running out of time, the next talk, I think the next session we can start after 10 minutes, so short.
Okay, thank you everybody. Thank you for all the speakers. It's very, really informative session. It was a great session. We'll have a break for 10 minutes. It's now 12 minutes. We'll be back at 11 o'clock. Then we'll run the session as the same, the next session. The prayer will be Jum'ah prayer, inshallah, starting Jeddah 12:30, okay? There is a mosque in the hotel, inside the hotel. They are performing Jum'ah prayer. Lunch will be 12 o'clock, inshallah, and we'll be back after prayer around 1:15, okay? Yalla, we'll be back 11 o'clock here. 15 minutes, please.
Haddad. We can start our next session. We can start our next session.
بسم الله الرحمن الرحيم.
تست شغال ومش شغال.
بسم الله الرحمن الرحيم.
تست
واحد. بسم الله الرحمن الرحيم. اي محمد حدد راح يصير اول واحد. اي راح يكون مكان صفهم، راح يكون اول واحد.
تست
راح يروح المطار.
في هذا التغيير هنا. هذا هنا الدكتور محمد حداد. يطلع فوق حيكون اللي هو أول
كم صورة حقي أنا؟
دكتور صفوان طه ينزل تحت. أوكي. أيه.
اشتغل. بسم الله الرحمن الرحيم. اي الله يجزاك خير. 5 ثواني. بسم الله الرحمن الرحيم. Welcome everybody for the second session. There is a bit of change in the program. Dr. Muhammad Haddad, he will start. We'll talk about the use of intraoperative endoscopy decreases post-operative stenosis in laparoscopic sleeve gastrectomy. Dr. Muhammad Haddad is consultant bariatric surgeon and head of the Center of Bariatric and Metabolic Surgery, a graduate of University of Baghdad, a fellow of the American College of Surgeons, Royal College of Surgeons Ireland and Glasgow. He also holds a PhD in clinical epidemiology and biostatistics, master bariatric surgeon according to the American Surgical Review Corporation, fellow of American College of Surgeons and the Royal College of Surgeons of Glasgow and International College of Surgeons. Dr. Muhammad Haddad.
Assalamu alaikum. Sabah al khair. Good morning, everybody. Thank you again for the kind invitation, Dr. Adnan, Dr. Isam, Dr. Ali, and Dr. Mahmoud, and the Saudi Society. It's been a great pleasure to be here among you. So I've been asked to talk about the role of intraoperative endoscopy in sleeve gastrectomy, and I just tried to summarize for you within 10 minutes what we published about the role of intraoperative endoscopy in bariatric surgery. This is where I work. It's a small public hospital, around 80 beds, and we have a high volume bariatric center. We do between 600 to 700 cases per year. This is our team, and this is my colleague, Dr. Khalid, who's sitting on the bench. This is our MDT just a few weeks ago, and he's very much interested into sleeve and reflux and the complications of bariatric surgery. So the outline of my talk, I will talk about the role of intraoperative endoscopy in sleeve gastrectomy, Roux-en-Y gastric bypass, and intraoperative endoscopy on table before doing a sleeve gastrectomy in a selected population of patients. We'll try to answer this question through two publications that we had in the obesity surgery, and the last one is still not published yet, just a raw data. So the message: the use of intraoperative endoscopy may decrease the incidence of postoperative stenosis in a sleeve gastrectomy. and intraoperative endoscopy decrease postoperative complication in laparoscopic Roux-en-Y gastric bypass. I have no disclosure. I do around 1/3 of the cases Roux-en-Y gastric bypass, 10% revision, and the rest are sleeve gastrectomy. These are the only 3 operations I do. And on-table endoscopy in asymptomatic patient, I will show you this study, which we did not publish yet, might not be necessary in a selected group of population in the Middle East where I practice. So the way we do the sleeve, we do 32 French, which is the adult endoscope. We use it as a bougie. We go 4 centimeters from the pylorus. We oversew the whole staple line with 3-0 vicryl suture. We don't put drain. We don't do upper GI study. We feed the patient immediately, and we use the scope at the end to check for narrowing, stenosis, leak, and bleeding at the same time when we finish. And if there is any narrowing or the scope doesn't go through easily, we will reposition, remove the stitch, reposition the stitch, and try to make it as straight as possible. Can we run the video? So just to show you how we use the endoscope, after the dissection, after we put the first stapler, you will see that we guide ourselves with the endoscope, and I think it's useful. I've been using it for more than 2,500 cases. Here's the scope coming in. Use it as a bougie at the beginning of the procedure, and at the end of the procedure, we use it for checking for leak and stenosis. So this is the first study that we published in the obesity surgery in 2016. It's a retrospective review of cases done over 5 years, 300 sleeve gastrectomies, 97% of them were primary sleeve, and the rest were revisions. So again, if the intraoperative endoscopy or post doing the sleeve and suturing, there is a stenosis or there is narrowing or the scope is not passing easily, we will reposition the stitch or sometimes remove it. The average age was 34 years old, average BMI was 45, average weight was 120. The length of stay is between 1 and 2, and the average is 2.2 days. What we found that our clinical leak rate was 0.3%. We had 1 leak in 310 cases. We did not have a leak in primary cases. We had 1 patient who behaved 1 day after sleeve gastrectomy like a leak. We never confirmed that he had a leak, but we treated him as a leak, so we consider it as a leak. We took the patient back. We could never demonstrate the leak by upper GI study, by endoscopy, or intraoperatively, but we treated him as a leak, so we consider that as a leak. So that was 1 in a revision cases, which is 8 cases at that time. All intraoperative leak tests were negative, so we cannot explain why the patient did not have a leak the first time and why he did not have a leak even when we took him back for surgery. When we did the endoscopy for these patients, 10 of them, we found there is a narrowing or stenosis intraoperatively, and we fixed that. So 3.2% of the patient intraoperatively, the endoscope changed our management with removing the stitch or repositioning the stitch. However, our clinical stenosis rate was 0%, or at least I know some of the patients will go somewhere, but acutely, we did not have any stenosis or any twist in all these patients. So we concluded that intraoperative endoscopy might be one of the reasons to have a low stenosis rate in sleeve gastrectomy. This was the first study that we published in 2016. Before that, we published about the role of intraoperative endoscopy in Roux-en-Y gastric bypass in 2015. So the way we do the Roux-en-Y gastric bypass, we do 4 centimeter pouch, anticolic, antigastric, 100 to 150 roux limb, 30 to 50 BP limb, but later on we made the BP limb longer depending on the BMI. We do double layer hand-sewn gastrojejunostomy and a pouch of 15 to 20 centimeter. We do again intraoperative endoscopy to check for leak and stenosis, and if there is a leak, we find the area of the leak, we put sutures, we put a omental patch, sometimes we put fibrin sealant, and sometimes we put a drain. Can we run the video? So this is the intraoperative endoscopy done post Roux-en-Y gastric bypass, and you see the 2 pictures here. Can we run the video, please? So you see we put water there just to check for bubbles, and we go inside the pouch and look at the anastomosis and go back. Looking at the literature, there is one study that at that time that was published about the role of intraoperative endoscopy, looking at more than 2,000 patients. The intraoperative endoscopy at that time detected a leak in 3.2%, while the clinical leak rate in that study was 0.02. So that's one of the reasons. In our study, we did a retrospective review again for prospectively maintained database. We looked at all the cases that was done. We perform intraoperative endoscopy. I still do that on all the cases. And again, if it shows leak, then we reinforce it, and then we put a drain. And sometimes there was one case that after 6 hours, we kept repeating it, it kept leaking. It was a revision case. So in that case, we put a drain and put a G-tube. We considered as a leak, and it did happen after the surgery. This is what we did. So that's the case. We looked at 342 cases. The primary cases were 82%, 18% were revisions. The average BMI again was 48%. Our clinical leak rate was 0.88%, which 3 out of 342 patients. Again, it's 0.4 in primary cases and more in revision cases, which is expected. Intraoperatively, we found that in 6 patients, we found a leak, which we could fix. So if we consider that was a significant leak, we don't know if these patients will transform into a clinical leak at the end, but we found that 1.75 of the patients, they have a leak. We fixed it, and our clinical leak rate was decreased to 0.88. Our clinical stenosis rate that needed dilatation, 3 again, which is 0.88 in the first few months. So the positive predictive value for our intraoperative endoscopy was 75, and the negative predictive value was 99.5%. So we thought our conclusion at that time that this might be one of the reasons for having acceptable leak rate and acceptable stenosis rate in hands-on anastomosis, because we all know when you do hands-on anastomosis over a 34 evacuator tube, the incidence of stenosis is a little bit higher. The last thing I will tell you is the on-table endoscopy. This is raw data. We did not publish this yet. This was the idea of my colleague, Dr. Khalid, who said, you have the scope in the room, you do the scope in all the patients, so let's scope all these patients. So basically what we did, these patients, patients who did not have symptoms of reflux, we do GERD-Q. So if they didn't have endoscopy pre-op, and our endoscopy rate for pre-op patients is around 25 to 30%. So these 25% are not included in this group. So these patients accepted to have a sleeve, and we did not say that they cannot have a sleeve because they don't have reflux symptoms and they don't have any history of upper GI problems, peptic ulcers or any other diseases. So what we did before we start, after we dissected the greater curvature, we just scoped these patients on the table. Again, this is what I explained. So on-table endoscopy was done, and if we can run this video, please. So basically, after dissecting the greater curvature, after we did not see that intraoperatively also there is a hernia that we need, or there is no dimple in the diaphragm, we did this intraoperative endoscopy. It usually would take 1 or 2 minutes, and that's extra time, but the scope is already there. So what we found that hiatal hernia in these patients that require repair of the hiatus is 3%, and we found around 1.5% of these patients, they have grade A esophagitis. We did not find any Barrett's in these patients, and no malignancies were discovered, gastric or esophageal. So our conclusion, this is submitted for publication. In our experience, on-table endoscopy in a selected group of patients that did not have upper GI symptoms or gastroesophageal reflux disease, and their GERD-Q score did not require endoscopy, might not be necessary in our population. We went ahead and looked at all the endoscopies that were done in a 2 years period of time by our gastroenterologists in the hospital. We looked at more than 1,000 EGDs, and we looked at these patients, only the patients with a BMI more than 35. We wanted to see what's the incidence of reflux. 1/3 of the patient had reflux, 1/3 of the patient had esophagitis, and Barrett's esophagus was 0.7%. With those who has reflux is 1.5. In the UAE national, which is 98% of our population where we treat in our hospital, is only 0.16%. So maybe the incidence of Barrett's and reflux is different from the West. We don't know, but this is one of the studies. The limitation, of course, the cost is a limitation. Expertise and time is needed for intraoperative endoscopy. We cannot explain why some of the patients did not have a leak and then later on they develop a leak. It's a retrospective review with all the limitation of a retrospective studies. It's a single center study. And again, endoscopy is highly operator dependent. But when we did the study, this 520 patients, it was 2 surgeons in the room deciding that there is no hernia and there is no esophagitis. So just to increase the validity and decrease the subjectivity of the study. So in conclusion, the use of intraoperative endoscopy might be one of the reasons for low incidence of stenosis in our series. It definitely for us decreases the incidence of complication in Roux-en-Y gastric bypass. And again, in a selected group of patients, it might not be necessary if they don't have any upper GI symptoms. But considering our population is young, the average age of the patient is 34 years, and they did not have symptoms of gastroesophageal reflux disease. And again, there is 25% of the patients already had a scope, so these patients were not included in the study. And thank you very much.
Thank you, Dr. Haddad.
Any question?
Yeah, we know that you are in a hurry to catch your airplane. So any questions before he leaves? Dr. Ali. Mike.
Thank you so much, Dr. Haddad. It's more of practical question in terms of building forces in endoscopy. You know, in our region, not commonly practiced by the surgeon. So what will be your advices for us societies or in the region? What should we do to build resources? I know you're doing it, and Khalid is doing it intra-op. So, and considering that it's something to be considered preoperatively, maybe intra-op, maybe post-op, should we continue on the same level or should we go and build forces?
Thank you. So according to the study that we've done, those patients, what we do in our clinic, we do the GERD-Q score and we go in details with the patient because sometimes we translated it to Arabic and we ask the patient and we go with the patient specifically about every single point in the GERD-Q. So if they don't have any symptoms, if they don't qualify to have endoscopy, then we don't do the endoscopy. And if they choose a sleeve, it's sleeve. If they choose a bypass. Now, if the patient has symptoms, even without, if the patient has reflux, but even without endoscopy, or if the patient has significant symptoms of reflux, from the beginning we tell them Roux-en-Y gastric bypass is the choice. Don't go for a sleeve, even before we scope the patients. Those who have symptoms, we scope them from the beginning, preoperatively, so we can plan. Because you know, lots of patients ask for a sleeve, and we tell them, no, we cannot decide. You have reflux symptoms, we will scope you, and we'll see if there is any objective evidence of reflux, and we'll do pH and manometry. If all this is okay, then we can go for a sleeve. Otherwise, Roux-en-Y gastric bypass is the solution. I think we have a different incidence of Barrett's, different incidence of malignancy in our region. We are a young population. There is a difference in the food type, with the smoking, with alcohol. I think all these factors are one of the contributing factors to the incidence of Barrett's. So I think in conclusion, we have a different disease, a different entity here of disease. So I think GERD-Q is working for us. We do intraoperative pre-op endoscopy in 25% to 30%, and this is extra 3% that we discover intraoperatively.
Dr. Haddad, I have a question according to your review and your personal experience. What would be your personal practice or advice for the pre-op routine endoscopy and intra-op routine endoscopy according to what's your presentation?
Well, if you can do routine pre-op endoscopy, that's ideal. But where I practice is a public system, and if there is no indication for endoscopy, unfortunately, they don't pay for it. So we cannot do it. So if there is a justification for it, and the justification we use is the GERD-Q. So we send for insurance for approval, although it's a public hospital, but we have to get pre-authorization.
No, but if you have the resources in your hospital helping you to do that one, will you do it as a routine pre-op and intra-op?
Not both, no. You don't need both, either. One of them. Pre-op is ideal. pre-op, which is ideal.
How many of the audience will accept or will take it as a routine that's pre-op routine endoscopy, because you know it's some sort of a conflict between a lot of people, and even in the consensus they are talking about it. How many of you will do a routine pre-operative endoscopy for all bariatric patients going for surgery? A few number.
I used to do pre-op for many cases, but I couldn't find any difference, in fact. And I must also emphasize on your point regarding the incidence of Barrett's. It is very low. We can hardly see it when we used to do routine endoscopy. I think this issue should be addressed in research here in our in Middle East to compare it with the West, not only statistically, but I think we need to know the pathogenesis of why is that.
I think it's related to the alcohol consumption, related to smoking, and we are a different population, and we are a young population.
Smoking,
it's like other
higher
cancers.
incidence in our region,
It's
much more than.
Yeah, but it's a different disease.
Europe.
It's like colon cancer. We are a young population. The incidence of colon cancer here is much lower than the West, because we are a young population and different food. That's one of the reasons, I think. I don't know the answer exactly, but I think that's one of the reasons. It's a different disease. I think it's lower incidence according to the studies. There is a new publication from Qatar also showed very low incidence of Barrett's in more than 1,500 patients.
Great. Thank you very much, Dr. Haddad.
Thank you.
And have a safe trip.
Thank you very much.
We will move to the second speaker, Dr. Birey Garnio. Please excuse my French language. Dr. Birey completed his residency in general surgery from Laval University, Quebec, Canada. Then he did his fellowship in University of Montreal. He started his bariatric surgery program, and now he's a professor and director of a fellowship program in bariatric surgery, University of Montreal. His main interest is the research-wise focus on the effect of fat tissues and on the revision surgery. He will talk about interesting topic, which is bariatric surgery as a day surgery. Thank you.
Thank you very much. I would like to thank the organizing committee for this nice invitation. And they asked me to present on our experience with day care surgery. Just to have a short history of my bariatric career. You know, I did my training in Quebec City, and I had the chance to work with Dr. Marceau. He's well known to be one of the godfather with Dr. S for creating the BPD DS, and he's the one who pushed or favored the sleeve as part of the modification of Scopinaro technique. And that's for sure my first bariatric case in 1996 was a BPD DS. And after that, first laparoscopic Roux-en-Y was in 2001. And after that, starting a robotic program in 2003 with band surgery. And since many years, like everywhere in the world, sleeve came as one of the most popular primary surgery. Actually, in my center, we are 4 full-time bariatric surgeons. We do more than 1,200 cases a year. A lot of sleeve gastrectomy, and 70% of those sleeve gastrectomy are done as day surgery. I do a lot of band removal and sleeve surgery at the same time, publish a couple of papers on that. A gastric bypass is a big part of our practice as well, close to 30%, and a lot of SID as well. And like any bariatric center, a lot of miscellaneous procedure, revisional robotic surgery. Where come the fear of the ambulatory or day surgery for bariatric surgery? You need to understand where it comes from the bariatric surgery. This is a nice paper from Di Mario that was prospective, not a randomized, but a prospective data study looking at more than 2,000 patients from 1995 to 2004. And if you go back 20 years ago, you know that the mortality rate was very high. But what was the impact of disease? The nicest thing Dr. DeMaria brought to us is the fact that we could focus on several aspects of risk of complication. BMI over 50 is a risk of complication. Male gender is a risk of complication. High blood pressure, risk of pulmonary embolism as well, and age over 45. If you join those criteria together, you could create like a scale of risk or for mortality. And they found that any patient with at least 4 or 5 risk factor could have a mortality rate as high as 7.5%. That means you could understand that in our previous year of open laparoscopy surgery, the mortality rate was always a concern for any bariatric surgeon. And if you look at the amount of comorbidity, any patient with all of those 5 criteria could have a highest rate of mortality close to 16%. That's mean in our culture, in our literature, a lot of discussion about the risk of surgery. It's always a big procedure. But as you know, laparoscopy area changed a lot of things, and I think those numbers need to be challenged now. And for colorectal surgery, you know that ERAS came out, and ERAS have been developed to try to improve the quality of the care of any surgical patient. But the thing is, if you look at ERAS, they don't focus a lot on death. We look on what is the reason why patients stay in hospital. Most of the reason is not because the patient will die, it's because patient have pain, patient have nausea, patient complain of weakness, or we still have problem with organization to send the patient home. Sorry, the slide is in French, but it's just to show you that in 2008, the Ministry of Health in the province of Quebec allow my hospital, Sacré-Cœur Hospital, to perform daycare surgery. And for us, as a chief of the surgery, that was very exciting to be able to do surgery outside of our hospital in a private center. But you know, as a bariatric surgeon, how could we figure out to do daycare surgery? Because mostly the big case need hospitalization, some patients need ICU, and that's mean that opportunity kick us to think about what we could do to improve the surgical care of the patient. In 2016, we published our first paper on 320 patients who had day surgery. We did it from August 2012 to February 2015. During that period of time, we did close to 1,000 sleeve gastrectomy in our service, but 1/3 have been done in the ambulatory center. That's for sure. We pay a lot of attention on our inclusion criteria. We decide already at the beginning to offer the surgery on a patient younger than 50 years old, BMI under 50, ASS score of 1 or 2, and the DeMaria score, we accept class A and B. We avoid any class C patient. And you could imagine that the exclusion criteria is the reverse. If we look at the characteristic of our data, regular patient, mean age 38 years old, a BMI of 44, and if you look at the chart, half of them have comorbidity, even sleep apnea. During the pre-op phase, you know, we applied our criteria for selecting the patient for the ambulatory surgery. We asked all of our patients to be on a strong diet for 2 weeks, plus the nutritional course, plus counseling with our team. For the surgical phase, regular medication, nothing different from any center. For general anesthesia, rocuronium, propofol, the regular narcotic and antiemetics. For the surgical protocol, heparin before the surgery, compressors, stockings, and that's for sure. You need an experienced surgeon for that. We paid a lot of attention in the PACU because, as you could imagine, being in hospital is easy. The patient is in a PACU for 2 hours, and after that you transfer the patient to the regular floor with nurses who could take care of the patient. And then in a daycare surgery center, it's totally different. You send the patient directly home, okay? That means no nurses. Yes, any patient needs somebody with them to at least to drive them back home. But we are very severe about the criteria to make sure that the patient is awake, don't have any pain, have a full control of the nausea to make sure that he's able to go home. And our regular medication for a patient going home, nothing special. All of our patients receive 3 weeks of enoxaparin, regular hydromorphine for painkiller, and regular medication to control the nausea. And all of our patients receive a phone call 24 hours after the surgery to make sure that they're feeling good. This is the raw data for our first experience at the beginning. The length of stay was 8.1 hours. 6 patients has been transferred directly to the hospital for safety concern. Our biggest issue at the beginning was the readmission rate. As you see here, our readmission rate was 8.5. If you look at the reason why the patient come back, mostly nausea, abdominal pain. If you look at the gastric leak, 2 patients for a total of 0.6%. And if you look at the type of complication, no leaks had to come back to the OR. That's mean percutaneous drainage or stent has been the treatment for those patients. Only 1 patient required another surgery, and that was for hematoma. We never had strong bleeding after ambulatory surgery, but when the patient come back with abdominal pain, you do the CT scan, you found a hematoma. Sometimes you have a fear of having active bleeding, and you brought back those patients to the OR. That was our first study. 2 years after that, I did another research for another topic on neuromuscular block, and we did at the same center. That's mean ambulatory surgery, but that was a prospective study at that time, and no revisional surgery. That means no patient with a previous band surgery for this study. Same type of demographic, 39 years old, mean for the age of the patient, BMI 44. And if you look at the comorbidity, we allow more patients with sleep apnea because we don't have the fear of sending a patient home with sleep apnea if the patient is on his device for the sleep apnea treatment, but he needs to be controlled. We found in our study that most of our patients have been not in a deep neuromuscular block, and that was a consequence during the surgery because we found that any unattended movement, rise in the abdominal pressure was done in the group with moderate deep neuromuscular block. That was not a big surprise, but expected. And that's for sure. With a patient in a deep neuromuscular block, the surgery is easier, faster, more safer. But for the pain or for the nausea, we didn't find any difference between 2 groups. But that's for sure, all the patient who has been operated not on deep neuromuscular block complain of more pain at the recovery room, need more morphine, more narcotic, and could be more dangerous for a patient if you want to send those patients home. And one of our surprise, young patients complain more about nausea. Women complain more about nausea. And if you look at any surgical program, who is the last patient of the day? It's always the youngest women, okay? But if you do daycare surgery, ambulatory surgery, doesn't make sense because the youngest one will complain and will receive more medication to control the nausea. This is the important slide. If you look, we are 3 years later. Length of stay, 7.25 hours. Overnight hospitalization, 0. No patient have been readmitted. The reason is, after many years of ambulatory surgery, all of our team pay attention to control or to give the right amount of medication to control the pain, to control the nausea, to have the perfect technique to make sure that the patient have a good evolution. On top of that, can you add more side treatment? Yeah, probably all of you inject medication to control the skin pain. Honestly, we don't find a huge impact even if you inject the Marcaine, except if you give a long action medication. Most of us just give the regular medication, but honestly, there's no proof to improve the surgical outcome of the patient. Probably the next step for pain control will be the preoperative transverse abdominal plane. We call it the TAP. And we use the same medication, but with the long action medication. And that's for sure. If you use this kind of medication on your patient, you will use less hydromorphine, less opioid medication. And if you use less dose medication, less chance of having respiratory complication. In conclusion, ambulatory bariatric surgery is safe and secure in a selected patient. Deep neuromuscular block prevent inappropriate abdominal movement. Patients with less neuromuscular block require more pain relief medication in a recovery room. Young women require more anti-nausea drug. You need to think about it if you start an ambulatory program. And probably the future to control the pain at home will be the pre-op TAP to decrease the amount of opioid. Thank you very much.
Thank you. A question.
I am happy to see your presentation. I do all the cases as day case, including the revision.
Now, actually...
But the one thing that I noticed, we do TAP on all our patients. Every patient receives a TAP and Marcaine TAP, in fact. And we found that we don't use narcotics. Opioid-free helps, but we end up with basically the same rate of nausea and vomiting, which I'm not concerned about. The only problem we had is making sure that the patient did not bleed. So we decided at the end that every patient, after 2 or 3 hours, has to be up and about and walking. If they feel groggy, somnolent, we do a CBC, we find there's a drop, then we worry and watch them. Either we give them blood or we take them back to the OR if we see the continuous trend in dropping of hemoglobin. That was the only thing that was concerning for me in sending patients home, is I don't want somebody going home and bleeding. Otherwise, I think nausea and vomiting at 6 or 7 hours improves a lot, and you don't have to feed them a lot the first day. I think that's the main issue. Don't give them a lot of liquids. Give them enough what they can tolerate without specifying the amount. But the TAP lock made a hell of a difference. We adopt ERAS and TAP lock, and that was helpful for us. The entire team speaks the same language.
Yeah, as you know, our mentality of giving medication after surgery, most of the surgeons don't pay attention because they just prescribe hydromorphine, blah, 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 and they don't care, okay? Because the patient will be transferred to the regular floor. But if you pay a lot of attention to all the medication to give to your patient, the amount of medication, the time frame after the surgery, you will be surprised how awake are your patient. Honestly, 3 hours after the sleeve, because I discharged by myself my own patient, you go back to the PACU, patient is awake, walking, having a sip of water, going to the toilet, going back, sitting on the side of the bed, and you realize that, okay, my patient is ready to go home. But you need to be very careful about all the medications during all the pre-op set. Yeah.
Dr. Ail?
Thank you so much, Garno, for this excellent lecture. And I think we should be moving forward to more of ambulatory care in our cases. Now, in terms of your next day, same night, the few days post-op, do you bring them back? Do you rehydrate them? Do you do what is special, more details in your protocol, very in the first 24, 48 hours?
You know, we realized that our patient, when they came back, as you saw on our first paper, our rate of readmission was 8%, okay? The commonest problem was nausea and pain all the time, okay? And we realized as well that the pre-op preparation is very important, okay? We told all of our patients that, yeah, nausea is the most common problem. It's not a big thing. We're going to control it with medication, okay? They always have a phone number where they could call, okay? And we ask all of our patients to stay in maximum of 40 kilometers from the hospital, okay? If they live far away, they need to have a hotel room nearby the hospital, just to make sure and for safety reason. And like I said, 24 hours after the surgery, they receive a phone call from our team and the nurse.
Okay, last question.
Thank you. Does this 8.5% return to hospital and 0% 3 years later include visits to the ER who were not admitted to the hospital?
You know, I just want to remind, on our first paper, on over 300 patients, 6 patients have been transferred directly from the ambulatory center to the hospital because we were not feeling safe to send the patient home, okay? All of the rest of the patients have been transferred or discharged to home, but we had 8.5 patients who came back. Some patients came back 1 day, 2 days, or maybe 5 days after the surgery.
Now the question is, does that include patients who came to the ER, took some fluid, took some painkillers, and went home?
Yeah, exactly.
They were not, does that include them? Is part of those 8.5?
Yeah, exactly. When I said 8.5% came back, they came back to the emergency.
And not admitted?
Not admitted. No, yeah, some patients have been admitted, yeah, because we had 2 leaks. Yeah, 1 patient had a laparoscopy for bleeding. 2 patients had a leak, okay? That's for sure. Those 2 patients has been admitted, okay? Few patients stay for a few days in hospital for fluid, okay?
Yeah, and 3 years later, not a single patient even came to the ER?
No.
Thank you very much, Dr. Pierre, because of time shortage for prayer.
Thank you very much.
It's a nice presentation. The next speaker is Dr. Abdullah Zahrani. He's a consultant upper GI and bariatric surgeon. He's one of the founder of SASMBS. Has been an active surgeon in the field of the bariatric surgery since 2000. Obtained an upper GI and bariatric surgery fellowship in 2003. He is a member in several national and international society. He is now the director of upper GI and bariatric surgery in Center of Riyadh, Prince Sultan Military Medical City.
Thank you very much. Good morning all, and thank you for attending. And I'd like to thank the organizing committee for giving me the honor to be with you. Again, I'm revisiting the subject, paying or shedding the light on the association between GERD and other bariatric surgical procedures. As we all know, obesity is strongly associated with GERD, but ironically, bariatric surgery associated with GERD as well. So what are we missing? Is obesity the only cause of gastroesophageal reflux disease, or are we doing or missing anything that could contribute to the GERD following bariatric surgery? I don't know, I'm not... Okay. GERD is defined as a condition developed when the reflux of the stomach content causes troublesome symptoms and or complication. And that could be typical or atypical and could present in what we call it gastroesophageal reflux disease, could present in what we call it NERD, non-erosive reflux disease, and could present in what we call it silent gastroesophageal reflux disease. The prevalence of gastroesophageal reflux disease is estimated to be around 20% in the general population and goes up to 28% in the Saudi population. Obesity is known factor for gastroesophageal reflux disease, and you find most of those patients subjected or presented to bariatric surgery are having around 50 to 70% are having GERD disease. Hiatal hernia is relatively common, occurring in around 10% of the general population and goes up to 40% in the morbidly obese patients. Central obesity was associated with higher risk of Barrett esophagus, and the association persisted after adjustment of the BMI. Sindro et al. From University of Chile studied in 2001 reported that 79% of their morbidly obese patients had heartburn, 66 had rigor symptoms, and as you could see, majority of the patients are having one form of gastroesophageal reflux disease. NERD is estimated to be around 50 to 70% of all patients, and silent GERD could be as 12 to 25% of those patients presented to for obesity surgery. Shower et al. Reported that in patients with severe esophagitis subjected to Roux-en-Y gastric bypass, the incidence of GERD was from 50 to 100%. And therefore, that clearly addressed the need for further studies looking into the true incidence of gastroesophageal reflux disease, how do they present, and how can we investigate them preoperatively. The obesity, GERD, and Barrett esophagus are known associations, and it could clearly be seen that presence of adipose tissue is an independent risk factor for Barrett esophagus. These factors are including insulin and insulin IGF, adipokines through metabolic control, inflammation, tissue repair, and immune modulation, ghrelin, Helicobacter pylori, hiatal hernia, intra-abdominal pressure, lower esophageal sphincter relaxation, and transient lower esophageal sphincter pressure. As you could see, obesity is an active disease with active inflammation. So one could imagine what harm it could cause. The weight reduction is known to be one of the remedy of those patients having reflux disease with bariatric surgery. And if you could see, has been presented today, laparoscopy, sleeve gastrectomy, and GERD, there has been heterogeneous reports of range of reflux disease from 6 to 60% of patients having reflux disease following sleeve gastrectomy. Several factors has been blamed, and one of the commonest is the hiatal hernia, and several recommendation has been posted describing the incidence of hiatal hernia in bariatric surgery patients, and what could be the incidence of reflux disease in those patients who didn't have hernia repair, whether it is a persistence of symptoms or a de novo disease. And in 2012, the international sleeve gastrectomy experts reported that 80% of them recommended an aggressive identification of the hiatal hernia, and 82 recommended hiatal hernia repair should be done prior to bariatric surgery, in particular sleeve gastrectomy. Intragastric pressure, we all know intragastric pressure does increase following the sleeve gastrectomy, but Jack Embens noticed after some time the pressure decreases. So could it be a main contributor of reflux disease following sleeve gastrectomy, or are we missing something else? reduce acid production. Theoretically, once we remove more than 80% of the stomach, you would expect the acid production to be reduced. So that carries a theoretical advantage of reducing the gastroesophageal reflux disease following sleeve gastrectomy. But in the contrary, we are having patients having high incidence of reflux disease. So where is the problem? Reduce weight. As we have stated earlier, obesity is associated with high incidence of reflux disease. So if we treat obesity, should we treat GERD? And are there any other factor we are missing? Gastric emptying. There are several studies that have reported improvement in gastric emptying, and that would theoretically reduce the incidence of gastroesophageal reflux disease. The lower esophageal sphincter pressure. Several studies has been reported, and I'm sure you have gone through these, of reduced lower esophageal sphincter pressure in those patients who had sleeve gastrectomy. But there are other studies that have reported an increase in the lower esophageal sphincter following sleeve gastrectomy. And if you could look into this graph, once you get closer to the esophagus, the sling fibers are disturbed, and that would lead to the increase in the damage of the lower esophageal sphincter. And if you go far away, the sling will be reduced, but you may end up leaving a bigger fundus. So how far you go from the gastroesophageal junction? If you go near or very close in the gastroesophageal junction, the sling fiber will be disturbed, and that will affect the lower esophageal sphincter. And if you go too far, leaving the fundus behind, that would induce a gastroesophageal reflux disease too. The proximal gastric pouch, as we have stated earlier, that if you leave a proximal gastric pouch, that would be a relatively reduced pressure zone. Fluid will accumulate there and would be expected to reflux into the esophagus. Mid-gastric narrowing. If the stomach is narrowed at mid, you would expect relatively increase in the pressure, and that would lead to stasis, and that definitely would enhance or influence gastroesophageal reflux disease. Proximal gastric migration. Again, that's part of the hiatal hernia. Many patients, the hiatal hernia could be small, could be missed, and whenever you dissect the stomach, creating a gastric sleeve, all the attachments are released, and that would eventually lead to the proximal migration of the proximal stomach. Sleeve gastrectomy and shape of different techniques. I want you to pay attention to this slide. As you could see in the shape of the sleeve, dumbbell, lower pouch, tubular, upper pouch. The incidence of de novo reflux disease was the lowest in those patients who are having lower pouch, and highest in those patients who are having the tubular type or upper pouch, and the excess weight loss goes somehow parallel with this, with lower pouch carrying the best excess weight loss as compared to the tubular type. And the conclusion was surgeon with the highest rate of worsening reflux had similar operative experience and complication rate than those with the lowest, and further assessment were recommended for this skill and different techniques. And one could see that the difference in the outcome and the incidence of reflux disease following bariatric surgery seems to be related to different techniques and standards we are practicing. A range of 6 to 60% doesn't seem to be solely associated to the procedure itself, but rather to the technique. The weight loss should have an influence, a positive influence on gastroesophageal reflux disease. So why are we having the GERD? Is it unsolved primary cause? Is it a poor technique? Is the shape or the function of the stomach is affected, leading to higher intracranial pressure, intragastric pressure, or is it a patient factor? Do we need further preoperative, operative, and post-operative assessment for those patients? The gastric bypass has been recognized as the most effective bariatric procedure for GERD, whether done as a primary procedure or done as a revisional procedure. But besides this, there has been reports on Roux-en-Y gastric bypass and the patient requiring acid-reducing medication up to 19% of patients, and on those patients who are having a pre-operative GERD symptom, 43% of them remain symptomatic. The study from Sweden by Dag Homburg, studying 2,454 patients, showed again, a striking result. Reflux symptoms remain and recurred in 55.8% of the patients, and therefore the prevalence of reflux disease was around 50% at 10 years after surgery. For those patients who were symptom-free preoperatively, 15 patients had reflux recurrence in the second year and 8 in the second to the fifth year. And overall, with 5 years of gastric bypass, 67% of them had reflux requiring long-term anti-reflux medication. The several factors has been attributed to the GERD following gastric bypass, which are hiatal hernia, migration of the gastric pouch, big gastric pouch, narrow pouch outlet, candy-cane syndrome, obstructed alimentary limb, and weight loss failure. The mini gastric bypass is as well being studied, and gastroesophageal reflux disease was found to be around 11 to 22%. 88% of them are de novo, and 75% of them showed erosive esophagitis at upper GI endoscopy. De novo findings suggestive of bile reflux was found in 36 to 39.5% of the patients, and bile reflux has been and always fear with relation of the esophageal and gastric cancer, though no study has been proven yet, but it has been an inherited fear by the surgeon. Now, what are the preoperative managements of those patients who are having GERD? Should we recommend the gastric bypass as the best option? I think the answer is yes, though some of you may be conservative, but gastric bypass seems theoretically to produce the best effect on gastroesophageal reflux disease. Sleeve gastrectomy, paying attention to all the risk factors, standardizing your technique, creating a tubular stomach, no remained or wide gastric fundus, repair hiatal hernia, wide incisura, hopefully would reduce the instance of gastroesophageal reflux disease. Combined sleeve and anti-reflux procedure, sleeve gastrectomy combined with Rossetti or the Nissen sleeve, anterior fundoplication, phrenic esophagipexy, sleeve gastrectomy combined with simplified hill repair has been reported and seems to be promising, but it's difficult to evaluate as of now. I'll just pass over this slide for sake of time. These are description of these combined procedures. Both sleeve gastrectomy GERD managements could be managed either medically or surgically, and we have to pay attention to medical treatment. I think it is unfair, and I personally consider it unethical to keep the patient on PPI for long or lifelong, because PPIs only mask the symptom, it switch off the alarm. So you could give a course of treatment, up to 3 courses of treatment, each extending 6 to 8 weeks. If it worked, well and God. If not, you have to look into the cause of this reflux disease and correct it surgically. BPI does not treat gastroesophageal reflux disease. It only reduces acid. So the standard option would be conversion to a gastric bypass. Re-sleeve gastrectomy again, take it with caution. It has been described, and again, please follow the algorithm of, if you think there is a reason to explain gastroesophageal reflux disease following sleeve gastrectomy, yes, go and address this. But if there is nothing to explain gastroesophageal reflux disease following sleeve gastrectomy, I would suggest converting it to a gastric bypass.
Dr. Abdullah, we are running out of time,
Yeah,
so if you can.
I'm done. Link system is non-cardiopexy and Mark-Pilsey type 4 are an option. For those patients with the gastric bypass, the best option for them would be revision of the bypass, repairing the hiatal hernia, downsizing the gastric pouch, revising the gastrojejunostomy, lengthening the row limb, or conversion to Pilsey Mark type 4 fundoplication, partial or total fundoplication, health repair, and the link system or Streeter procedure. And for those patients, both mini gastric bypass, the best is converting them to a gastric bypass. In conclusion, rigorous preoperative assessment of GERD is recommended in order to plan the operative intervention and post-operative care plan. Attention should be paid to all technical risk factors that predispose post-bariatric surgery patient to GERD, and proper selection of the bariatric procedure in obesity and GERD patients. Post-operative care should be paid to routine versus selective post-operative surveillance of GERD post-bariatric surgery, and post-bariatric surgery patient with GERD should be closely monitored. Medical treatment should be discouraged except for short period of time, 6 to 8 weeks, for 2 to 3 courses, and if the GERD is intractable or requiring continuous medical treatment, surgery should be considered. Thank you.
Thank you very much, Dr. Abdullah. I think because of time, we'll not take any question, and we'll move to the next speaker. The next speaker is Dr. Ali Al-Bahrawi. He is going to talk about Dr. Muhammad Abu Khatir. He will talk about the technical tricks of robotic bariatric surgery. He's a consultant, upper GI and bariatric surgeon in King Fahad Medical City in Riyadh.
Bismillah ar-Rahman ar-Rahim. Thank you. It's an honor to be here. Thank you for the organizing committee. Today I will speak about, where is my slides, please? Yes, I will speak about some technical trick robotic bariatric surgery. Sorry. Sorry. Yes. Sorry. Which one? Thank you. As we know, always between surgeon and patient, there is things. In open surgery, we have the open instruments, and in laparoscopic surgery, we have the laparoscopic sets. But in robotic bariatric surgery, there's a computer between the surgeon and patient. There's a lot of power. People talk about robotic, either surgeon or others speak, it's a danger, stupid, too big, too long to operate, too long to set up and dock, difficult to teach. There's a lot of things. It's a toy. But what literature say about robotic bariatric surgery is sorry, back. As literature say, it's a better vision, better range of motion, better ergonomics, and short hospital stay, revisional surgery. What's the learning curve? I will explain in the coming slide what literature say about it. What are the history of bariatric surgery? The first bariatric surgery was done in Belgium by Hembens, 1998. By 2003, there was 11 surgeons in US doing robotic bariatric surgery. Initial implementation by 6 surgeons utilized the hybrid technique. They just do only the anastomosis part, and the other part they completed by laparoscope. Bariatric surgery incorporate the robotic surgical system into their surgical armamentation, and with advantage of hand sewing techniques and improved outcomes in 2000. So as FDA approved. The first robotic Roxanne Y was done in the same year also, and also the biomechanical diversions. Why we do robotic bariatric surgery? With the rise of bariatric surgery and obesity all over the world, in special high BMI, patient with high BMI and limited space with thick abdominal wall, also in revisional bariatric surgery, maybe it's helpful. and managing the complication and reoperation of bariatric surgery. What also important in the robotic bariatric, the vision. As we know, the 3D camera in console, ergonomics. You know, the surgeon will be relaxed, sitting in chair. He will not have fatigue, especially in the muscle, elbow, and also in the shoulder. Retraction is really amazing during robotic surgery. Robotics also demand unnecessary movement and tremor. In super obesity, especially high BMI, above 60, we find a lot different. If patients have thick abdominal wall, really you struggle during laparoscopic, but in robotic you didn't have this feeling at all. Significant also visceral fat, and also robotic platform important and more durable instrument. Additional arm in the recent, version of robotic surgery of robot. Also, the very important point that hand sewing anastomosis really in robot, it has different angle. As you know, the needle holder has different angles, not like in laparoscopic surgery. You will have some difficulty if you do your anastomosis, especially the gastrogenostomy, with hand sewing anastomosis. Also, the last generation, they have more arms, they have long arms, and this really helpful in doing your surgery easier. Also, long stable line. Now I'll speak about three important procedures, the sleeve gastrectomy. Usually, in our center, we start in sleeve gastrectomy. Why we start sleeve gastrectomy? Just to train the staffs and nurses and your scrub nurse, your assistants. To get used, if you're just starting in robotic surgery, you start with a simple procedure. What points we have there? We have a long stable line. The people who do over sewing of the stable line, maybe the robot will help in sewing that part. Also, dissecting the hiatal. If you have hiatal hernia, for repair, easier by the robot. And also mobilization of the fundus. What literature say about robotic sleeve gastrectomy? There's two studies by Dementia and ILO et al. There is no difference in case of morbidities or complications, but some other studies show some different, especially in Romer study. They found that the leak rate is less in around 134 robotic sleeve gastrectomy. The leak rate was compared with laparoscopic, it was 0.7 versus 1.2. I don't know about this study, but still there is studies supporting that the leak rate is less. I have to present it. I will show you my experience, limited experience. I started less than 1 year in King Fahd Medical City. By the end of 2018, I performed around 62 patients sleeve gastrectomy. Male ratio 33 male, and age was from 21 to 61. The BMI was, I chose less BMI in the beginning of this, the service, just not to have, just let the team use with and also for training of the staff and everybody. It was the BMI from 41 to 52, and our operative time in the beginning was long, but in the end, really, we have a shorter operative time. It reached up to 63 minutes. Length of stay was 2.6. The total, the complication, we didn't have any complications, especially thrombosis or leak or bleeding. We have to convert one patient from robotic to sleeve because we didn't have, there was some problem in sterilization of one of the instruments, but not due to, work. I will show some technical point how you fix your ports. We usually only two arms. The optical trocar as usual, but we go around 18 centimeters from the sternum. We put the camera port as usual. After we do insufflation by pneumoperitoneum, I apply two robotic arm 8 millimeter and one for assistant robot, assistant port that we use for a stapler because our robot was used. The old version we didn't have approved FDA approved stapler. Here is the setting, the top of the patient, the robot. This is outside sitting. The surgeon will be sitting here, the nurse scrub here, and the assistant here, and the anesthetist from the top with the robot. I will just pass this because of the time. And we started around 3 weeks ago, we started the robotic Roxanne gastric bypass. We performed around 4 cases, 3 straightforward Roxanne and 1 revisional from sleeve. Sorry. sorry. So we start Roxanne. Why we did Roxanne considered a gold standard surgical procedure for morbid obesity? Robotic surgery is currently considered as an attractive technology that could help perform Roxanne gastric bypass. Really, it attracted me. This study attracted me. It's an old study in 2008, but the result of this study done by Sender in US, the anastomosis leak was he performed around 356. Standard laparoscopic procedure, Roxanne Y, and robotic was 249. The leak was 0 in this study. And in laparoscopic one was 1.7. It was considerable. And I think the people who is doing hand sewing, maybe it can a rule for reducing leak rate. Here, a nice study comparing robotic and laparoscopic, the number of patients more than 3,000. And here, three of the study shows hospital stay reduced in 3 studies. In operative time, 4 of the study shows that less operative time in robotic Roxanne gastric bypass. The average leak rate in all the study was 0.9 in robotic part and 1.6 in laparoscopic one. Learning curve in laparoscopic Roxanne gastric bypass around 75 to 100. Robotic is different. If the surgeon is well trained to do laparoscopic one, up to 14 cases in order to achieve mastery. How I do the robotic gastric bypass? Here I increase one robotic arm. I use 3 arms, 2 in the left side, 1 on the right side, plus the optical trocar and assistant port as usual between these 2 ports. And I use Natison river retractor also. I will show this quick video. So can you run the video, please? Please, can you run the video? Okay. One of the advantage of robotic, you see how manipulating the bowel by the grasp, you are doing by 2 fingers only calculating the bowel. You remember when you do it laparoscope, you have your shoulder will be hang. You have to change the position. You have to struggle. You are worried about the assistant will hold the bowel for you. If he is not not senior assistant, maybe he will tear the bowel. Here, after we create the pouch, we do the gastrogynostomy. I do 50% of my cases hand sewing, so especially in revisional surgery, I don't do stapler anastomosis. In robotic, I do all them hand sewing, especially the gastrogynostomy. See how you control the needle if you enter, which you cannot do it by laparoscope. Sure, you can do everything by laparoscope, but there's some angles. Really, it's difficult to do it by. You will struggle. You will do it, but you will struggle. You have to be trained to use the left hand and the right hand together in laparoscope. But in robotic, it's not the scenario. You can control. What I do in robotic, I just take the loops completely and do the posterior part, the first layer of posterior part. I do it continuously with Vicryl suture 2O. Then I run it completely. Here we have too much power. In the beginning, if you start training in the robotic surgery, you have to be careful. You depend on your vision to stretch the stitch, not your power. There is no power. You didn't need too much power. The power is too much in the robot. So you depend on the vision. If you apply too much power, you will cut the sutures. So in the beginning, maybe when you start the practice, you will have this problem. So after I do the posterior layer, I open I cut the biliary limb, I separate the biliary limb. Then I will continue the anastomosis. I'll apply GIA here, white GI. Then I will continue the anastomosis. I will do the posterior layer. Sorry, it's about to finish. So I open the stomach and the small bowel, and I do the second posterior layer. Here you control it, and the robot also there's harmonic is like the usual harmonic. Also there is version for robotic. It's also now I do the second layer. I start in out, out in out. Then I do the posterior part. Then I do a third and fourth layer. This is the second posterior layer. Then the anterior, the first anterior layer, I do take them continuous. In one suture, I do the posterior, the second posterior, and the first anterior, I do it in one run. The fourth layer will be the thing also is different than if whatever you hold the needle in the wrong position, you will not spend time much to adjust your needle. In laparoscopy, you need to adjust it. But really, there is advantage. I noticed myself because I do both. I didn't need to adjust the needle very, very well. I just do it anyway by there is a lot of joints in that needle holders. This is the last layer, the posterior layer. I run it all together to be sure then I do my test, and also I do the jejunostomy by stapler way. So I have no control to the video here, but it's only 1 minute and I will finish everything. Here is the last layer. Then I do the test to confirm there is no leak. Then I do the jejunostomy. Here I count the elementary limb. And see, we have this, sorry. Okay, for the time I will just run.
Yeah, I think we
Okay.
are all agreed that there is advantage of using the robotic surgery compared to conventional laparoscopy, especially in certain cases.
I will just conclude and
Okay.
Also another use of robotic bariatric surgery is the sorry, I'm confused with these buttons. Revisional bariatric procedures are difficult and complex. More patient required revisional procedure. Anatomy is distorted. There is a lot of adhesions. Complication rates, as we know from the literature, around 13.2%, and mortality around 2%. Also, this study shows that robotic rostral margin is associated with shorter length of stay. This is one of the studies also proved this. And also by Stephen Scott in US, he did study from 2013 to 2005 around a laparoscopic patient around 197 and robotic 137. The leak rate was less in robotic one, and also the bleeding was less 1.4, but it's not significant. So in conclusion, routine use of robotic bariatric surgery is a safe and visible option. Several studies have shown that lower complication rate with the robotic platform, including leak, hemorrhage, and stricture. The advantage of robotic precise more and challenging cases like robotic bioluminescent revisional bariatric surgery need to move step by step, like starting with robotic sleeves, then moving toward a complex cases like bypass. So you didn't start immediately bypass if you are starting your practice. The entire team learn with the surgeon and develop experience about patient safety, precaution, OR setup, and type of instrument needed, thus leading to better OR time with better patient outcome. Robotic system improve the ergonomic and lesser operative fatigability. Operative time decrease, robot provide augmented, higher quality input from the patient to the surgeon, empowering tool to the surgeon, which can potentially change the way surgery is practiced today. Thank you.
Thank you very much, Dr. Muhammad. Just because we are limited with the time, especially the break time, we will move to the next speaker. Dr. Muhammad, no? We don't have time?
Yeah, we apologize. We have to prayer time now. So the lunch in that area. The last lecture, Dr. Ali Bahrawi will do the first lecture in the afternoon session. So prayer, the mosque and the lobby, ask them, they will tell you there is a mosque and Jum'ah is going to happen there. For those doing Qasr, there is prayer room here beside the bathrooms there. And the lunch area will be here. We'll be back here around 1:15, okay? Thank you everybody, all the speaker for the nice session.
تسمح تاخذ لي بس كده اسحبها من الزاوية.
you know?
Bismillah ar-Rahman ar-Rahim. We would like to start our next session. Our moderator for the next session will be Dr. Tariq Jabir. Dr. Tariq Jabir, consultant pediatric and metabolic surgery with American Board in Surgery and Associate of Gastroenterology and Pancreatic Endoscopy with the Canadian Fellowship in Laparoscopic Surgery. He is a non-figure of National Guard Hospital and in Bariatric Surgery. And our colleague from the board member, dear Dr. Basma Fallata, graduated from King Faisal Medical School and grant her clinical fellowship in minimally invasive from Lyon in France. And our third moderator is Dr. Ali Khammas. Dr. Ali Khammas obtained his medical degree from Gothenburg University in Sweden, and he is the head of the department in general surgery, vice president of the Gulf Obesity Surgery Society. We will continue the remaining two lectures of the previous session, and then we will continue with the themes.
Bismillah ar-Rahman ar-Rahim. We'll start our session by calling Dr. Safwan Taha. Dr. Safwan is a consultant bariatric and metabolic surgery. He is the director of bariatric and metabolic surgery in MedClinic at Abu Dhabi, and currently he is the governor of the UAA chapter of the American College of Surgeons. He will be talking about SADI and SASI as stand-alone revisional procedure for weight regain. Please, Dr. Safwan.
Thank you very much. I take the opportunity to thank the Saudi Society for Metabolic and Bariatric Surgeons for the kind invitation and generous hospitality. So how does this work? Green button? Okay, okay. It's working. Okay, green button, thank you. Okay, thank you. So I'm almost 1/3 of my work are revisions. 40% are sleeves, 20 OEGVs, and 7 Roux-en-Y gastric bypass. So I'm going to talk about SADI and SASI as standalone procedures for weight gain after bariatric surgery. SADI stands for single anastomosed duodenal ileal switch, and basically it's a modified version of duodenal switch. We're honored to have the inventor of the procedure with us, Professor Torres. I don't know whether he's here or not. And it was introduced first in 2007. It's a combination of sleeve and duodenal bypass, and I'll talk very briefly about how to do it, but it's not our topic. So there are no new spaces created, and the data will show that it gives effective weight loss. Basically, it's a loose sleeve that's associated with division of the first part of the duodenum, preserving the pylorus, and then anastomosing small bowel side to end with the duodenum 250 centimeters from the ileocecal valve. SASI, on the other hand, stands for single anastomosed sleeve ileal bypass. And as you can see, it's a totally different concept. It's based on the Santoro technique that was first described by Dr. Sergio Santoro, basically a sleeve gastrectomy with transit bipartition. It's a combination of sleeve and sleeve ileal bypass. Allegedly, 70% of the food goes through the bypass and 30% goes through the small bowel, to duodenum to small bowel. Again, there are no new spaces created here, and data, as I'll show you, proves that it does give satisfactory weight loss. It's a rather wide sleeve, a loose sleeve, and the small bowel is anastomosed side to side, 250 centimeters from the pylorus, around, 200 centimeters from the ileocecal valve, around 6 centimeters from the pylorus. using a 45 millimeters load. And this is a very quick graph about the hormonal effects of the bypasses on weight loss. We're not going to go through it. It's not the scope of our presentation today. But before going into their effect as standalone procedures on weight regain, what about their effect on as primary procedures? For SADI, it's easy because, as you know, and as you can see here, IFSO has commissioned a task force in 2018 this task force studied around 1,100 cases from 17 studies of SADI as a primary procedure for obesity. And the total weight loss was around 37% and excessive weight loss of 68%. Quite impressive, actually. And there was the complication rate didn't go more than 2.6% for GERD, and everything else was well below that. The lowest were anemia, which is 0.6%. So the task force 2018 concluded that SADI should be considered as a surgical option for the treatment of adiposity and rare diseases. So that's over. SADI is good and safe for as a primary procedure for obesity. What about SASI? SASI is the new kid on the block, and there are not so many studies about it. Actually, the first study was by the man who popularized SASI, Professor Tariq Mahdi from Sharjah, and Dr. Abdul Wahid. And they published in 2016 a series of 50 patients, and the data showed that SASI produced excellent weight loss and diabetic resolution. But that was followed by a very nice study in 2019. And as you can see here, this study is a retrospective multi-center study that spanned over 7 countries and included more than 600 patients. That's a totally different story. Again, the data showed that SASI produced satisfactory weight loss and improvement of medical comorbidities, not only diabetic resolution, but actually even hypertension, sleep apnea, and GERD with a very low complication rate. So for as primary procedures, they do produce good results with low complication rates. But what about weight regain after surgery? In my humble opinion, I think this is the most difficult task that we face and need to manage. So many factors are involved there. I mean, this is mostly about sleep, but since SASI and SADI involve sleep, so probably the sleep things are jointly shared between them and the other important parameters. But again, what we're talking about is the surgical part of the management, so we'll go for that. But then, just like we all know, and the data shows, you cannot just go for surgery primarily. What about the role of other factors with weight regain? What about pharmacotherapy? And as you can see here, pharmacotherapy is really important. You have to try it in certain patients. There's a lot of data that says you have to do that. But again, just like this paper, all the data says that the effect of pharmacological agents are not reproducible in every patient, even with the same presentation. So you will have to adopt a cautious individualist approach, which really voids that tool from its being really efficient. Reproducibility is really important. And the same thing applies to the other factor. The initial step in the management of post-surgical weight regain is always a comprehensive evaluation of all the factors that are involved, but namely lifestyle interventions, diet and exercise, and behavioral modification. They are fundamental, but again, just like this paper, all the data shows that they are fundamental, but they have very limited efficacy to achieve the goals that we look for, which takes us for surgery. So what are the things in SADI that makes us think of adopting it as a revisional procedure? Well, it's efficient, and data has shown that it's efficient as a primary procedure. There are no anastomotic strictures or small bowel obstructions to the point that make them a threat, and marginal ulcers are they're not very rare or not recorded. Dumping syndrome is the same thing. Well, the nutritional problems are there, but they are not that prevalent, and they are easily manageable. It is an anti-reflux procedure, but again, you saw in the data, even with the best hands, it gave 2%, but that's not a high percentage. And there's a low risk of gastric remnant cancer. So it's worthy of consideration for revision. And 2018, this study took analyzed 22 patients who regained weight after gastric band, and all had SADI. None of them had leak, no mortality was there, and there was only one incisional hernia. It was probably not related to the SADI itself rather than the technical procedure. So the conclusion for this study was that SADI is safe and effective for weight regain following gastric band. Of course, because of the number of cases is limited, it's rather a newly implemented for weight regain. That's why the recommendation is to have more data. But the initial numbers are very much supportive. What about sleeve gastrectomy? And this is a study by Professor Torres himself and his team, and they studied 16 patients with weight regain, all following sleeve gastrectomy, and all underwent SADI with a 250 centimeters common channel. There were no real significant complications recorded here. And the conclusion was that it's a very safe, satisfactory weight loss with, especially following sleeve gastrectomy, and the side effects were very much well tolerated and low complications, which is probably why you see in the conclusion that SADI is as a revision procedure is recommended most following sleeve gastrectomy. But that even applies to Roux-en-Y gastric bypass. This study was published 2019, and it studied 15 patients with weight regain following Roux-en-Y gastric bypass. 10 of them underwent SADI, and eight as a one-stage procedure, and the others as 2. And there was only one case of lesion stump leak, but no mortality. It was managed well with very good outcome. So the conclusion is that SADI can give actually significant additional weight loss even following Roux-en-Y gastric bypass. One of the dilemmas is weight regain following Roux-en-Y gastric bypass. Complications are there, malnutrition is there, but this is mostly because of this case. If you look there, there were 10 cases of SADI and 5 cases of BPD and the switch, and most of the malnutrition cases here were actually for the BPD and the switch. So it's also effective for weight regain following bypass. Again, because of the number, we need more data. So now you know that sleeve, bypass, and band, it is effective. What about SASI? Well, those are probably the same characteristic for SADI that are here we're mentioning, but the two different things are, it gives you ERCP access, and the reversibility is very easy. You just put a stapler there, and that's it. And you just turn it into a sleeve, which makes it really alluring. The thing is, there's no data published yet about SASI as a revision procedure. We were lucky enough that Professor Tariq Mahdi gave us a pre-print data. He's currently doing, finalizing the writing of paper, comparing 3 procedures for revision. And you can see, special thank for Professor Mahdi for the data. This is those are the 6 cases of so far. He's still in the study of Roux-en-Y gastric bypass, and you see their numbers, the BMI on the start and at the end after 1 year. And the other cohort is for mini gastric bypass, again with the BMI here and the 1 year BMI following surgery. And this is the cohort of the SASI with the BMI and 1 year later. All the other criteria were more or less statistically similar, And if you compare the data, you'll see that probably in the graph it looks better.
We have 5 minutes, doctor, please.
We're almost done. You see here that's the Roux-en-Y, and the orange is the OIGV, and the green is the SASI. So in 1 year, the drop of BMI was, in 1 year, the drop of BMI was highest. They all started around 46, and the lowest after 1 year is 24.4, which is the SASI, which gives an impression that those numbers are low, but there's an impression that potentially SASI can be a very good procedure for weight regain following bariatric surgery. So, in a nutshell, SADI is safe and effective for weight regain following bariatric surgery. Side effects seem to be tolerable. The complications tend to be minimal and controllable. Nutritional metabolic derangements need to be closely monitored, but they are not really serious and quite manageable. The outcomes seem to be best following sleeve, just like the data showed. And because of the small numbers, more studies are recommended. More or less the same applies for SASI. Still not very well investigated for weight regain. It's still not yet recognized as a primary procedure by the credible bodies, although the data shows that it is. Initial reports indicate that it's superior to AGB and Roux-en-Y gastric bypass for weight regain following sleeve. All those cases were following sleeve. And because of the numbers, then we need more studies to verify the data. Thank you very much.
Thank you, Dr. Safwan. Any question, please? Okay, no questions. Okay, thank you very much. I'd like to call our second speaker.
No questions is generally very serious. It either indicates that everybody understood everything or nobody's understood anything.
Dr. Jabir has a question.
Thank you very much.
Actually, I had a question, but we thought that we might leave it for the end. You mentioned the role of SASI and SADI in revisional surgery for gastric bypass. I just wanted to elaborate a little bit more on that. Would you, I don't know if you have any, this is routine practice in you, would you do it in 1 stage, 2 stage?
Well, the fact is I don't do them both. The thing is, I was intrigued by the literature about them, and as you saw, and you know, IFSO has recognized SADI, and SASI probably, if there's enough data, it will be on the way. But I was intrigued by the fact, all right, so what about revisional surgery? And there are very few data in the world about that. And as a matter of fact, if you can do it as a one stage, it's preferable. And Torres himself, when he did those 10, he did 8 as a primary procedure and did 2 as a 2-stage procedure. I don't know exactly what are the mitigating factors. I wish he was here to talk about more. But apparently, it's probably because of anatomical issues, because of the revisional procedure. The data is still too small, but I don't know. It sounds encouraging.
Okay. The other thing is that when revising a sleeve, I think the first thing would come to a surgeon's mind is to go to a bypass. Do you have a criteria when you say bypass is a good revisional surgery versus going to this? Or?
Well, you know, now there's a big debate between the Roux-en-Y gastric bypassers and one anastomosis and gastric bypassers. I used to be more of a Roux-en-Y gastric bypasser, but over the past 3 years, I've changed course. Now I'm doing, for the patients who qualify for a bypass, I do OIGB, unless there's something else. I mean, reflux, definitely I'll go to Roux-en-Y.
When do you utilize SASI for?
Yeah, SASI, I believe, I mean, I've seen the presentation of Dr. Tariq, I've seen his videos, and I've read about it. My own conviction is that SASI probably might be good for a failed sleeve. That's it. I don't think I will ever implement it I'm sorry, no disrespect to anybody, but I don't think I would represent it any day, adopt it as a primary procedure. But if we get more data, probably, if a big multi-center study, probably it will prove itself as a case for sleeve failure.
Thank you very much.
Thank you.
Okay. Our second speaker, Dr. Ali Al-Bahrawi. He's a consultant bariatric surgeon at King Abdullah Medical City. He has his residency training in Paul Sabatier University in Toulouse, France, and he has his fellowship training at McGill University in Canada. We'll be talking about bariatric surgery in elderly.
Assalamu alaikum. Good morning, everyone. First, I would like to thank the SAMBS organizers and Dr. Ali Muntashawi for giving me the opportunity to present our research and our experience in bariatric surgery in one of the extreme of ages, which is elderly. I'm gonna start. So I have no disclosures. Actually, our study was published a couple of years ago. It was done at McGill University, Canada, MUHC. It was done on patients who are morbidly super morbid obese and morbid obese with a BMI above 50 and had an age above 60 years. So just to start talking about the problem is obesity is an epidemic that hasn't really spared any age group. And by 2050, elderly is going to present up to 22% of the US population. The problem with obesity is in elderly, it's associated with exacerbation with already the declined functional activity and dependency. And they become more and more having loss of autonomy, and they have chronic pain, loss of muscle mass, and joint dysfunction, as well as decreased life expectancy. So the weight loss in those patients would bring benefit in all aspects. Metabolic surgery has been proven to be the most efficient treatment for the weight loss and its obesity-related comorbidities. And the elderly are at higher risk for post-operative events, especially if they're already obese. Moreover, the patients who are having a BMI above 50, the super obese patients have increased operative morbidity and mortality when we compare them to patients who are just morbidly obese with a BMI above 40. So why did we conduct the study? So the problem that there is no consensus so far about the safety and efficacy of metabolic surgery, about the age cutoff, when should we offer bariatric surgery to our patient. Do we have a specific age cutoff, or we don't have a specific age cutoff, and we take it like case by case? And in the era of the minimal invasive surgery, the enhanced recovery after surgery, and the multidisciplinary team approach, there is a growing evidence in the literature that both that the metabolic surgery is both safe and effective in those patients. During the past decade, there is already an increase by threefold of number of surgeries performed in those patients, and now it comprises 10% of total procedures performed. Talking about the magnitude of the problem, this is a graph from Statistics Canada in the year 2012, and it shows that patients aged from 55 to 65 had the highest prevalence of class 1 obesity all over the country. So that's why it's really an alarming problem, especially in the West with an aging population. It's not a new thing that we start to talk about bariatric surgery in elderly. Actually, it has been reports since late 90s and early 2000s. This is one of the most important reports by Dr. Sugarman, and he showed that the excess weight loss in patients less than 60 was 65% at 1 year, and in patients above 50, above 60 was 57%. Talking about the safety, this is another important study by Dr. Nguyen. He conducted his study on two periods from 1999 to 2005, and he showed that the mortality in patients above 60 who have bariatric surgery was up to 1%, but in the next period from 2009 to 2013, it got reduced to 0.1%. Still, it's double the mortality in the patients with the younger age group between 18 and 60, but still it's high. So the rationale, no one has studied the modern diversified practice, sleeve gastrectomy, Roux-en-Y gastric bypass, and even biliopancreatic diversion with duodenal switch in obese and super obese patients. And there is still controversy, as we already mentioned in the indications, the age cutoff type of procedures, and especially for patients who are super obese with BMI 50 to 60. Talking about Roux-en-Y gastric bypass, this is a systematic review which was done in the year 2016, and there is only 1,800 patients reported in the literature age 65 and above who had the Roux-en-Y gastric bypass, and they had a mean total post-operative complication of 21% and excess weight loss at endpoint was 66%. For biliopancreatic diversion with duodenal switch, the biggest cohort reported in the literature, it came from Quebec City, from Université de Laval, where they reported 105 patients who had open duodenal switch, patients age above 60, and they compared their results to a matched cohort of younger patients. The mortality, it was almost 1% in both groups. Mortality was the same. Excess weight loss was almost 70% at 7 years in both groups. So it didn't show any difference between duodenal switch, open duodenal switch between young and old patients. This is another study from Dr. Phil Chower and Brett Howard, Cleveland Clinic. They studied the bariatric procedures in super obese elderly patients, patients who have 65 and above and had a BMI above 50. And they showed they had major morbidity of 10% and the mean excess weight loss of 44% at 3 years. So the objective was first to evaluate the safety. Is it safe to perform those procedures, especially diversionary procedures, bypass, or even the most complex procedure, biliopancreatic diversion with duodenal switch in patients with super obesity and given the fact that they are elderly? And second, to evaluate the medium to long-term outcomes and efficacy of those procedures. So it was a single-center retrospective study of a prospectively collected database, patients aged 60 and above for a period of 8 years with a minimum follow-up of 2 years. Data obtained on demographics, weight outcomes, type 2 diabetes, especially hypertension and sleep apnea, comorbidity resolution, and complications and safety. So during that period, we had 2,100 patients had bariatric procedure. 104 patients had were elderly, above 60 years. They had 115 procedures. 11 patients had a planned second stage biliopancreatic diversion. That's why there is discrepancy between number of patients and number of procedures. 64% were super obese with a BMI above 50, and we had no 30-day mortality. Talking about demographics, age at surgery was, average age was 64 year. BMI for the whole cohort was like 48. The whole, for the super obese cohort, the BMI, average BMI was 54, 56. 60% were diabetics in the whole cohort and the super obese cohort. Talking about the complications, we had almost 10% complications, major complication in the whole cohort and the super obese cohort. 2 patients got leak post Roux-en-Y gastric bypass. 1 patient post biliopancreatic diversion from the duodenal ileostomy. 1 patient had obstruction in his sleeve, and we had to convert to Roux-en-Y gastric bypass, leading in 1 patient liver injury from liver retractor requiring re-exploration and repair of bile leak in 1 patient. And for minor complications, we had 6 or 5% rate of complications from gastrointestinal stenosis to sports site hernia or surgical site infection. For rate of reoperations, we had operated on 7% of the patients conversion to biliopancreatic diversion, and that was a planned conversion from sleeve to biliopancreatic biliopancreatic diversion with duodenal switch. 2 patients had to be converted to Roux-en-Y gastric bypass for weight loss failure, and 1 patient we had to do raised sleeve and hiatal hernia repair for weight loss failure. Non-weight loss related reoperations. We operated on 1 patient who had sleeve because of his liver injury, 1 sleeve to bypass because of the obstruction, hernia repair for the trocar site hernia. This is for the weight loss. We have, for the whole cohort at 1 year, we have 52% excess weight loss. At 4 years, we have 50% excess weight loss. For the super obese cohort, we have at 1 year, we have 48, which seems to be very efficient. And even at 4 years, they continue to have a 43% excess weight loss with 26% total body weight loss. This is when we compared by procedure. For the sleeve, we have 75% of the patients had sleeve. We had 18 patients who had Roux-en-Y gastric bypass and 8 patients who had biliopancreatic divergence. So when we compared the excess weight loss, we found that the biliopancreatic diversion offered the best excess weight loss at 2 years. Like if we compare each procedure, so at 2 years, the whole cohort had a 52% excess weight loss, the super obese group 48%, sleeve gastrectomy 51% at 2 years, Roux-en-Y gastric bypass 59%, biliopancreatic diversion 55%.
3 minutes, please.
Okay. For the outcome of comorbidities, we have also the Roux-en-Y gastric bypass. It showed a resolution of diabetes in 58%, biliopancreatic diversion in up to 80%, and the sleeve gastrectomy 36%. Same for the hypertension. The biliopancreatic diversion in the whole group, in the whole cohort, 50% of the patients had complete resolution of their hypertension. Sleeve gastrectomy offered only 19% complete resolution of the hypertension. This is a comparison between the whole cohort and the subgroup, the super obese. It didn't show much difference regarding the BMI or the excess weight loss or even the total body weight loss. So as a conclusion, we have more and more super obese patients, elderly, which require metabolic surgery. And from our study and other studies, apparently there is a growing evidence that contributes to reinforce the safety, feasibility, effectiveness of a mixed, restrictive, and diversionary surgery for our patients. An elderly patient with morbid obesity or even with super obesity should not be denied the surgery solely based on their age, and they should be even counseled for the higher risk and should be informed about all the procedure, either restrictive or malabsorptive. Thank you very much.
Thank you, Dr. Bahrawi. Any question, please, for Dr. Bahrawi?
Thank you very much, Dr. Ali, for this good subject. My question, what is your definition for the age of the elderly patient? Is it 60 or 65? And there is any limitation for the age? I mean, up to how much? And then also, another question, what is your criteria for selection of those patients? And is there any added investigation or ICU bed like this? Thank you.
Okay, so first, thank you very much for the question. First, when we decided to take the age of 60 to call it elderly or older adults, we were faced in the literature, there were discrepancies between definition of elderly patients. For the general population, as defined by the WHO, the elderly patients is 65 years and above. But when we looked at the literature in talking about bariatric procedures, we even found some studies talking about 55 and considering the age of 55 as elderly patients in this patient population because they already have a loss of functional reserve. They have decline in their physical activity. They have already loss of muscle mass and joint dysfunction. So even the definition just to have like one age limit to call it like elderly and obesity, it's pretty, in the literature, it's like all over the sport, like high and up. So we decided to get like a mean point 60, but there are other literature studies in the literature, they choose 65, and even there are some reports of reporting bariatric surgeries in patients 70 and above. In our study, the oldest patient had 73-year-old. This was our oldest patient, but after finishing the study, we operated up to patients who are 78-year-old. So it all depends on the physical status of the patient, their dependency, and one more thing that we found, like patients are coming, even they're having good physiological capacity and they don't have much physical decline, they ask for a bariatric procedure because they think later on it's going to be hard for them to have a good like physiological reserve, or they can even move or can be ambulatory. So they don't want to get into this like gray zone or dark zone, and they want to have their surgery early on. What was the second question? So for patient selection, it's like the same exact patient selection for all other patients. All patients were assessed by pulmonologists, by cardiologists, by anesthesiologists. All patients had echo before surgery, and if patients, not all patients, we had an reserved ICU bed for them, unless there was like any clear indication to have an ICU bed, like patient with bad sleep apnea, or patient with low ejection fraction on echocardiography, or patients coined as high risk by other pulmonologists, anesthesia, or cardiologists.
Thank you, Dr. Ali, for this great presentation. During your literature review, did you come across any study that looked into performing these surgeries in the elderly from the region here in the Middle East? Because, I mean, comparing Middle East to Europe when it comes to the elderly is like comparing apples and oranges, especially when you look at the percentage of the elderly with good physiological reserve, which you consider are the candidates for these surgeries.
So last time I did the study was published like a couple of years ago, when this was the last time I did the literature review. A few days ago, I did like another quick literature review. I couldn't really find something from the region talking about bariatric surgery in the elderly. I found like new studies get published last year from the States, from UK, and even from China, talking about bariatric surgeries in patients 75 years and older.
I just had to comment. I missed your presentation. I'm sorry, I was away. But the 2 points, SASMBS held 2 meetings, 2015, 2016, the luncheon when they do the experts, and everybody agreed on 2 points. First of all, there is no age limitation, and in fact, people talked up to 83 years old. They're doing it, and there were a bunch of us, I think, from the Arab world, and they all agreed. And the other point they discussed is that sleeve is the right procedure for the elderly or the extremes of age. And they all describe problems having them, especially with the glucose balance in those patients when they're elderly, when they did Roux-en-Y gastric bypass. And we saw the same thing with our patients.
Even in our cohort, we had like 75% of the patient had sleep. And for the patients who even had the biliopancreatic divergent, they had it as a two-stage. Most of them, they had like bad controlled diabetes. That's why we offered them the second stage of biliopancreatic divergent. Thank you very much.
Thank you very much. Now I think we're moving to the officially to the next session, which is complication in bariatric surgery. And I always thought it is a very difficult question to answer, or a task to have good experience in treating complications at the same time maintaining very, very low complication. Everybody will build his experience from complication. At the same time, you're trying to achieve, or you should try achieve, zero level complication. Our first speaker is Dr. Walid Bukhari. Dr. Walid Bukhari is a senior surgeon, and he is one of the pillars and founders of bariatric surgery in Saudi Arabia. I think at one stage of your life, you don't go back to qualification and you go by your reputation. So I'm not going to spend much time talking about the educational history of Dr. Walid Bukhari. Dr. Walid Bukhari is going to tell us today about the role of gastric bypass in managing leak post-sleep.
السلام عليكم. أشكر اللجنة المنظمة للمؤتمر على رأسهم أخويا الدكتور علي منتشري والدكتور عصام بتايا والمجموعة اللي بذلوا جهد كبير الحقيقة في إظهار الواجهة المشرقة للشباب حقونا والتنظيم الرائع إلى الآن. Can we go on? Can we have the slides? It's not working. Ah. Okay. How do you go back? Okay. So it's laparoscopic Roux-en-Y esophageal for leak fistula after laparoscopic sleeve. That was a controversial subject when I started doing those procedures, and everybody was accusing, why are you doing such a tremendous operation for a less grave complication, which have proven to be totally wrong way of thinking and taking it publicly. So the clinical evaluation, it's not always evident clinical examination. Cut-edge tachycardia, when do we start suspecting? Fever not specific. Rarely patients at the beginning complain of abdominal pain, leukocytosis with high CRP or calcipoprotein. CT scan is a logistic problem, especially in super obese patient. The onset of presentation, the early leak is 1 to 3 days, and there are so many ways we thought about, less surgical and surgical. The early re-laparoscopy is very much indicated. Control of leak by resuturing, gentle knotting, choice of suture is very important, and the drainage procedure, external with GI tube, with CT scan guidance, and nutrition with T-pen and feeding genostomy. Late leak after 3 days, re-laparoscopy, adhesions, lack of space, suturing is totally impossible, especially in ischemic tissues with the presence or absence of peritonitis, tissue inflammation, and the drainage with CT guided or open drainage or laparoscopic drainage is always a choice. And there is a an old study showing by Nasser Sakran showing 2,834 patients at 2012. It have shown re-operations 61%, 20 by resuturing, and conservative 39%, ended up by 63% of the 39 percutaneous drainage, stent, clip, and fibrin glue. Our protocol in the management of acute chronic leaks as follows: stabilization of the patient, control sepsis and nutritional support, immediate laparoscopic surgical intervention when safe. Leakage after sleeve gastrectomy, primary GIA repair or simple repair, hand sewing, suturing, or laparoscopic oesophagogynostomy bypass. Laparoscopic total gastrectomy with Roux-en-Y oesophagogynostomy for chronic gastric fistula after laparoscopic sleeve gastrectomy. And this is done by Andrea Kadir. This is one of the few publications that we found available to discuss about 5 cases they have done, or 4 cases they have done. They report of 4 patients with chronic staple line leakage in close proximity to the EG junction that progressed to chronic fistula. All patients failed multiple attempts to conservative treatment and required total gastrectomy with esophageal anastomosis. And those patients, you could see the time of the surgery, the age of the patient are 35, 38, 41, and 21 female. And time to surgery in month till they made the decision to do a total gastrectomy with esophagogynostomy. You see, the first case is 3 months, 4 months, 18 months, and 24 months in the 21 years old patient. Oh, sorry. And the discharge from hospital after the procedure was 5 days, 8 days, 15 days, and 7 days. Prolonged non-operative management of high chronic leak after sleeve gastrectomy with a range of repetitive endoscopic therapies beyond the 3 months period is futile. It won't help. And that will take them into more serious complication, as I have experience with few patients that we will come to mention. Treatment of stapler line leakage depends on timing, clinical and anatomical consideration. So if the leak persists and transformed into chronic fistula, a definitive surgical procedure is required. We like to beat around the bush for one of two reasons. Either we don't trust in our ability to carry out such a big procedure as we see it, or we hope that this problem will disappear and go away. It won't. It's going to always come in your face, and the patient will be there and his family will be there. The proximity to esophagogastric junction is very important, because the more the proximal to the esophagogastric junction, the surgical options are limited. And then you have to make this big decision. And the option usually is total gastrectomy with esophagogynostomy. A chronic fistula always starts with a small leak. Early treatment is most important to avoid chronic situation. Case number 1, status post-gastric sleeve, 1 year duration, complicated by chronic gastropleural fistula, operated many times with laparotomies and thoracotomies, but failed at the end to prevent the persistence of that and the progression of that problem. Recurrent admissions to ICU due to sepsis and chest infection, managed by laparoscopic esophagogynostomy. No, where is the film? Huh? Can you operate the film, please? Case number 1. في هنا أحد؟ You need the USB? Huh? Anyway, so, and as time goes by and the experience becomes more and more, I find that tackling the problem of leaks, and our subject is not that, our subject is through total gastrectomy or subtotal gastrectomy with esophagogynostomy. Tackling the problem of leaks really is dependent in the golden hours. The minute you discover it, if you discover it at the end of your day and you're tired and you want to go home at 6 or 7 o'clock, don't say, I'm going to leave it till tomorrow morning. I'm going to put it on the first of the list. You have lost immense, important golden hours. And I believe that if you are as much as tired as you are, get back to the operating room, get your patient down once you discover the leak. And I believe, out of experience, it is the first 6 hours from the time of discovering the leak is the time where you can minimize the damage and the necessity for a more bigger operation, like gas. ها؟ مستحيل أنا شغلته هنا. ها؟ لا الكمبيوتر لا. أعتقد اللي فوق شغلوه. على كل حال يعني I wanted to show it appears to be almost impossible, because in those situations, especially with chronicity, there is no space to operate. You think at the beginning, but as you go on and you start dissecting, it becomes more obvious and it becomes more. There are standard anatomical features you have to follow, and that is the hiatus, the crus, the superior pore of the spleen, the diaphragm. And it's very important to follow those doing your dissection. It will always come and it will always help. طيب إذا ما في فيلم we progress بس نتكلم عن الحالات. إيه.
Walid, I think we'll progress.
طيب.
I think we're just gonna progress, Dr. Walid. If they fix it, we'll show it later on.
Yeah, طيب خليهم يحطوا بقية السلايدز. ماني حافظها عن لم أحفظها عن ظهر قلب. لازم أشوف. ما بضغط أهو.
أنا حافظها يا وليد أقولها.
ما أنا أيوه طيب. بالضبط عشان لا يضيع الوقت.
Replay the presentation يا دكتور علي.
إيش يقول؟
يقول أخصم منك 5 دقائق.
أنا يعني while we're waiting for the you wanna go like this?
On the basis إنه أنا ما عندي شغل بعد كده.
Dr. Assam, should we change the schedule? Will play without the video? Will what?
طب نكمل بس المحل.
Yeah, I think Dr. Assam will take care of this.
طيب.
Say what you want to say.
Let's benefit from the time and talk about the lack of also publications in that aspect. Very few publications that are published in that field, though it's, and I blame myself too, not publishing, though I have one of the largest experiences in the world in dealing with those problems. And I've dealt with problems with chronicity up to 2 years, 2.5 years, with gastro, pleuro, bronchial fistulas, with gastro, colo, cutaneous fistulas, intrafistulas, gastroenterofistulas. And patients' lives were destroyed, divorces have happened, loss of jobs have happened, families have broken because of this situation. Whereas the solution, and I respect my professor and older colleague in position and younger in age, Professor Mufti, when one time he said, you are treating a small problem with a big gun in the University of King Abdulaziz. I told him, no, that is not a small problem. And now it appears to be a small problem. Wait, and we will see, Adnan. And that was more than 8 or 9 years ago, or 10 years ago. It is a grave problem when it happens. It has very bad implication on the life of the patients. We know that some patients die from this. And the solution, a grave operation, true, it's a big traumatic operation, it is true, but you preserve the life, you bring the patient back to his normal rhythm, to his life, and you preserve his health, and so on. So that's why I advocate as a last solution, but make the decision early. Don't wait till it becomes chronic.
What is early in your opinion? I mean,
I'll tell you, if you, the earliest you can resolve it. We're talking about chronic patients that are referred to you. Then the situation, yeah.
I want to explain my question first.
Yeah.
Are you against stents?
No, I'm not. No, I am not. But I have seen stent failing In most of the cases I did. I saw stents eroding. I saw stents not functioning. And I saw stents that succeeds. But the percent of the success might be growing higher with the experience we're gaining in application of the stent. But we should not only rely on that, because you have also a high rate of failure with stents.
So you would prefer to go in without
No,
stent, or
chronic
you would
ones,
wait for the stent to
no.
fail?
Those are chronic leaks. They have already gone through all what you want. They have gone through internal fistulation. They have gone through internal drainage. They have gone through stenting. And they come to you. Make the decision and do it.
I think this is the point. The title would be probably the role of esophagogastrectomy and gastrostomy or jejunostomy in managing chronic leaks rather than managing leaks. Because
No, it's not a first choice, definitely, but it is an important choice, and it is reserved for those cases. I wish I had a chance. I have few cases I wanted to show with different approaches.
I think by the time they're resolving it, we're going to
let's go to the next
interactive. Anybody has any point to?
I think the video is running, Doctor.
Okay, now it's working.
Yeah. Now I forgot what is this. Which film is that? Case 1 or case 2? Huh? 1. Okay. You see here, this is an early leak following bleeding with a definite leak and beginning of sepsis. There is no way in such tissue you could do suturing or any sort of, and you see it's in more than one area, lateral and medial. There is no way it would be repaired. And here, even the cutting, you have to modify yourself. You have to sometimes resect in cases of such a problem. The leak is so high, it is beyond even the gastroesophageal junction. It could be even in the lower esophagus. And you see here what's holding the bougie is only the mucosa. So, resecting after that, and then doing higher anastomosis, hands-on. And it's a nightmare. It's really a nightmare. You start thinking of interposition, of colonic interposition, and this and that. Maneuvers to lengthen the mesentery. You would say, is that going to hold? Yeah, it will hold. Patient will do well. And in 5 days, the patient was out of the hospital.
You're taking interrupted stitches?
Yes, cruropexy, and repair of the opened left crus. Okay, next. Next slide.
So you fix the esophagus to the crura. I'm asking here. And knee.
أيوة.
So you were fixing the esophagus to the crura as well.
No, no.
Cruropexy. Or you mean just the closure of the
Cruroplasty.
Cruroplasty, yeah.
Yeah, cruroplasty, because we have seen cases where after they lose the weight, you find bowel going in the thorax and you get my God. فين علي؟ ما قلت لك يا علي بلاش ادي المحاضرة، عارف انا حظي منيل معاكم. يس سامع. ها؟
If the anastomosis go to the chest.
No, I'm not saying it's a problem, but you get, we have seen cases where you have bowel loops going up and it causes obstruction and impairment of the vascularization. If you don't close it. We had a case that was 3 times operated for that problem.
But people argue, Dr. Bukhari, that if you have a tight crura, the problem will be worse. And if you have a herniation with a wider hiatus, it is just a herniation. If you have,
but herniation, we have seen herniation leading to bowel gangrene.
this is what I'm saying. It is going to be theoretically
No,
worse.
without repairing the crura. And when you repair the crura, ya Tariq, you don't go and make it too tight. There is the 50% distance comparing the anastomosis to a 50% relief. You don't go and do it beyond that because you are going to tighten on the anastomosis, as you said. Case 2, laparoscopic esophagus for management of gastric leak, late presentation.
Dr. Walid, you did loop behind you. You did loop anastomosis.
Yeah.
If you do it Roux-en-Y, would it be less
It's a
tension?
Roux-en-Y, but I didn't show when we did the section of that part because you take a loop of bowel and you try to see which is the best part that goes the highest point.
Can we go back to track and carry on with the presentation?
Yeah. Case 3. So no films. Chronic persistent leak for 3 months duration, status post-laparoscopic sleeve, frequent laparotomy, drainage operation with burst abdomen, gastrocutaneous fistula, failed leaking feeding genostomy, failure of stent, managed by laparoscopic esophageal genostomy. Film is not working. هيشتغل؟ نرجع يعني؟ Okay.
Meanwhile, Dr. Walid, as we are having too many interruptions, any few of, okay. It is working here.
I have a Tariq. I have. Yes, Dr. Walid, in 2018, I had similar case, chronic leak with even fistula, and I contacted him. I said, what I do, I will refer the patient to you. Patient critically ill. He said, Khalid, you have to do it, and I know you can do it. If you don't do it, you will never do this case again. So I listened to him, and I did the same oesophagostomy. Since then, I have done 2 more cases, because the same situation, very bad situation. But he insisted, he said, don't refer the patient to me. Do it, and you can do it. Thank you for
I remember, not at all.
So the message, don't refer to Dr. Walid or do it yourself.
هيشتغل ولا نكمل الدسكشن؟ لا اشتغل.
هذه case number 2 ولا number 3؟
3.
انت لا تحفظ اي شيء.
ايوه. This is a chronic case, a chronic leak also for more than, oh, this is for more than 1 year. And you could see the drains and the effect of them. This one actually was so adherent. This patient had, this case number 3, if I remember well, this patient had burst abdomen. I sutured the skin and I did it laparoscopically because I tried to go in that plastered area. It was impossible. So I only sutured the skin and went down from the left iliac fossa, got everything down under vision, and then started my dissection. And soon enough, we discovered the area of the leak. Our always guideline is the hiatus. And again, an esophagogynostomy, jejunojejunectomy, and an esophagogynostomy. There are different methods of doing them. Hands-on is one of the methods I prefer, but you can use the circular staplers, you can use the DLUs, and they all work. Closure of the enterotomy. And you could see the space is minimal, but still you can work. Don't expect that you're going to have an ample of space that you can deal with. It's not, but it's workable. Patience, take your time, and do a good job. Can we push the next slide, please? So the third case, a patient had thoracotomies, had repair with Gore-Tex mesh through thoracic surgery and thoracic surgery. If you don't deal with the primary problem, which is the chronic fistula, it will come back, it will haunt you. So they jumped the third, which is fine. Status post-gastric, this is case number 4. Removal and sleeve gastrectomy, 1 week duration, presented with leak, managed by bridge bypass with jejunal fistulotomy. Can we see this film, please? So I'm just showing that we don't, because we have a hammer, we don't see that every patient is a nail. But you have other less, when it's applicable, other less invasive procedure you can do. For example, this case, the tissues are better. When we opened the site of the leak, there was, you could see that there is good tissue response. You could see the left hepatic artery pulsating. That is a very important parameter. There is a lot of vascularization in the area. So the decision here was to go, and he had a left aberrant hepatic artery. The decision was to do a fistulous jejunogastric fistula. And the beauty of this, that after 3 months, you see the patient eating and you do the fluoroscopy for him, 95% of the dye, solid and liquid, goes into the stomach. And barely anything would go into the jejunal fistula. And so it functions really as a sleeve gastrectomy. And it have overbridged the problem when it happened.
a loop or a row?
Huh?
You put up a loop or a row limb?
No, no, it's a row limb. I showed jejunal down there, absolutely. No, row limb. Next. Can I have the slide after? If I was talking about the one with thoracotomy, you find the cortex like cigars in the abdomen. A patch here, a patch there. No, okay, the next slide. We did, yeah. Summary. Bariatric surgeon will face a variety of challenges. Key is through knowledge of surgical anatomy and applying Hasted principles of tissue handling laparoscopically as well as in open surgery. Gentle manipulation of tissue is very important. Preservation of blood supply is of utmost importance, and accurate apposition of tissue layers. We don't always go for esophageal bypass, but when circumstances allow us to go for less dramatic procedure like bridging jejunal fistulotomy or primary suturing or staple excision of leak site, we would opt for the less aggressive procedure. But when you are left without any other choice, then you have to be able, as I told Khalid, you have to be able to make that decision and do it because you've reached that maturity of surgery. Unfortunately, sometimes we are left with that solution and that only solution, and you should be, as a bariatric surgeon, able to do it yourself.
Thank you very much. We're not going to go to take any more questions for Dr. Walid, so we can keep him till the end of the session. We're going to move on to the presentation of Dr. Bawahab. Dr. Bawahab is known to all of us. He has made also his reputation in bariatric surgery. He had his basic training in Canada and his fellowship in upper GI surgery again in the University of Calgary. Then he moved and he had another fellowship in bariatric surgery in the States. Dr. Bawahab is going to talk about hypoglycemia post-bariatric surgery. Thank you very much.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee, the Saudi Society of Metabolic and Bariatric Surgery, Mr. Co-chairs and mentor of the session. My topic today is about hypoglycemia following metabolic surgery. So which one will move?
Just try.
So I have no disclosure for this talk. When I thought about doing hypoglycemia in post-bariatric surgery, an extensive...
Dr. Bawahab, can you just come?
An extensive literature review from 2013-2019, including Google search and PubMed databases. Hundreds of thousands, all of us we know, of different bariatric surgery being done annually across the world. Bariatric metabolic surgery is the most effective therapy for obesity with serious comorbidities. Well-documented benefit for long-term morbidities and mortalities. Risk and complication of these surgeries still can stay years and years after the procedures. Post-bariatric hypoglycemia can happen after all different types of surgeries, starting from bypasses, lap band, sleeve gastrectomy, single loop bypass. Post-bariatric hypoglycemia is a potential serious complication, which is totally different from dumping syndrome that we see after bypass surgery. Patients with post-bariatric hypoglycemia can have serious complication like hypoglycemia, seizure, with adverse effect on the quality of life, even mortality. Incidental and premature deaths have been reported. Post-bariatric hypoglycemia or Roux and White gastric bypass, it's over 30% of most of the published data, mostly postprandial. None of them were fasting hypoglycemia, documented usually by oral glucose tolerance tests by giving the patient 75 grams with concentrated glucose with serious postprandial blood glucose testing. Postprandial hypoglycemia of glucose less than 50 grams per decil or 2.5 millimole per liter. Though hypoglycemia is a glucose as been defined by American Association of Diabetes and Endocrinology of less than 70 grams per decil, mostly it happens in 2 to 3 hours post-meal. This curve, the first one shows the level of glucose, and the solid line is the hypoglycemia effect, which corresponds to the lower graph with a high insulin level around 60 minutes and after. As we know, dumping syndrome is early in post-bypass surgery in the first hour of surgery after meal due to rapid transit of food into the bowel because of loss of pylori control that lead to fluid shifting with sympathetic response, which presented with diarrhea, sweating, flushing, tachycardia, abdominal pain, and light headache that might last an hour or so. Last, post-bariatric hypoglycemia, which happened 2 hours and after from the meal, due to hormonal effect presented with symptoms of hypoglycemia, fatigue, weakness, sweating, shaking, dizziness, tachycardia, can end with loss of concentration and mental confusion. The pathophysiology actually is not clear to us, but what's being postulated like an endogenous or exogenous reason, and the endogenous factor accelerated delivery of nutrient into the root limb of the bypass that stimulate the hypersecretion of incretin effect that will elevate the postprandial level of GLP-1 that lead to hypertrophy of beta islet cell with superphysiological insulin secretion that followed by drop in the glucose. The second theory is suppression of counter-regulatory hormone that would increase the peripheral insulin sensitivity as well as glucose clearance will reduce the clearance of circulating insulin level. Always put in your mind, if you have a late kind of hypoglycemia, think about insulinoma. Insulinoma, usually it happens fasting hypoglycemia. It's not a postprandial, and we have to document it by CT scan imaging or endoscopic ultrasound. The other causes exogenous factor like Munchausen syndrome or malingering that happen by excessive doses of sulfonylureas or insulin injection. Type of post-bariatric hypoglycemia symptom, either autonomic symptoms like anxiety, palpitation, sweating, tremor, or diaphoresis, or neuroglycopenic symptoms, which is the most severe and most causing agent or reason for mortality and morbidity that might lead to confusion, false seizure, and loss of consciousness. So where we stand from that, SASMBS, they posted their statement or position statement in 2017, and they follow a patient, they published their paper in 2017 based on a retrospective review from several institutions. They showed the neuroglycopenic symptoms several years from the procedure and average 2 to 4 hours after the surgery time. 2 to 4 years from the surgery time, it happened and after 1 hour from the meal. More on women, documented by glucose less than 55 milligram per decil with a Whipple triad. Measure glucose and insulin, C-peptide, proinsulin level with a mixed meal tolerance with provocative test, first in the fasting moment, then after that 30 minutes interval. The mixed meal tolerance test that used by the SASMBS group, postprandial hyperinsulinemia and hypoglycemia after bariatric surgery that requires symptoms occurring after 1 year from the surgery. Usually they have normal fasting and normal insulin level, and with correlation of symptoms and hypoglycemia that followed by spontaneous resolution of hypoglycemia and positive prophylactic test. How we treat it? Okay, usually we need our colleague from endocrinology on board with us, medical nutrition therapy that's supervised by dietitian or by clinical dietitian, frequent meal. Usually it should be high in protein and high in fibers, low in fat, as well as in low of carb. Usually it doesn't work well because the inconsistency of the patient following this regimen, and sometimes it's ineffective. So this was being posted by SASMBS group, the way that we treat the patient by diet. The pharmacotherapy started by acarbose, which is the alpha-glucoside inhibitors that inhibit carbohydrate absorption, thus decrease the insulin response, which is limited use because of its non-GIT effect that might happen in 20% of the time, diarrhea, flatulence, and abdominal pain. Other agent, dioxide, that that will open the adenosine triphosphate sensitive channel, that will reduce the opening of calcium channel, by that will reduce the insulin release and increase the glucose level. Side effect is edema, heart failure, hypotension, and hirsutism. Third factor, octreotide, that will inhibit GLP-1 and insulin release with a known side effect of diarrhea and rarely bile stone. So all of these medication has not been liked by the patient. GLP-1 receptor agonist, which is new, yet under investigation, that will improve the post-bariatric hypoglycemia, possibly due to downregulation of insulin secretion from beta cell and increased secretion at the same time of glucagon from alpha cell during hypoglycemia. Fifth agent was the most effective agent out of all what I mentioned, nifedipine or verapamil, that's calcium channel blocker that will block insulin secretion by inhibition voltage-gated calcium channel on beta cell. It's very effective in treating post-bariatric hypoglycemia when combined with dietary restriction or acarbose. It has a side effect of hypotension. Bridging all these medication, it's a bridge just before surgical intervention. So, hypoglycemia after gastric, many published paper, okay, and only what I did is highly selective of the recent paper of them. Hypoglycemia after gastric bypass. This paper was published recently, I think somewhere around 2017. This is the algorithm that I was talking about, starting by the dietary control followed by the medication. The 72 hours fast, which is a documentary for insulinoma. So they keep the patient fasting except from non-caloric and decaffeinated beverages. After 72 hours, they start testing the blood glucose. And if they have a glucose less than 55 with insulin more than 3 and C-peptide more than 2, pro-insulin more than 5, it's a documentary for insulinoma that should be documented or confirmed by imaging study. So pancreatic imaging looking for insulinoma, if 72 hours fasting hypoglycemia present with hypoinsulinoma, it's confirmed. So CT scan and ultrasound or endoscopic ultrasound, it increases the sensitivity of more than 100% in a lesion less than 5 millimeter in size. If it fails, we have to do selective arterial calcium stimulation. If fasting hypoglycemia is still present with hyperinsulinemia, that confirmed the imaging test is negative, so it has a sensitivity of more than 96% of the time. Same algorithm of what I mentioned. So surgical treatment, if all fail, what should we do as a bariatric surgeon? Gastrostomy tube, it's a first step in the remnant stomach or in the mother stomach, okay? It can help. If the patient hypoglycemia improved, it's a bridge before reversal of a bypass surgery. Or gastric outlet restriction by endoscopic technique that might decrease the dumping syndrome as well as the post-bariatric hypoglycemia. Reversal of Roux-en-Y gastric bypass if it works with a feeding tube. Distal pancreatectomy is being mentioned by some group of surgeons in Sweden as well as in the UK, but it has been rejected and not been advised by SASMBS. So, prevalence of hypoglycemia symptoms after Roux-en-Y gastric bypass and vertical sleeve gastrectomy and associated risk factor. They have a large group of patients, almost close to 1,200 patients, and all they agree they have a risk of post-bariatric hypoglycemia of more than 30% of the time, and they've been treated with the algorithm that I mentioned. So preoperative hypoglycemia is strongly correlated with postoperative postprandial hypoglycemia in both Roux-en-Y and sleeve gastrectomy. Preoperative diabetes is not a risk factor for post-bariatric hypoglycemia, though hypoglycemic patients before surgery, they showed more hypoglycemia post-surgery. So all these papers, they are in line from different countries, from different journals.
3 minutes, Dr.
Sure. I need maybe 2 more minutes. So the last paper, it is a prospective study of 333 patients with 2 years follow-up, both Roux-en-Y gastric bypass and sleeve gastrectomy, as well as adjusted laparoscopic gastric band. The study is based on OGTT based with the glucose of less than 2.8 millimole per liter. It shows of postprandial or post-bariatric hypoglycemia of more than 25% of the time, mainly in the bypass group. And what they correlate in this patient, they find high frequency of postprandial hypoglycemia that is after all type of different procedures. So what we recommend, or what they recommend in that paper, patients should routinely undergo oral glycemic tolerance test post-bariatric surgery. Patients should be trained by dietitian to increase the number of meals per day with less carb and less fat. Patients should know the signs and symptoms of hypoglycemia and how to treat. Okay, so last study is a retrospective study of other almost 200 cases from Virginia, United States. They used OGTT as a test for post-bariatric hypoglycemia of 180 patients. What's interesting in this paper, they found a correlation of a patient who been hypoglycemic, low PMI, low and high triglyceride pre-op, they are at high risk of postprandial hypoglycemia as an independent predictor of their postbariatric hypoglycemia. So in conclusion, mild to moderate symptoms that suggest of hypoglycemia and dumping syndrome is more high in the sleeve gastrectomy as well as in the gastric bypasses. In some papers it quoted by 40%. So what about laparoscopic adjustable gastric band? Yes, in laparoscopic adjustable gastric band there is a reported case of 3 cases from 2008 to 2012 that very rare at the time of onset of postprandial hypoglycemia or postbariatric hypoglycemia. It happened after 2 years from the surgery, irrelevant to the volume of the band as well as the frequency of the filling of the band. None of them is diabetic, and diagnosis made with a positive Whipple triad. Thank you very much.
Thank you, Dr. Wahab, for being so informative and so concise. We can take one question if you have.
Assalamu alaikum. Very good review. I think we face this problem as I was doing bypass a routine since 90. And 2 important points which I can't say it here. Number 1, actually all bypass, they will have some degree of hypoglycemia. But not all of them, they will come and report. And that is only of early type, not of the late. Late, once the patient gets late, we have to investigate for islet cell hyperplasia, and then at that moment the treatment strategy will be different. So all bariatric surgery, as you have said, they can have some degree of hypoglycemia. Right. But the worst one is bypass, and probably the bypass which will need treatment. Number 2, which is very important, is that the early is a behavioral change. That's why if you look in the literature, you will see 80% they are self-limited or treated non-surgically. But the others, they are late one. In your review, the question which is very important, once the patient has come with such a symptoms and signs, what is their strategy to identify the way how to treat?
Well, first of all, patient has to be admitted, monitored, be sure that this patient is really hypoglycemic using the oral glucose tolerance test under the supervision of endocrinologist. First of all, we have to get the diagnosis. If we have positive OGTT with a positive Whipple triad, that's all we know. I mean, hypoglycemia symptoms, low glucose that improve with glucose supplement, okay? So this patient has a post-bariatric hypoglycemia, which is the late onset one. Now we think about the treatment, okay? All the literature is saying patient should not be discharged on an oral instruction to go and just try to help himself at home, okay? Admit him in the hospital, start a high protein diet, high fiber diet, low carb and low fat, and monitor the patient for at least 3 days or so. If they do well, okay, with a good calculated calorie intake, so he's from the group that will be treated with nutrition. Some group of people, we need to move to the second arm of management by using the pharmacotherapy, acarbose, and the rest of the medication that I had mentioned. None of the patient, okay, maybe few case report that end up with pancreatectomy, okay, but okay, it's not being advisable anymore. I think you're going to make them worse by doing pancreatectomy. So I think what we have is dietitian, training.
Well, I have done pancreatectomy, unfortunately induced distal pancreatectomy.
Did it work?
I did reverse bypass. And now we do sleeve them, we convert them to sleeve in order to bring back the pylorus as a tool to reduce the effect of rapid emptying. But the point which I think is very important, if we look backward in 2000, we do more than 80 case bypass per year, okay? If 80% of them, I will admit them to do all these workup. Actually, most of them, they have the same complaint.
But
they come with hypoglycemia.
But you cannot diagnose them without this workup. You cannot make a diagnosis without the workup.
والله كلنا عندنا questions, including myself. Dr. Wahab, this is pretty a complicated issue
And you mentioned like 4 types of pharmacotherapies and an admission. I don't think that surgeons are there to treat this kind of complication. Surgeon treats surgical complication. This is pretty endocrinological complication, and I would ask you if you agree with me that once patient fails dietary therapy, they should be referred either to endocrinologists and deal with them, or bariatricians, because they are much better in dealing with this complication.
If you listen to the first statement when I mentioned under the supervision of endocrinologists, like endocrinologists, they are on board with us. We're not admitting the patient under our care, but at the end of the day, they're your patient. You operated on them.
Well, you go and say hi. It's okay.
Say hi, send them back. Okay. But the thing, yes, they've been treated by endocrinologists.
Dr. Osama بعد يسأل سؤال.
Just one comment.
One last question. Do you think the width of the stoma correlate with the hypoglycemia?
فين اللي يسأل أول شيء بشوف. Okay.
Do you think the width of the stoma of the bypass correlates with the hypoglycemia?
Yes, it does.
So why not narrow it?
This is what I said. Part of it, you have to endoscopic narrowing of the stoma.
This should do the trick or no?
There is a lot of controversy. We don't have an absolute answer of all what I said. Just being algorithm, and you follow it and see which patient will respond to which.
Last question from Dr. Osama Saleh.
3 comments. Number 1, you mentioned
كانت واحدة
GLP-1 agonist. You meant GLP-1 antagonist, because GLP-1 agonist will drop the
No,
glucose.
receptor agonist.
Antagonist, in fact, because it's extending 939 is what they are trying now in the market, and the idea is it's a glucagon-like peptide.
Exactly.
So you need to block it.
Right.
But actually, when you reverse them to a sleeve, what you're doing is you're introducing duodenal feeding. And in duodenal feeding, what happens is GIP, which is a glucose-dependent insulinotropic polypeptide, makes glucagon get secreted. That's how they get treated from hypoglycemia. And only Roux-en-Y gastric bypass now is becoming a diabetic procedure. Why? Because diabetics don't have a strong pancreas. So when they are given the Roux-en-Y gastric bypass, they rarely go into hypoglycemia. While most of those patients who have neuroglycopenia and those symptoms are the patients who are non-diabetic go for Roux-en-Y gastric bypass. And hence, that's why we're doing them less and less, so we see them less and less.
But how do you explain the hypoglycemia post-sleeve gastrectomy, which fit all these criteria?
It's the same fact. If your insulin is, here's the statement that people have said. If you take a patient who is a high BMI, okay, they have a very strong pancreas. Suddenly, you drop them to a very low weight. Their pancreas is stronger than them, and they get hypoglycemia if they don't eat. Not only if they are postprandial. And that was one of the major research people are doing now on them, that how to make sure that they don't lose a lot of weight to get that.
I think just last comment to what he said. Through all my research, it was very extensive research, Dr. Osama, none of the patient had Roux-en-Y gastric bypass being managed surgically by putting them back into sleeve gastrectomy. Either. It's not a treatment option, at least from what evidence I throw.
I'll show you tomorrow.
I think we'll leave it till tomorrow. Very interesting subject and too many questions. Everybody's talking about the problem with hypoglycemia and bypass. I think the worst part is when you have hypoglycemia with sleeve where you cannot do anything about. We're going to move on to the next speaker, and Dr. Khamas will present him.
Our next speaker is Dr. Ricard Gonzalez. He works in Cleveland, Abu Dhabi. In his portfolio, there is 40 published papers in American and international journals. He's done more than 1,000 different bariatric procedures. And he will talk about factors associated with length of stay in intensive care after bariatric surgery.
Thank you, Chairman, for this kind introduction. I would also want to thank the Saudi Society for the invitation, especially to Dr. Ali and to my old friend Isam Bataya, who I firstly met many years ago, back in 2013, in our fellowship in Ohio. I have no disclosures for my presentation. And I'm going to talk. Is that better? And I'm going to talk about risk factors related with intensive care unit after bariatric surgery. So I think that we all agree that bariatric surgery interventions are safe and effective, no? And it's been because of several quality programs have been designed by the most prevalent organizations in the field, such as the ASMBS, the ACS, and other international societies like SAGES, IFSO, etc. No? With the main endpoint to decrease the clinical and financial burden that suppose all postoperative adverse effects. But if you let me point out or highlight to my humble opinion, the most important quality program, this is the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, which is quoted the MBS AQIP, which is basically a joint venture between the American College of Surgeons and the ASMBS. And most importantly, that quality program, what provides us is a huge and enormous volume of data that is used for developing innumerable contemporary studies on the field. And finally, the main objective of that is to standardize high-quality care at centers of excellence. And to my humble opinion, I've been only 2.5 years in the UAE. I believe that we in the Middle East, we need, that's probably one of our flaws, the lack of national-wide, well-organized and standardized databases in which we can publish our results. I've been here a couple of days. I'm amazed about the quality of the scientific presentations and the speakers, but I think that we should all together put our efforts and start publishing high-quality nationwide studies. Let me start with this paper published by my colleague Ali Aminian. This study was published in 2015, and the study evaluated mortality rates in the states in between 208 to 212. You can see the slide has no outstanding quality, but you can see over the top mortality rates for the cabbage at around 3%. If we go down infrainguinal bypass, mortality rate 2%, laparoscopic colectomy 1.5, lap cholecystectomy, lap appendectomy, and Roux-en-Y gastric bypass, mortality rate was 3 cases out of 1,000. And that is, I think that we should highlight these results to our patients that overall and generally speaking, gastric bypass has lower mortality rates than the appendectomy or than a standard cholecystectomy. And to me, that's astonishing, and that is a clear answer about how well is being done bariatric surgery so far. But ladies and gentlemen, we still have some complications now. This study is based on the MBS AQIP database. The study was conducted by Chris Daigle back in 2015. The study includes more than 135,000 patients. The majority, that is not surprising, of the patients were females at around 80%. 75% of the cohort were Caucasian patients. Mean age and BMI were 44.5 and 45.7 respectively. Again, this is data from 2015. This is, includes patients older than 18 years old who underwent primary, that's important to highlight, primary bariatric surgery. And the type of procedures among all these 135,000 patients were almost 70% sleeve gastrectomy, 30% Roux-en-Y gastric bypass, 3% gastric banding, and 1% the duodenal switch. This is, of course, data from the United States. And the frequency of all complications was 1%. But let's look more careful to that data study, which was the 30 days postoperative complications. And I have highlighted this clearly was bleeding. Bleeding was the commonest complication, early complication at 30 days, 0.7%. It was followed by the surgical site incision infection, 0.5%, UTI 0.3%, and VTE 0.2%. When Chris Daigle and colleagues looked at the main adverse effects at 30 days post-op bariatric surgery, they found the results that are shown in that chart. And if we focus in my topic today about ICU admission, they identified that 0.76% of patients were admitted in the ICU. Also, important outcomes were a 4.2% of readmission rate, a 1.3% of reoperation rate, and mortality was quite low, 0.1%. But I want to please ask for your attention. This is probably the most important slide in the whole presentation. Chris and colleagues, they try to investigate the relative risk adjusted population. It was based on a separate regression model analysis of each complication and its outcome in outcome pair. They observed that for the ICU admission, they identified bleeding, leak, VTE, and pneumonia. Bleeding, 13.7%. What that means? It means that if the patient bleeds, we have almost a 14% of probabilities that that patient ends in the ICU. For leak, it was 7.5%. Any leak carries a consequence, an ICU admission in 7.5% of the cases. VTE, almost 5%, and pneumonia, 4.2%. And I want you also to look at the mortality. Any of our patients that had a VTE, it carried a 17% of risk to end in the ICU. 70% of mortality. Bleeding, 5.5%, and leak, 4.3%. And the authors concluded that the main outcomes were that bleeding and leak, as I showed you before, were the complications with the largest overall effect on not only on ICU admission, but also in end organ dysfunction reoperation. Also, they highlighted the importance of targeting the reduction of post-op VTEs because it was the highest relative risk factor for mortality in the bariatric surgical cohort. Several studies have also tried to figure out the risk factors for an ICU admission. Those were described in the studies by Helling, by Polos, by Truss, and basically advanced age was one of the commonest. Male, gender, the higher BMI, it means patients with super obesity, BMI over 60, and those patients that required the longer intubation times, all these were more prone to end in an ICU. Which factors are associated with length of a stay in the ICU? This is a study that I participated with my co-fellow, David Frolich. This is back in our times in Ohio, in Cleveland. We evaluated, this was a retrospective study. We included all patients that were admitted in the ICU in a 7 years study period between 2006 to 2013. We identified 124 patients out of almost 4,000 patients that were admitted in the ICU. It means it was approximately 3% of all our bariatric patients. Among them, importantly, 85% of the patients admitted in the ICU were unplanned admissions. So it was the majority of patients we did not plan to admit them in the ICU. Only 15% were kind of scheduled admission in the ICU. The distribution of procedures, keep in mind that it was in 2016, were Roux-en-Y gastric bypass, sleeve and gastric banded, and they were 65%, 15%, and 5% respectively. Also, a total of 15 patients, it means 12% of all patients needing admission in the ICU. And looking at the most common cause for admission in the ICU, it was respiratory failure. It was identified in 35 patients, representing almost 30% of our series. I think that this slide shows you in an easier way the reasons why our patients ended in the ICU. The majority of them because of respiratory failure, 31% of the cases. The second main reason was due to intra-op bleeding, 25%, and the third one, an anastomotic leak. Table shows operative and post-operative data of all ICU patients, of all the patients that were admitted in the ICU. 7 patients, it means 6%, were patients that had surgery by open approach. 6.4% of the patients were those individuals that were converted during the operation. Importantly, reoperations, 39 patients representing 21% of the overall, those patients were admitted in the ICU. Importantly, there were 4 intra-op complications. It means 3.2% of the patients, and finally 5 patients, 5 casualties in the series. If we look at mortality, it happened in 4% of the cases. 3 individuals had cardiac arrest, 1 patient with sepsis at the GJ anastomosis. Yeah, good. And 1 patient with prolonged mechanical ventilation. The univariate analysis in our study showed that asthma and COPD, conversion, anastomotic leak, reoperation, and the time that lasted in between the OR to the patient to be transferred to the ICU were independent risk factors for ICU admission. Finally, I'm going to finish, if the chairman allow me to do that, highlighting this multi-center study. This is a study that was conducted in Australia, also trying to investigate the incidence and risk factors of intensive care unit admission. Now, this was a national database of the Department of Health in Australia. It included more than 12,000 patients. Here you can see the reason why patients were admitted. Those were statistically significant risk factors: male, gender, again, advanced age, revisional bariatric surgery. And the importance of this study to me is that the authors proposed a nomogram. A nomogram is a visual diagram that combines also numerical data and that plots you where the patient risk category for an ICU admission is. Let me show you with this picture. So here you have the points, so the points that each patient has. If the patient had any respiratory abnormality, it was yes or not. Yes was 70 points. For diabetes, yes, no, yes was 30 points. For sleep apnea, no, yes, 60 points. Revision, a total of 100 points. And open surgery, almost 50. So the authors calculated the total points that had the patient. For example, let's see, the patient had revision surgery plus OSA, 160 total points. It means that the probability of having admission in the ICU was, as you can see, 160 down is almost 40%. 44%. So this is a way that the authors can exactly figure out which patients had at higher risk for ICU admission. This is my last couple of slides. I believe that bleeding and leak are the main contributors to ICU admission. It is fundamental and paramount that quality programs and institutional protocols have to be implemented in order to decrease all adverse events in bariatric surgery. Also, it needs to be mentioned that patients admitted to the ICU after surgical anastomotic leak, reoperation, or conversion to open surgery should be a high risk for extended length of stay in the ICU. And finally, of course, early diagnosis and transfer to the ICU may reduce ICU length of stay. I kindly invite you, all of you, to visit us in Abu Dhabi. By the end of March, we have the 4th Digestive Disease Symposium and the 3rd Diabetes, Obesity, and Cardiovascular Diabetes Summit. And I think that with this I conclude. Thank you.
Dr. Osama Sani wants to ask a question, so we'll allow one question because we are running very late.
Can you elaborate on the primary respiratory failure? Because to us, can you elaborate on the primary respiratory failure as an indication for ICU admission? Because if you say somebody is tachypneic on the floor, etc., we assume that they've had a complication, missed for a while until they became tachypneic and failed the respiratory. I mean, you isolated bleeding and leak. So what are the causes of respiratory failure happening, causing the patient to come back to the ICU?
If I understand the question, you want to know more about why we categorize these 30% of patients that had respiratory failure that ended in the ICU. That includes exactly all patients that had any sort of acute respiratory distress that ended with the patient, or intubated, or with respiratory insufficiency that was not able to be controlled in the floor and ended in the ICU.
No, Dr. Osama Sani's question is that patient with leaks ends up with respiratory failure, but you actually separated leak and separated respiratory failure. So is that a pure respiratory failure?
Yes, it
bleeding,
is. No.
Without leak, without VTE?
Yes.
That's interesting.
Yes.
Yeah,
that's very interesting.
One small thing, because this is very important to separate. Do you put those patients who need extensive monitoring separate from those who need ICU treatment?
So 80% of the patients, the admission in the ICU was not planned, 85% of them. So those patients were not put on intensive monitoring after surgery.
I think we need to conclude here because we are running late. We can continue the discussion in the break. Thank you, Dr. Rika. Dr. Hanan? Dr. Hanan is coming. Dr. Hanan Al-Ghamdi is our next speaker, and she does not need me to introduce her. She's a well-known bariatric and hepatobiliary surgeon. She is an assistant professor of surgery at the University of Dammam, and she will speak, Dr. Hanan, about biliary complication after bariatric surgery.
Dear colleague, Organizing Committee, Society of Obesity, thank you for giving me this opportunity to present another controversial issue and subject that hopefully at the end will agree in principles. So my talk is about biliary. Mostly I will talk about gallstone disease and some complication post-bariatric surgery. In busy practice, most of us face this. No conflict of interest, except I am a hepatobiliary surgeon, and this is a mix of cases. By the end of my presentation, hopefully we'll put XO in this schedule, a different scenario that we are facing when we are dealing with the bariatric surgery and gallbladder. Important facts that there is in patients with obesity and rapid weight loss for any reason, but particular for bariatric surgery because this is what we are doing, there are a risk factor for developing gallstones, and there is increased incidence of biliary complication. In specific procedure, like in bypass, there is change of anatomy, and this is impossible for conventional intervention like ERCP. Therefore, there is a need for specialized services which incorporate a team of interventional radiologists, gastroenterologists, and hepatobiliary surgeon. In this talk, I will divide my talk in this manner. It was because of this beautiful study done by Gustafsson. What he did during bariatric surgery, he aspirated the bile from the gallbladder. It was normal gallbladder. And at post-operative, after bariatric surgery, when the patient lost weight, after 1 month to 7 months, he, under ultrasound guidance, aspirated the gallbladder again and found that mucin play an important role in patients who develop gallstones. And this is the change of composition post-bariatric surgery. So how frequently and when do the patient undergo cholecystectomy? A lot of studies try to answer this. This is one of the biggest study by Altieri in 2018, 5 years follow-up. However, the data is an old data. In all the bariatric surgery, there is increased incidence of cholecystectomy, post-bariatric surgery. Surprisingly, Roux-en-Y and sleeve gastrectomy was almost the same. And there is a risk factor by multivariant analysis, mostly the age, the sex, the race, and other comorbidities. So in this study, they concluded that patients should be counseled preoperatively about this risk, and biliary prophylaxis should be contemplated. Change and L in 2015, they presented their data, 3,765 patients. Only 3.6% of the patients post-bariatric surgery developed biliary complication. The mean time was between 1.8 to 1.4 years post-surgery. Complications mostly are chronic cholecystitis in the majority. Interestingly, that most patients only required laparoscopic cholecystectomy in 97 patients, 97%. And the univariate analysis in this study showed that complication of biliary complication are mostly in female gender, advanced aged, cholelithiasis time from bariatric procedure, and in Roux-en-Y gastric bypass. So the indication of for prophylactic cholecystectomy at time of bariatric surgery remain unclear based on this study. The approach to cholecystectomy in the literature and how we practice differs from some school to another. This is the 3 most common approaches, and we'll come to them one by one. The first approach is the prophylactic cholecystectomy, whereby simultaneous bariatric surgery, any bariatric surgery, and cholecystectomy irrespective. There is gallstone or there is no gallstone. So even normal gallbladder. The rationale is based on the increased incidence of gallstones after bariatric surgery, the low sensitivity and specificity of ultrasound in morbidly obese patients. The main concern is the diagnosis of microlithiasis is difficult and the incidence might be higher than expected. And this study by Warney showed that the proportion of patients undergoing concomitant cholecystectomy decreased from 26% to 3.7%. Those patients who had concomitant cholecystectomy, prophylactic cholecystectomy, they have higher complication, more intervention, higher mortality, and longer hospital stay. So this is a retrospective study. The second approach is elective or selective. When you have gallstone, then you do, even if it is asymptomatic, you do cholecystectomy simultaneous with the bariatric surgery. Hamad and et al. Performed cholecystectomy in 16.9% during Roux-en-Y and compared the outcome in those who did not have concomitant surgery, and the result was longer operative time, longer hospital stay, higher major morbidity. There was, however, no specific morbidity directly related to cholecystectomy in this study. The final approach is the conventional. This involves expectant management with or without prophylactic administration of uracil acid. So even without giving it, so you only operate post-operatively when the patient develops gallstone, symptomatic gallstone. The advantage of the approach is that surgery is performed after significant weight loss is achieved, and the patient is leaner and possibly healthier and less complication, as we heard from the previous presentation. No need for more, can be as a case of day case procedure. Only 9.8% of patients after Roux-en-Y without prophylactic required subsequent cholecystectomy. So the justification to do 90% unnecessary or more than 90% unnecessary cholecystectomy with the possible, we know that cholecystectomy, even we heard in the morning, there is higher complication in cholecystectomy than bariatric surgery. So the natural history of patient with asymptomatic gallstone undergoing bypass is very much like the natural history of asymptomatic gallstone in the general population. This nice study is a systematic review and meta-analysis of patient having cholecystectomy in bariatric procedure. And they examined all the possibility, around 44 patient study included in this meta-analysis, whether it's committed, prophylactic, selective, conventional, and the complication. And the conclusion of this meta-analysis that patients submitted to bariatric surgery have low incidence rate of biliary complication and concomitant cholecystectomy, increase the risk of post-operative complication. This is systematic meta-analysis data.
5 minutes left.
5 minutes?
This is not Oman. I saw you there.
Okay. More than enough. So we come to the issue of prophylaxis to prevent the development of gallstones and complication in asymptomatic gallstones. So the use of ursodeoxycholic acid were studied in different study, and this is big systematic review, and we have a meta-analysis also in this subject. And the conclusion was administration of UDCA after bariatric surgery seems to prevent gallstone formation. How effective? We know in a lot of study, it lowered the incidence of gallstone formation from 32% to 2%. Not only that, this is one of the nice study by German, and showed that what is the appropriate dose that you can give the patient to achieve this desirable outcome. And he tested 300, 600, 1.2 gram of UDCA and found that 600 is the optimal dose per day. For how long? Also, UE et al. Showed that BMI is an important factor for the duration of the medication, from 3 to 6 months, depending on the BMI as depicted here. However, we have to educate the patient about the possible side effect of the medication, diarrhea, skin rash, which is tolerable, especially when you have gallstones in patients with bypass, super obese, and you don't want to go there, and he have a lot of comorbidities, and so on. Final topic is about cholelithiasis. It's really an important topic when you are dealing with a discontinuity of the GI system, like any bypass procedure. This is the possible option that you can hear about. You can tell us if there is anything else we can do. Percutaneous transhepatic instrumentation or double balloon enteroscopy, or percutaneous laparoscopic assisted transgastric ERCP, or transenteric ERCP using specialized endoscopist, or CBD exploration by laparoscopy or open by the surgeon. This is the BTC. It's not a new procedure since 1981. BTC and instrumentation. This is one of the biggest study by Nafzat from Turkey. 261 patients with 95% success rate, and some complications, serious complications, 6.8 were depicted here in the slide. Comparing double balloon enteroscopy with the laparoscopic assisted ERCP, this is one of the biggest study I can quote. With laparoscopic assisted ERCP superior to the double balloon. Of course, the double balloon need special expertise endoscopist. This is our data regarding percutaneous, transhepatic or transcystic exploration and of biliary system. For different reasons, we have 15 patients, 2 of them post-bypass. We dealt with 13 patients. We don't see a lot nowadays because the majority of the procedure done, bariatric procedure in our region is sleeve. It's not bypass, but this is the patient. 8 patients we did by percutaneous transhepatic instrumentation, 2 by percutaneous transhepatic endoscopy with the help of the urologist, and 3 laparoscopic exploration. Can you play the video, please?
You have 1 minute left, Doctor. Play the video, please.
Play the video. Okay, this is transcystic exploration in patient post bypass. This is the schedule, and I will leave it there and done. I saved 30 seconds.
Great.
Thank you.
Dr. Khalid Mirza has a question.
Thank you, Doctor. Just question maybe a little bit related. If you have a patient going for bariatric surgery and he has asymptomatic gallstone, are you going to do concomitant cholecystectomy or not?
Actually, she answered this question. She showed lots of study. Dr. Khalina Jawba. She actually showed studies regarding this. If you were not talking with Dr. Bawahab. Don't answer it, Doctor. Next question, Dr. Osama.
I'll just have one comment. I think the upgrade trial is going to give the answer on the symptomatic gallstones.
Symptomatic?
Yeah, because
symptomatic, no.
No, there is the upgrade trial finished just in June. They've done 1,000 patients looking at urodiaxycholic acid effect for taking it for 6 months whether symptomatic gallstones change, because we know ursodeoxycholic acid works well for gallstones.
Yes.
And I think the ones who did before them a randomized control trial, Istamer Al-Baq in Egypt published last month or 2 months ago, they published a reduction by 6%, from 9 to 3% when they gave ursodeoxycholic acid for 6 months, not 3 months.
Yeah.
So I think the upgrade trial will answer the symptomatic, because I think unless we know that symptomatic gallstones change, we probably shouldn't change our practice.
Any comments, Doctor?
I'd like to thank our great moderators. Thank you for your great time. So we'll continue, we'll not stop. Next moderators will be introduced by Dr. Isam. So whoever want to get a coffee, yani one by one, can get his coffee and come back. And we'll continue the session. No break. The coffee is ready. Just please, one by one, not everybody, one by one. We'll continue our session. And you can bring your coffee and drink it. Chatting is not good outside. Yeah, let's go.
So our next session, inshallah, will be continue with the prevention and identification of a treatment. Our guest speaker, our guest moderator, Dr. Badr Al-Hadrami from Oman. Dr. Badr, he is a member and the president of the Omani Society of Bariatric and Metabolic Surgery. He is well known for everyone as they hosted the last Gulf Obesity Society program a few months back. And our professor, Dr. Muhammad Al-Na'mi from University of King Saud University is being presented earlier and with his talk. And finally, I will say, the youngest laparoscopic surgeon in Kingdom of Saudi Arabia, Dr. Muhammad Hammo. Dr. Mahmoud Hammo, Asif.
من تبغى تقدم منه تقدم حقنا مفتي هاي خلاص انا اقدم نايف هو يقدم عندنا مفتي
هاي هو يخليك الآية خليك انت استرك.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. We are going to start this session. So in this session, we have five speakers. Dr. Ali Al-Khammaz, Dr. Naif Al-Anazi, Prof. Adnan Mufti, and Dr. Ashraf Maghribi, and Dr. Abdullah Al-Mas'ud. So I'm going to start with Dr. Ali Al-Khammaz. He's going to speak about management of OAJ MGB leak. So Dr. Ali Al-Khammaz is going to speak about management of OAGB MGB leak. So Dr. Ali Al-Khammaz is a well-known pioneer of bariatric surgery, and he's the head of department in Dubai, Rashid Hospital in Dubai. He completed his training in Sweden, and he is he's certified Swedish board beginner surgery, and he's a good friend of us. He gave us a lot of support in Oman, and actually it's my honor to present him. So, and this beautiful music, he has a very sense of humor always. So this music maybe was a good introduction for him. Please, Dr. Ali, go ahead.
Thank you, Dr. Badr. And I thank the organizing committee. I thank Dr. Ali Muntashri, Dr. Isam for the kind invitation and the generosity. I will speak about MGB leaks. And this is Rashid Hospital. MGB leaks has issues in people's minds. People who does not do MGB, people who does not deal with MGB leaks has some thoughts in mind or had thoughts in mind. And issues about MGB leaks that this is a pretty new procedure compared to the traditional RONY or the sleeve or the bands. There is limited literature regarding MGB leaks and how to treat it. And there is this bile thing. So people talk a lot about biliary peritonitis. How scary is it to have biliary peritonitis? And then the role of stent, that MGB leaks cannot be stented because of the presence of a loop. So when you put a stent, your stent probably will block the biliary limb. This is a very, very interesting French study that came, I think, in 2015. Yes, it did. And here, this group have done more than 2,000 procedures and collected 35 MGB leaks. It's a huge study, and they looked into different aspects of leaks. Their they defined 3 types of leak: the leak that happened at the esophagogastric junction, the leaks that happened at the anastomotic site, and the leak in the tube. They did not report any leak or any perforation in the remnant stomach. They also had a type where they call it undefined type, where they went in peritonitis and they could not see any leak. And they managed those leaks which has identifiable hole, I would say, or a perforation with the stitch and an omental patch, and then irrigation, and all of those leaks has healed well. But I advise people who are interested in MGB leaks to read this study. It's an excellent study. This is the Chevalier group. They reported 17 cases for MGB leaks, and they do convert all of their leaks into RONY gastric bypass. The recommendation of the founder of MGB is to convert to normal anatomy. Now, I will show some cases that we face in Rashid Hospital with different types of MGB leaks. So the first case is a 34-year-old male, super obese, and day 1 post mini gastric bypass with the tachycardia and desaturation and a CT scan that should play by itself. It does not. So I click probably and it will play, yes. So you can see that there's some consolidation in both the lungs, and you can see a contrast outside the stomach there. So we went in, and once we lift the liver, bile comes out, and then the first thing to do is, of course, to have a proper liver retractor in order to see. This is a very early leak. Tissues usually are favorable, so you can dissect out the anatomy pretty easy. And it's contained leak. If you notice that there's no bad peritonitis in this patient. There's barely any fibrin plugs in this patient. So I think this is one of my first ever MGB leaks. So that's why you will see that I kind of repeat myself here and there, trying to make sure that this is the only hole that I need to take care of. And this surgeon, if you noticed, have used non-absorbable stitches to do his anastomosis, strangely. he used Ethibond. I think you see it there. It's obvious that he used Ethibond. It's actually clearer here. So the first thing after doing a wash, if necessary, removing the contamination, if any. You see, there's no big contamination. There's just some bile, and there is the hole. And you see, I repeat myself here, just making sure that it is the hole, and probably also showing it to the assistant and the audience, because usually when you have these leaks, people in the departments wants to come and see. And then what I did in this case, I just put a stitch on this leak, actually a couple of stitches, and then an omental patch and left a drain. And it worked well for this gentleman. Here you can see those are not the hands of Walid Bukhari, so it's a bit shaky. We'll go to the next case. This is a little bit later presentation, but as you can see, there is no tachycardia when we saw this guy, and we don't have a CT scan because we didn't have a CT scan in our system, but he had a CT scan in a CD that we could see, and a CRP suggestive of leak. And the first look is almost like the previous one that we presented. And again, this is, you can see, you will see now that it is more, there's more tissue reaction to the leak. There's more fibrin, but it still is also a contained leak. So we begin always to separate the omentum, identify the anatomy. One of the good things about MGB, like I will mention in the conclusion, that the anatomy of the MGB itself is favorable for reconstruction if needed. So you see there's fibrin plugs here more on the tissue. There's more fibrin stuck to the bowel. There's more fibrin stuck to the pouch. And here there is another surgeon who also uses Ethibond. And then I found out that Ethibond is actually easier if you use the endo-stitch, the endo-stitch. People find it's easier to use Ethibond with endo-stitch. I don't know why. So a leak test is positive. And here I have shown this video in different occasions, and many people reacted that I was, when they were polite, they were saying too brave. Those people who were a little bit serious, more honest, said that this is crazy to stitch such tissue. I actually test the tissue by the stitch itself. If the stitch holds, then I don't care if it looks a little bit beige in color. If the stitch holds, then the stitch holds. And stitch did hold in this case. But this case, as you have seen, it has more than one leak. So probably this surgeon was not tightening his anastomosis well. This stitch in particular, people reacted to. Of course, it's easy now to be wise and say, see, it was a correct decision to do so because I know the result. I think I would do it again if I face this again, because like I said, if the test of the tissue is not the way it looks, it's the stitch itself. If it holds, when you tighten the stitch, does not cut through, then probably the tissue is good enough. One of my teachers in laparoscopy used to say, slow is fast in laparoscopic surgery. So it looks slow, but does not take much time at the end. Of course, I'm defending my suturing now. And I actually use a 50 cc syringe to wash instead of using the irrigation. I use a 50 cc syringe through different ports to do the wash because I can have a stronger stream than the one I have in a 5 or a 10 millimeter suction device. And then I wrap the, I did that in the first case also as well, and I did it in this case as well, that I wrap the omentum around the leak area. I already took a stitch on that far side of the omentum, and then this part, and then I just when you do so, the common channel of one anastomosis gastric bypass tend to go to the other side, and did that in the first case and did this in this case. That's why I fix it to the antrum, because otherwise it will cause a twist on the anastomosis, and twist in MGB or one anastomosis gastric bypass is a complication per se. So that's why I try to make the common channel of the one anastomosis gastric bypass into the right side of the patient.
Dr. Ali, you have 2 minutes more.
Perfect. So we can skip this. This one is a bit later, and we actually started with a CT scan. I'll skip the CT scan and show you this one. You can see this is a contained leak between the pouch and the ruminant stomach, and you can see the air fluid level in there. So this was not my case. Another consultant was handling this, and he decided to do an endoscopic drainage. So he went in from the leak side. So this is endoscopy. This is not laparoscopy. So he went inside in the pouch, cleaned it 2 times, irrigated, cleaned it 2 times, and it worked for him. I have 4 other cases in the esophagogastric junction, whereas all of them eventually stented. The one who stayed longer healed with 2 of them healed with the gastrogastric fistula, like the one I will show here. You can see now, this is, you can see a contrast in both the remnant stomach, duodenum, and the pouch and small bowel. So MGB leaks or one anastomosis gastric bypass leaks is not like sleeve leaks. I don't think it's like Roux-en-Y gastric bypass leak. It's more like perforated DU. It's more like small bowel perforation. It is not scary. And yes, you can stent it. If you have a good endoscopy, you can reverse it to normal. You can reverse it to Roux-en-Y gastric bypass. You can drain and stitch. You can just irrigate if the hole is not as big or it's very, very tiny. So in conclusion, it's easier to manage, and the long pouch of the one anastomosis gastric bypass make it easier to negotiate with this type of leaks. And the reason I think it's easier because the stomach has good supply and the loop has a full arcade. I don't know if hitching is protective, but none of the cases that we handled had ever had hitching. And the high pressure system theory in sleeve leaks, I don't know if it holds because the leaks that we had in MGB in the esophagogastric junction, despite being very low pressure system, also were persistent and were bad. So thank you very much for listening.
Thank you, Dr. Ali. We'll allow for questions. Dr. Osama.
Ali, I think your first statement that MGB leaks are not like sleeve leaks is true except in one situation. If you had a patient who had a sleeve and came for a mini bypass and you had a leak at the AG junction, then that's when you treat them like the sleeve leaks mainly. And I had one of this scenario, and what we did, Roux-en-Y and feeding in the common limb with a feeding tube. I we just left that. 2 weeks later, even with the patient, continuous leak, I fed the patient. And the funny thing is, I just give them a fluoro study. And if they still have a hole, but they're not leaking through it, and they have a drain, then I just feed them and let them go and come back after a month and it closes.
Why did you do the Roux-en-Y then? Why did you do
I just diverted the bile because the bile does go back.
Okay,
In those
because of
patients,
that bile,
when
yeah.
you have an infection, etc., you can never guarantee that the bile will not go back. I mean, even when you don't reverse, if you just divert the bile away, patient do well. And you want to feed them in the distal.
Yeah, thank you.
Thank you. Dr. Ali, thank you very much for sharing your experience with us. I have just a few comments. As our experience in bypass, whether Roux-en-Y bypass or mini gastric bypass, now we reached to 15 years, since 2005. I want just to emphasize for all surgeons who can look, inspect after the side-to-side gastrojejunostomy, the last 2 to 3 staples at the end is weak. And some of have stapler disruption. For that reason, as I can tell from the 2 videos you present, the leak site was actually posterior and lateral, whereas the weakness of the stabilizer. For that reason, when we thought we did methylene blue, some of.
What do you mean first by last? You mean the last firing or last
in
down?
when you do, we do by 30 millimeter gastrojejunostomy.
Yeah.
We use the blue, whatever, echelon or covidia.
You mean the anastomosis?
The anastomosis, the stapler at the end, not the gastrostomy, where you will repair. The end of the staple, inspect, you will find it weak in all. Whatever the company, still the weakness in that 2 last or 3 last staples and the potential to leak by a time. For that reason, actually, before we have the leakage rate 2%. After we change our technique to 36-degree suturing, reinforcing that weak point, we start from that weak point and we continue reinforcing, we have a 0 leak in that area. So I think doesn't matter whatever you use, endostitch or needle holder, ethibond or Vicryl, it is the matter of the error in the stapling that manufacturer, they didn't solve it till now. This is number 1. I totally agree with you 100%. The surgical technique and the loose suturing is an important factor. For that reason, the skills of the surgeon who will do this procedure should be perfect. And I totally agree with you, as the old said that there is no rule of a stent in mini bypass. I don't think this is true. I have one case which I managed with the stent, but we choose the stent which is partial cover.
Esophagus stent, not bariatric stent.
Yes, partial covered esophagus, which is from Boston Medical. That it holds. That's a case of a revision from mini bypass, from sleeve to mini bypass, and we restrict that. you assured that but by restriction that the lumen of the pouch was narrow, so it held. It didn't migrate. Thank you, Dr.
Thank you,
Ali.
Dr. Ahmed. We'll thank also Dr. Ali Khamas for his nice presentation. May I invite Dr. Naif Al-Anazi to come up to the podium. Dr. Naif will present the portomesenteric thrombosis after sleeve gastrectomy. Dr. Naif is a graduate of King Saud University. We are very proud of him. And he did his general surgery fellowship in Riyadh. Then he went to Canada, where he did 2 fellowships, one in Mount Sinai Medical Center and one in Sacré-Cœur Hospital, where Dr. Pierre Garneau works. And he is also smart enough to take a master's degree in healthcare management. So one day he will be a CEO in Prince Mohammed bin Abdulaziz Hospital. Dr. Naif, please.
Thank you very much. Today we're going to talk moving from leak to thrombosis. So I'm going to share with you the 3 cases that we had as a portal vein thrombosis ended with X laparotomy, and there is no disclosure. As a background, the utilization of sleeve gastrectomy for patients with a morbidly obese is rising, and contributed of sleeve gastrectomy to be an effective weight reduction and improve of quality of life. The increased sleeve gastrectomy for patients with morbidly obese urged the surgeon and practitioners to check for the post-operative complications. DVT, pulmonary embolism, hemorrhage, and anastomotic leak are commonly reported as a complication post-sleeve gastrectomy. The portal vein thrombosis is a rare complication for sleeve gastrectomy. However, it could be obvious impact on patient outcome and survival. It's infrequent event associated with a high rate of morbidity and mortality. We're going to share with you the first case that we had. She is a 43-year-old a lady with a BMI of 37. She's presented to the emergency department with a severe abdominal pain 1 day prior to arrive to the emergency. She had a history of sleeve gastrectomy 2 weeks prior to the arrival to the emergency. White blood cells was 37,000, and CT scan was done, showed superior mesenteric vein thrombosis, portal thrombosis, and splenic vein as well. So with a combined extensive small bowel ischemia. Diagnostic laparoscopy carried out and confirmed the finding, then X-lab was done. The second case is 22-year-old with the male with the BMI is 38. Patient came to outpatient clinic with coffee ground vomiting, melena, and abdominal pain. Patient sent to the emergency department, and he had a history of sleeve gastrectomy 2 weeks prior to arrival to the clinic. The white blood cells, it was 29,000, and CT showed bowel ischemia secondary to the portal vein thrombosis that has been confirmed through laparoscopic procedure. X-lab as well done, and ischemia found involved 2 meters starting from 10 centimeter from DJ. So the third patient, 34-year-old female with the BMI 49. She came with a history of constant and diffuse abdominal pain that progressed in severity over the past 3 days. She had a sleeve gastrectomy 1 month prior to the arrival to the hospital. CT showed extensive portal vein thrombosis with splenic infarction. Patient was treated conservatively, dressed with a heparin, warfarin, then she was discharged home with a follow-up with the primary physician. As you can see here, this is the CT scan for the patient, one of the patients before arrival on admission to the emergency department. You can see there is portal vein thrombosis and severe mesenteric vein. Here is the X-lab showed the extensive bowel ischemia. this picture after the anastomosis. And CT scan showed the anastomosis and before discharging the patient to discharging home. As a discussion, you know that bariatric surgery patients are particularly susceptible to thrombotic event due to potential hypercoagulable state. And the hypercoagulability is attributed to metabolic syndrome, which is associated with the increased rate of fibrinogen and coagulation factors. Portal vein thrombosis is uncommon as a surgical complication to bariatric surgeries. In 20 to 35% of the cases, the sleeve gastrectomy remains the primary cause of thrombosis. And the exact etiology is not well understood. And it has been suggested that venous stasis is secondary to enhanced intra-abdominal pressure and operative intervention in splanchnic vasculature and hypercoagulable state are possible causative factors for portal vein thrombosis. Protein C and S deficiency, homocystinemia, prior abdominal surgery can play an etiological factor. And experimental studies deduced that the intra-abdominal pressure produced during laparoscopic surgery have inverse relation with the blood flow within the portal vein, which in turn prepare for the thrombus formation. The release of vasopressin during operation, reverse Trendelenburg position, and elevation of portal venous pressure in response to retained CO2 may also contributing factor. In our cases, main risk factor was severe dehydration and improper duration of prophylactic anticoagulation time. There is a study that suggested sustaining of pressure of 14 millimeter mercury could affect the mucosal blood flow in experimental animal model. And the study showed that inverse relationship between intraperitoneal pressure and portal blood flow, because an increase of intra-abdominal pressure beyond 14 millimercury is enough to reduce portal venous flow by 50%. And it's not the direct pressure alone that might predispose to thrombus formation. And carbon dioxide can cause sympathetic vasoconstriction through the release of vasopressin, which eventually reduce the venous flow and increase the risk of thrombosis. Although the portal vein thrombosis is a lethal complication post sleeve gastrectomy, the diagnosis is very deceptive owing to non-specific complaints. The patient may experience abdominal discomfort or pain, fever, vomiting, nausea that can be as well asymptomatic and discovered accidentally through radiological examination. The presented cases had a severe leukocytosis, disturbed vital signs, and physician might also encourage to mild raising in liver function test. However, laboratory values fall usually within normal limits. CT scan can also detect the portal vein thrombosis with a sensitivity of 90%. So the implication of laparoscopic exploration for a diagnosis of portal vein thrombosis remains controversial. Shaw and his group support the diagnosis of laparoscopy by all means, irrespective of clinical condition or laboratory findings. On the other hand, Kumar and his group oppose the laparoscopic exploration for the diagnosis of portal vein thrombosis because it may compromise the mesenteric blood flow. However, Swartz and his group suggested that the extent of bowel ischemia could not be accurately determined by CT scan alone. Therefore, to determine the exact magnitude of bowel ischemia, a combination approach should be used, which involves both radiological investigation and laparoscopic exploration. There are several treatment options for portal vein thrombosis based on the degree and severity of the thrombus, which include oral anticoagulant, thrombolytic therapy, and thrombectomy using tissue plasminogen activator. 60% of the patients receiving thrombolytic therapy develop major complication. And if there is evidence of bowel ischemia, the laparotomy is better than laparoscopy because of insufflation of the abdominal cavity with gas will increase the pressure inside the mesenteric veins, in addition to extensive bowel edema and abdominal distension that make the access of laparoscopy is difficult. And the advantage of prophylactic anticoagulation given routinely after bariatric surgery is accepted to a large degree. Both low molecular heparin and unfractionated heparin can be used in bariatric surgery. However, until now, there is no strong evidence regarding dose and duration of prophylactic heparin. However, it's noted that there is no data demonstrating a relationship between deep vein thrombosis and regarding pathophysiology, prevention, management, and complication. So the deep vein thrombosis prophylaxis given for surgical patient can be used in portal vein thrombosis. The conservative treatment with the standard anticoagulation therapy is usually applied for patients with portal vein thrombosis and can be entirely lead to a thrombus resolution in a mild to moderate cases if there is no bowel ischemia. There are retrospective studies reported that patients with acute portal vein thrombosis treated with anticoagulation that showed partial recannulization of the portal vein occurred up to 93% of the patient, while complete recannulization occurred up to 45%. The guideline, most of the society that recommend the regimen of prophylactic heparin following bariatric surgery that include intermittent pneumatic compression device in addition to subcutaneous injections of heparin, either low molecular heparin or unfractionated heparin. Deep vein thrombosis prophylaxis for a long period of time should be given for all patients with a high risk factors, such as patients with a past history of DVT. One of the methods for DVT risk stratification is modified Capellini score. With application of this score to our patient, most of them were at high risk. In comparison to Roux-en-Y, portal vein thrombosis is rare and has a fatal consequence, but the record cases are less than reported after sleeve gastrectomy. In spite of both procedures having the same risk factors, presentation, onset of diagnosis after surgery, and management result, there is no elucidation for contradiction. Gandhi and his group recommend
You have 2 more minutes.
I have 2 slides. Recommend 3 to 6 months of anticoagulation, which can be extended further if there is a sign and symptoms, if the signs and symptoms persist. And another study suggests a longer duration of anticoagulation therapy ranging up to 12 months. However, patients with systemic etiology are required to be on a lifelong anticoagulation therapy. In conclusion, patient undergoing for sleeve gastrectomy, he might experience of portal vein thrombosis few weeks after the surgery, and the diagnosis of portal vein thrombosis after sleeve gastrectomy required high indexes of suspicion because patients usually present with vague signs and symptoms that are difficult to detect early. Therefore, the healthcare professionals are encouraged to consider portal vein thrombosis in the differential diagnosis. Thank you.
Thank you, Dr. Naif, for this nice review. Any questions? Yes, Dr. Naif.
Thank you, Dr. Naif, for this review. I have a question that I don't have the answer, and I didn't find the, let me say, the answer that could make me convinced. Why the incidence of portal vein and superior vein thrombosis is higher in sleeve gastrectomy so far more than any types of bypass, either Roux-en-Y bypass and many bypass? This is the first question, because the only finding that I see gangrenous bowel in the bypass cases was in the cases of internal hernia due to obstruction, which is mechanical obstruction to the vascularity.
Okay, let him answer this first question. And then.
Thank you for this question. Actually, I don't know the answer. And yesterday, I was talking with Dr. Subhash Kini about this situation. I had 7 cases who ended with portal vein thrombosis and bowel ischemia that he needs to be operated on. And he's the same, he mentioned there is maybe like up to 20 cases with portal vein thrombosis, but I think 1 or 2 patient who was who underwent for surgery. In my thoughts that either to go back, most of the patients were on anticoagulant postoperatively, but I think one of the main reasons severe dehydration is playing very good role in creating thrombus. This after the sleeve gastrectomy, because we are making the, as you know, the sleeve is very narrow, so patient will not tolerate taking the fluid in normal way. That's different from gastric bypass. That's my explanation. And I don't know, I need to hear from the audience what could be the possible of thrombosis after sleeve.
Okay, yes, Dr. Khalid. And then Dr. Walid.
I think in addition to that, which have led me to master the art of doing sleeves or actually laparoscopic surgery with 3 ports without a liver retractor, no matter how big is the liver, either large or small, floppy, fatty, or otherwise, is that there was a publication from Cleveland, Phil Shower, about the role of liver retractor in causing SMV or portal vein thrombosis.
Okay, so you think it's because of liver retraction?
It could be an added cause.
Okay.
With the dehydration, of course, I agree 100%.
And the other factors.
And there is no consensus, as Dr. Naif have mentioned, in how do we use the anticoagulants and what is the effective dose and how long should we use it?
Still controversial.
I have used the anticoagulation as Dr. Hammo, and we have used it since we started the bariatric surgery program more than 22 years ago in Prince Sultan Center for 3 weeks. First of all, 2 weeks, and then we extended for 3 weeks. And this is what we're following. And we have seen throughout my experience, 1 portal vein thrombosis that tend to have some embolic already phenomena, the C protein he had that patient.
Dr. Khalid.
Yes, in sleeve, as you see in the sleeve, we are devascularizing the stomach. Devascularizing the stomach, you will affect the portal vein with dehydration. So we have 2 mechanisms different from the bypass. Devascularization of the stomach, severe dehydration, inadequate prophylaxis. In our guidelines yesterday we mentioned, based on BMI, on induction 40 milligrams subcutaneous heparin, we started on induction and continue less than BMI 40 for 2 weeks, twice a day, more than 50 BMI.
So you think the portal vein pressure increases after sleeve compared to after bypass?
Yes, due to
That's a
devascularization.
good possibility,
And
yes.
For if it was a liver retractor, then it should be more in gastric bypass because most gastric bypasses take longer than a sleeve.
Yeah.
In fact,
Yes.
nowadays people are doing sleeves like Dr. Naif is saying in 15-20 minutes, whereas a bypass obviously takes between 1 to 2.5 hours. So if it was a liver retractor, it would be the case. And when we looked at it in Mount Sinai and NYU, the cases were put together.
Get close
they
to the
were
microphone,
all,
please.
They were all sleeve gastrectomies. They were not one was a gastric bypass. And
Okay.
between the 2 centers, there were 2,000 bypasses.
Excellent.
done.
Let's hear another opinion. Yes.
Yeah, there is another hypothesis that devascularizing the greater curve with sleeve gastrectomy has a thermal effect on the blood vessels, which gives a low effect, gives some effect on doing some coagulation in these small vessels and propagate to the portal vein. And we did a study in our university comparing putting a vascular clip before using the energy device compared to other patients who didn't use the energy device alone. And we found out that the patients we did a clip on the vessel before using the energy device, they didn't have in this group any kind of portal vein thrombosis.
Okay.
So there is hypothesis that you put just a vascular clip before using the energy
Okay,
device.
I think we'll stop here because this is endless discussion. We thank Dr. Naif and we'll move to the, thank you so much. We'll move now to Dr. Abdullah Al-Masoud. Is he around? Yes. Dr. Abdullah Masood, General and Bariatric Surgeon, a graduate of King Saud University. Again, we are proud of him. And he's been working as a bariatric surgeon for more than 18 years. And he got his fellowship in bariatric and minimally invasive from Canada. And now he is having a good experience, as well as another fellowship in abdominal wall reconstruction and recurrent incisional hernia. So if you have also complex hernias, send them, please. Thank you. يا دكتور عبد الله تفضل.
Thank you, Prof. Muhammad. Bismillah wa salatu salam ala Rasulullah. My talk is mainly oriented to bariatric surgeons in regards to the multivitamin. It's not a textbook lecture. So my overview today will be simply talking about an introduction, our current statistics in multivitamin among different bariatric surgeons in the region or in the country, our patient dilemma, local market options matching ASMBS recommendations, which is more important, pre and post weight loss surgery vitamin deficiencies, and finally a conclusion. So I have no disclosure to start, and as an introduction, a patient after bariatric surgery might have some nutritional issues from minor to major. Optimizing the post-bariatric post-bariatric outcomes starts actually before the surgery. Screening the patient is important. However, it's not the norm in the vast majority of practices. And patients should be educated before and after surgery as what's going to be expected. The data showed by evidence that the micronutrient deficiencies increases with time after bariatric surgeries. However, the screening or the surveillance is decreasing at a contradict. This is an important slide showing what we do. So among surveilling our colleagues, the participant was 40% of the national bariatric surgeons. 80% of them, they prescribe correctly B12, and the vast majority, we prescribe on an average 50% of the other multivitamins. So why this happened? Next thing is the patient dilemma. This is how some or might be the case of some of our patients in the social media. Questioning. So from the 80s, the cartoon of Popeye was so famous. And Popeye, whenever he's in trouble, he uses his spinach. So is there any similar to spinach with Popeye for our patients? Answer is no. So let me make it more scientific. Is there any single pill multivitamin tablet enough? Answer is no. Why is that? First, the iron sufficient supplementation on daily basis, it makes a bad taste of any multivitamin tablets, which is reflected by the market. Market is driving everything. So bad taste, less compliance, finally, less sales. So there is no single tablet. Second more important thing, why does it contain, is there any tablet contain enough D, B1, B12? The answer is no. Why is that? Just to make it simple, the weight of the tablets will be too large, meaning you need a tablet that contains everything like the spinach with a USP size. Nobody can swallow it. So this is the local market options matching ASMBS update recommendations. So I'll go to further details on the highlights on pre and post weight loss surgery vitamin deficiencies. B1, as an example, thiamine. 1/3 of our patients, before touching them or operating them, they would suffer from this problem. And close to 50% would have this issue. Keep in mind that there are some high-risk group even on your patients after surgery, especially females, dark-skinned people, and anyone with GI symptoms, meaning nausea, vomiting. Not only that, even constipation might ring a bell in you once the patient is suffering from it, that it might be a thiamine deficiency. Again, a highlight on B12. B12 carries the same risk before operating the patients and afterwards. What I would like to address is the reflux. We have a reflux, 2 lectures ahead of me. So whenever you are prescribing proton pump inhibitors, Nexium and others, think that it would augment the risk for B12 deficiency. Iron, at least near to half of the population of obesity patients, before operating on them, they have an iron deficiency, especially females. And what happens after surgery is between 20% to close to the initial percentage. So how much patients need? This is an important question. From B1, the need is 50 milligram daily with whatever restrictive or malabsorptive procedure. From B12, 500 mcg daily. If we think of the common in the market replacement, which is Neurobion, which contain only 200 mcg. So you need at least 2.5 tablets. Is that too much? Yes. So instead, you can give the 1 gram on monthly basis as an injectable form. Folic acid, the patient needs at least 1 gram, and then the iron with the range of 18 milligram for the males and 3 times that amount for the females, especially for restrictive procedures. Risk. When I did the surveillance among my colleagues, some of them would write, I would prescribe so-and-so, let's say Neurobion, after 1 month. Is that appropriate? Think of a simple thing. The half-life of B1 and B12 is short. B1, it needs only around 2 weeks to vanish. And B12 needs only less than 1 week. Again, not prescribing any kind of vitamin B complex supplementation is alarming a real risk. Back again, the spinach of the prescriptions that I saw it in the survey is Centrum, whether Centrum Silver or Centrum Ordinary. It's not a spinach, please. It has a very trace amount of B complex. So the amount of B1 is 1.4 milligram. It's nothing. B12, iron, even the iron. Most of our patients complain from the bad taste, intolerance to the multivitamins. So they ask so frequently, can I take gummies, especially the pediatric gummies? Please, the answer is big no. How to overcome the bad taste of spinach? Again, the Centrum, crush it, add it to any kind of yogurt, flavored yogurt, with a brand of Danate, gelatinous material, anything. It will be better tolerable. The calcium supplement, whether Caltrate or Caltrate Plus, that has the advantage of the zinc, is good, and think about 2 tablets each day. The reason is to achieve the daily requirement, which is 1,200 milligrams. Bericol is an expensive multivitamin supplementation. It's good, excellent. However, some patients might hesitate to buy it because of the expensiveness. The Berry Life as well, it has an advantage of a good taste, better compliance, though it's expensive. This is my conclusion. So for a sleeve gastrectomy, the recommendation is 1 tablet from the multivitamin spinach. Add the vitamin D, please. Add the calcium in any form that you want it. Please don't forget the Neurobion. You can, for the bypass group, the addition of the iron supplementation is needed. Thank you very much.
Thank you very much, Doctor. We have only 2 questions because he was in time, and we appreciate this. Perhaps you are the first one. Any question, please?
Just one comment. Did you study the Fit for Me product, the product Fit for Me?
Feed for
Feed
Me.
for Me. Feed for Me.
I don't know it, and
Yeah.
it's not
Yeah,
available in our
I'm
market.
using
That's
it
why.
for the last 3 years, and I do routine investigations for my patients. Usually, most of the one anastomosis, because I do a lot of one anastomosis, so I have anemia. Like 10% of them have anemia with the Fit for Me. But for the rest of the patients and for the sleeve patients, I think it's working good with them. Of course, they have the point of the taste of iron with the one tablet, because it's just one tablet for sleeve patients per day. But till now, it's proof for me with the investigations is very good. So I recommend you to try it. I have no conflict of interest with them. I don't work with them, but I tried and it works very well with the patients. It's just one capsule per day. Fit for Me. Fit for Me. It's from Netherlands.
So what do you think about the duration? For how long we should keep using vitamins or advising to use vitamins? 2 years, 3 years for sleeve bypass? What do you think?
No evidence yet, even in the ASMBS 2016 update that was published at the end of 2017. So whether to give it 3 months, 6 months, 1 year, years, the answer I don't know. The latest ASMBS update in regards to the micronutrient supplementation, they did not mention it, so it's unknown.
Thank you very much, Dr. Thank you.
One more question.
Yes, please.
Dr. Abdullah, here in the moderator side. How frequent you do the blood test for the vitamins, to check for the vitamins? Because also there is a lot of controversies about how frequent you should do the blood test for the checking for the vitamins.
Evidence-based, there is no guidelines for such thing. In my practice, on 3 intervals for sleeve, 4 intervals annually for the malabsorptive procedure. If I'm talking about the sleeve, 3 months, 6 months, and 1 year. And I might add a 4th one based on the abnormal labs. For the bypass group, it's 4 intervals at least for the first year, and then annually afterwards.
Thank you.
Thank you very much. Thank you. Now I have a great pleasure to present Professor Adnan Mufti. He is the only, perhaps from the rare colleagues here, I can talk about him because we know each other since 90s. Perhaps we didn't like to say so, but early 90s. And he is, I cannot, no need to talk about his background, but I talk about how he is give what he know. And this is a great thing to professor title is this point. And thank you for whatever you gave for all the generation, and welcome to your talk.
Thank you, Mahmoud. Thank you. It is my pleasure, and really I am honored to know people like you and like all of you here with us. This is a last-minute lecture, which I was called last week by Ali and then they want something on the strategy. What you want to do with the strategy? They said, insist they want to do something on the strategy of how to manage the complications in bariatric surgery. Of course, we suggested that we keep it to the end, so everybody has presented you with the scheme, the type of complication, how to manage it, and you will have another session after this where more complication will be elucidated. You've seen the management of the complication from the heroic surgery Walid is doing to the large pills Abdullah is prescribing for how long, and you've seen the controversy in that. So, my philosophy how to do that, and I must thank my daughter Sarah, who is a final year law student in Prince Sultan University. She is the one who helped me to do this lecture and made the animations and the things. So if there is anything you don't like or is not right, it is her fault, not my fault. Okay, let's go in. So we are talking about how to build and my talk is not for the senior people like all of you here must be, but mostly to the our fellows, the young generation, and in particular to the accident and emergency department, physician, and the general surgeons. The general surgeons, quite a lot of them who are practicing some bariatric surgery or probably just sleep or maybe more, they are comfortable to do the procedure, but they are very uncomfortable to receive a patient who is obese, who had surgery somewhere, and he's presented to them with some complication. This is how they will protect themselves against medical incompetence or malpractice suit and things like that, and in overall, how to help this patient who had the procedure not to go into a very serious. So, bariatric surgery is the one proved to be the most viable treatment for morbid obesity. This is why it is liked by everybody. They want to do it. And it is more than that. You can see how the effectiveness of the procedure with the others. If you come to talk with the pharmaceuticals, and you've seen less than maybe 5% or 6% until you reach to the golden, powerful procedure of the DS and BBD. This is how it when you treat the things. So what is special about the bariatric surgery? What features are special with these things? One, it is one of the fastest growing procedures in the world now. Every day there is a new procedure, and you've seen and you heard a lot of things. Significant improvement in the performance. You're getting more skills, you're getting finer and better instrumentation, and here we are. And the experience, you are dealing with very difficult issues. This led to a unique complication that may arise in this type or this population of patients. They are not like all the other population. No, they require specific knowledge for you to manage their complication, okay? Above all, what we are doing, we are altering the normal, or whatever you will call it, the usual anatomy of the human being and some physiological issue, and this is why we need a different strategy for this procedures. What about the operative procedure themselves? Now we are having shorter stays. You heard people saying we're doing a day case procedure. Some of them, they are discharged 7 hours after the procedure. So, and others take, but the hospital stay is taking shorter and shorter with all the proper management and ERAS. And the complication also, if you compare it to others, you heard them, maybe the complication or the mortality is less than the appendectomy and cholecystectomy. Why? Because you are getting more experienced and the patient are prepared and managed well. Successful weight loss. We are getting very good result from this point. Although there is a weight gain, there is other, but the procedures are producing a successful weight loss, and they need some lifestyle, better cost effectiveness, and this is no doubt about it. This is the value of the bariatric surgery. And the complications are relieved or treated or reversed completely. So how you build your strategy to get optimal management for these possible complications. Remember, you have to understand, and I hope that whoever will indulge in surgery, whether he's doing gynecological procedure or bariatric procedure or neurosurgical procedure, he should understand his anatomy before he starts treating the patient. He must know the spectrum of the possible potential complication for the issues. he must have, because we are doing mostly minimally invasive procedure, he must have the availability and of endoscopic and laparoscopic, the tools and the techniques. And above all, he must have the expertise to use them. If he doesn't know that, it is not necessary for us. The risks are really potentially substantial. They could be a lot, especially in those type of patients. This is a special population of patients. So you can find it that the complication or the thing, it is different from my hospital to your hospital, from this procedure to other procedure. So it is procedure, I want you to understand, it is procedure related, malabsorptive component, complication and hormonal disturbances. If we take features of this complication, abdominal pain or peritonitis, and this is the most common complication in bariatric. Patients come complaining of abdominal pain or features of peritonitis. It is usually either an anastomotic leak, stable line fistulation or leak, and usually it occurs early. In bypass, within the first week or first few days. In a sleeve, it may take a little bit longer, but it will occur there. You must understand and always remember that the classical sign of guarding and rigidity usually doesn't happen. You cannot find it, okay? They never present. Simple post-operative tachycardia, this is your serious signal or warning sign, okay? So in emergency setting, when you have some people coming to you, he's obese, he had bariatric surgery, your algorithm for proper management has to change from the other population. Depending on the patient characteristic, how old, how young, what is he? He's a male, he's a female, how much obese he is. All these characteristics are important. What procedure was done for him? And what is your capability? What is your institution capabilities? If they can't, then you have to go think of quick alternative like transfer, and you have to communicate. If the patient had already the surgery somewhere else, you must communicate with the surgeon, or at least with the center where he had the procedure, to understand what is going on, especially in our community. Naif said about portosystemic thrombosis. This is one of the serious complications that you always remember when you have obese patient coming to the ER for one reason or another because he is vomiting. Always think of this complication that he might have this in addition to other things. So always, and if you suspect or there is any doubt about that, go in and do this simple test in order to make your suspicion right or not. So you can ask for proper consultation from hematologist, or otherwise the death rate for those patients once they arrive to you will be higher as you delay your diagnosis. I don't want you to think a lot of like when we say about the chronic leak and things like that, leave it to the expert if you are in the emergency setting. Uncommon complication like vernix encephalopathy, vitamin deficiencies, leave it to them. But you have to manage them or at least assist them and suspect that they have these things and put them in the line track so you refer them to a proper center to do them. If we talk about what Muhammad Bawahab talked, postprandial hyperinsulinemic hypoglycemia. If it comes, you have to treat the initial emergency management and then refer him for endocrinologist or the experienced bariatric surgeon who can deal with him. It is a very difficult complication to treat, but it is treatable and he might need to go for another surgery. Late complication most of the time related to equipment failures, like the bands or or balloons or the infection, intestinal obstruction, hernias, gangrene, all these nutritional, chronic leaks, fistula. In chronic leaks, I don't advise that you deal with them if you are not experienced to deal with a chronic leak. Chronic leaks, although in our experience and probably those in the military hospital, maybe in the university, I don't see Professor Dahayan, most of them, they will respond to the conservative and the stenting and nasogastric. Very rarely we need to interfere surgically, and if we interfere, it will be a simple patching, drainage, putting jejunostommy. To deal with chronic leak with jejunoesophagectomy, leave it to the very expert people. And I tell you, in my experience, we did only one case of esophagojejunostomy in a case of leak with bronchopleural fistula, another, me and Salih al-Bishri, and we failed before that, and we started laparoscopic, and we ended by the procedure completed open, but this depends on the experience and the availability. But only one case. MashaAllah, Walid, he said, probably, I don't know, 100 or so. But so, chronic ones, leave it to those people. Mostly they will respond to the conservative. Weight regain, also, he has to have, I have finished.
Professor,
I
you have only 1 minute.
Okay. The last thing is please remember that patient might come to you in the emergency room or in emergency crisis with emotional disturbance, because these things are true actual complication, okay? Just to tell you that the emotional, the physiological and psychological are combined, and we must look at the patient emotional well-being, okay? These are some of the outlines. This is for the general practitioner, what to do when they have people who are, of course, I'm not talking about specific one, but this is how, in order to, because the aim in order to, in bariatric surgery, we keep the mortality less than 1%, please. Otherwise, everything will come up and become unclear. So be vigilant, minimal denial threshold. So don't deny that the patient is not ill. No, please do. Early efficient recognition of the C's and teams and protocols, communication and exchange of information, and make your intervention early and efficient, okay? Summary of the strategy, this is for you. All are evidence-based. You must have protocol and guidelines in your ERs, and this is how you will save yourself. And accreditation, quality improvement program with plans for collecting your data, monitor your data, and analyze your outcome in order to improve your situation. I think that's...
Thank you very much, Prof.
Thank you.
Thank you very much. Allow me, dear colleagues, since I have the mic, I have the authority.
Yes, good.
Because you raised for us to summarize, if you allow me to say, what we are dreaming to do in I don't know in the other country, but here in our kingdom,
Yes.
We should establish referral centers for expertise to tackle, because the volume of bariatric surgery is above the capability of many centers to do or to tackle such problems.
If you allow me to say something, but I don't want much, but from my experience, I think
Mike, please.
the centers are there and present and they are ready. The problem we are lacking, or the problem we are creating, is the communication. If I have a problem, if I have whatever, say it, bleeding or leak or other something, and I talk to Walid, or I talk to Abdullah Dahan, or to whoever, Muhammad Bahab in the area, please, this is my patient, they will accept them in their center, or in King Fahad. The problem is that the practice of the bariatric surgeons, sometimes they're afraid from facing their complications. So what they do, if the patient, either they don't meet him, they don't accept him, or he lie in the ER of wherever there, and he's there, nobody able to add until his condition deteriorate and he become irrecoverable. If they can, and you, because if I want to send him to Walid, for instance, I have to talk to him. I tell him what is that. Not to, what they tell them, go to this hospital, go to this place, this is a governmental, they will accept you. This is nonsense. Even if I am working in the governmental hospital, I will not take Dr. Haider case if he comes to me, because he did not talk to me, his resident did not talk to me, nobody even cared to do. This is what we have. The centers are there. And I cannot bring a big center and bring super people and tell them you are there just to accept those coming from other way. It doesn't happen. Okay.
Great suggestion. Any two questions only, or one question if you are.
Whatever you say, you are the boss.
Finish? Yes. Thank you very much
You
for
see,
all the
Ali
speakers.
is the boss. We will take one question from the, yes, please.
خلاص, he's the boss, he's the president of the Saudi society, so he's the boss of
Yes,
everywhere.
please.
Thank you very much, Prof. This is a presentation of wisdom and experience. With the comment of Dr. Hamu, I think what we are needing is to have from the society a clinical pathway or a clear guidelines for those patients whom they are coming in the real emergency situation. This is very important, and we are seeing patients coming from outside Saudi Arabia in a very bad shape. I'm dealing with obesity center in the north, and so we are doing this clinical pathway. What we needed is to deal with the patient according to the time frame, more than, secondly, to send him to a dedicated center. Thank you very much, Prof.
I cannot agree with you more, but I will tell you. The guidelines are there, it's present, published, and you can use it. The clinical pathway, I think it is important that you yourself develop your clinical pathway or roadmap for your institution, and that's it. But it needs effort from you. And if you need help, the help is available. You can call Haider, he will be able to. You can call Naif, you can call anybody, and they can help you. I mean, different institutions, they will help you with that. But the guideline is already there for the emergency and for the chronic and for if you want to practice bariatric. Is that, thank you, Naam. Thank you, Badr. Thank you, thank you.
Assalamu alaikum. Thank you for the great faculty and for the great moderators. So we need the moderators of the next session, please, to come to the stage. دكتور سلمان الصباح، شيخ سلمان، دكتور باسم عثمان، مين كمان دكتور مين؟ دكتور عصام عطية، حياكم الله. طيب, so this is the interesting session, which is the video session. Session will be 8 minutes, please. 8-minute maximum. Discussion 2 minutes if allowed. For those want to go to Jeddah, Old Jeddah, downtown Jeddah, Jeddah Tarikhiyah, there will be a bus at 5:30. You can gather 5:30 in front of the registration area. In the registration area, then the bus will take you from there around 6. We'll be back 8:30. The gala dinner will start 8, inshallah. Gala dinner will be at 8. Everybody is welcome. There will be cultural band, مزمار ومبعاوي ومجس وكل حاجة يعني. You are more than welcome. المكان في الهيلتون، مطعم تحت مطعم السفينة، برا في السويمينج بول في الخارج. It's outside. It's around the swimming pool. The gala dinner will be there. Okay. It's will start at 8. Dinner will be served around 9. So when you come tomorrow, we have another session in the morning. So we need to finish by 11. So everybody will go take a rest. Last thing for members of Saudi Society of Bariatric Surgery, members of Saudi Society, please, you can stay at the hall. After we finish the last session, we'll go ahead for the General Assembly. We'll give you a brief of our talk, okay? Go ahead.
Bismillahirrahmanirrahim. I would like to welcome our first speaker in this session, Dr. Khalid Mirza. Of course, Dr. Khalid Mirza is our senior consultant in laparoscopic and bariatric procedure. Besides that, he is the IFSO MENAC chapter president and the vice president of the SASMBS.
Yes, good evening, everybody. We are sorry for the delay, but this is what happened. So my presentation will be the complication. I will not talk introduction too much. What are the causes of revision failure, or to lose weight, or loss of quality of life, or complication of previous procedure? These are the most indication for revision. VBG, restrictive procedure. Either you can do BBD, mini bypass, bypass. Why VBG is one of if you notice, you have a lot of options. If you have cases with all the organs is there, you have many options to do anything. So this is why we have to have a reversible procedure is more important in case of revision. So in gastric band, still you have all the options available there because you have all the organs still there. Gastric bypass again, gastric band, banded gastric bypass, distal bypass, mini gastric bypass. It depends what is the complaint of the patient, what is the situation, why we are reversing the procedure or treating these complications. So we have to, most important thing to analyze the patient, why you want to do this procedure. Sleeve, you have all the options. Also, you have only re-sleeve, mini bypass or BBD. We don't have much option except these two procedure because you don't have BBD. Again, you have all the anatomy. It depends to the cause. Is it malabsorptive to engage the limb or to full restoration? You have a wide range of revision of BBD. Novel techniques with all the, just to mention, revision of BBD by Scopinaro, by all the revision of BBDs associated with weight regain, because you are elongation, treating the complication, which is metabolic, mainly for BBD, metabolic complication. But we have novel technique by revision, elongation of the limb, and resizing the stomach. This is what we are doing. I have done more than 25 cases. I added resizing of the stomach. This is why I gain correction of metabolic complication and also no weight regain. In spite, you will have better weight loss. So it was not mentioned by Scopinaro in his revisional case of BBD. But we learn from revision of Scopinaro a lot of things. Because of its, that's how we will show you the post-sleeve to mini bypass. We start classical. You have to see the anatomy. Most of the probably of our cases is due to the weight regain or chronic vomiting or malrotation.
I did not present the acute complication like leak or bleeding in this video. Just simply the only indication of these cases is weight regain. So you have to review your anatomy, evaluate the upper part, and for this patient, it is clearly obvious why this patient gained weight. The upper part is fine and good. You don't have to do anything, but look for the distal part of the stomach. It was so big because I think they started with more than 10 or 7 centimeters from the pylorus. This is why you have a big antrum. So this, as we mentioned this morning, and here in the revision of sleep, the technique is different. We don't go from the lesser curve side. We go from the greater curve. You don't. It will be easier, and you resize. You don't have to be meticulous in resizing of the pouch because you are doing sleep. In this case, we find some little. I think hiatus hernia. We corrected. So again, with the same technique, I would like to tell you that revisional surgery for weight regain, you don't expect that the response will be like the virgin or primary case. They never lose as good as the primary case. This is, you have to consider it in your mind, and you have to, if you add malabsorption, you have to be more than normal. I mean, if this patient primary procedure, you have to do 160 biliary limb. In revisional case, you have to make it more because there is adaptation of the GI for absorption. You have to consider it, otherwise they will not lose as much as you expect. So you have to add more to 10 centimeter long for that considered case. The technique will be the same. We don't have much, but most important here, I will show you here, this is a case of sleeve. Malrotation. Malrotation, why it happens is very common because the stapler line. When you do the sleeve, please don't make the stapler line anterior. Do it as a standard, it is lateral. If you make it anterior, the liver will lie over the stapler line anteriorly, and there will be adhesions. The liver will shrink after 1 month. It will shrink and will pull the stomach with it and will cause malrotation. So in this case, it's a malrotation. So we have to read, and I found incidental hiatus hernia with this patient. Again, the same thing, weight regain. So please, your technique in sleeve gastrectomy, try your best to make the stapler exactly at the lateral side. If you find a hernia, small hernia, you have to just 1 or 2 stitch. You don't have to do much, but you have to repair it. Don't close your eyes and you make sure if you didn't see it, you do something. Again, please, we have done many revision of sleep. I find the stapler line anteriorly. This is called vomiting and symptoms of the patient later, not acute. Within 3 months, 2 months, the patient will come to you. And you cannot tolerate because it's malabsorption, malrotation. Malrotation is due to the stapler line adhesion to the anterior stomach. If you do it this way, please be careful with your sleep. Other thing, bleeding from the stapler line. Please, you don't have to be so generous with the stapler. So put in your mind 50% they gain weight and need another operation. So don't make us in a trouble that I find a stapler line and hundreds of clips there. So please don't be too generous with the clips because somebody will come one day and do something and you will see what will happen to us. So the same technique, you don't have to do much. Again, the same technique here. Now we come to the, why I show you this video, to show you the technique of sleeve gastrectomy. Everybody will tell you, do this and do this. You don't know why, because we see why. You don't have to, if you want to over-sewing of the momentum to the stomach, if you want to do it all, don't do one side or one in the middle to keep the stomach in the situation, because we have seen cases of narrowing or angulation, because they suture it in the middle to the omentum, and it will be like L shape, and the patient complains. So you want to do it complete or not to part only, upper part or middle part or lower part. It will make an angle, and the patient will complain. Endoscopy will see everything is normal, but when you go inside, you will find what is the situation. Regarding the suturing, you have to do in both sides. It's better because most of the leak, as you said this morning, close to the angles. Please be careful about the angle when you close the enterotomy from both sides and close it in the middle. So the technique is the same.
Nothing special for this case, but if you find any hernia, even is small, your recommendation, people who are doing so many sleep, we have to do something regarding the hiatus hernia. We go again. You see, this is type of sleep also. This patient, especially I make 2 videos, but I make something there to tell you the truth. It is not the same patient. You see this patient, there is no small gauze inside. The second patient, to tell you that is different. But 2 different patients with the same pathology. Imagine, this is a sleeve, post-sleeve. How many staplers they use? I don't know. You see from more than 7 centimeters from the pylorus, and only he stopped in the middle of the stomach. So you see how large is the sleeve. If you want to do this revision, you have to be sure that posterior, because adhesion posterior will push the stomach down and will give you big sac. After you do this, and please, you see now it is closed. When we dissect it, you will find a lot of stomach. Al-fundus is still kinking there. So please be sure that you have al-fundus is clear and angle of his is clear on you, in front of you, then you put the stomach. So this is a sleeve. I would tell you I have almost like these cases from everywhere, even from here, from our area. It's not from outside the kingdom, it's from our area. Most of these cases, weight regain. So please, if you want to do sleep, take care of this, and posterior part. You see, I dissect the angle of his. You see, all these parts of tissue, stomach will be there. If you do even mini gastric bypass, you would end up with biggest pouch. So you have to do the dissection carefully, and you have to have a very nice, good tube. Posterior, you see a lot of adhesions. So this is, we call it, I don't know what you call it, sleeve or partial sleeve or mini sleeve, or I don't know, even the proximal part. I don't do sleeve too much, you see, more than 7 centimeters. So you select your side. I will show you the issue of using too much clip to control the bleeding. Bleeding can be controlled even with the pressure, or you do anti-bleeding like Surgicel or anything, or just wait for a few minutes because it's stapler line. Again, we do the same thing, from the lesser side. Please, your landmark is the stomach. Always, I tell my assistant, start from here, and you go, just the stomach wall is your landmark until you go to the lesser cave. Be careful, be careful. People will go dissecting until they injure the pancreatic tissue. When you reach to some part, retract the liver upward, and then you can do dissection, because we say it in Arabic, تسرح for dissection, and you go on and you go on and you find yourself middle of the pancreas. Pancreas is there. It is very ugly organ, and he doesn't like anybody to touch it. If you go reach posterior, elevate the liver, retract the liver up so you can see again. There was a problem here. In this case, we resize it, because if you don't resize it, you will not benefit much, because this is a revisional case. Resize the stomach. It was so big. In the first case, I didn't resize it because you don't need. Again, here, I told you, believe me, it is not the same case, because I put piece of gauze there to differentiate. But it is the same principle idea of doing sleeve, very huge fundus, adhesions. You see, they are suturing, they suture all the omentum to the stapler line, and you posterior don't, please, you have to dissect posterior and anterior, because this adhesion will pull the stomach. We saw that. After you dissect very carefully and you see posterior, you see it was big and narrow and big again. It's like hourglass. Somebody mentioned today that they will gain weight and increase the reflux. You have big pouch upstairs and narrowing, and it's the reflux. So select your size again, and you do dissection. And mainly we go from greater cave toward the lesser cave using the stapler. Be careful, you see, always raise the stomach. Don't do the stomach while it's lying down on the pancreatic tissue. pancreatic tissue injury in this bariatric surgery, you cannot appreciate it intraoperative. You cannot. You will find the patient post few days. You see, again, I try my best to clean it, long pouch, narrow pouch, but you see, failure of a stapler. This is failure of a stapler due to many clips for controlling the bleeding. So my stapler is failed because the clips was hidden behind the tissue. So please don't use too much clips to control the bleeding. Bleeding can be controlled by other modalities. So in these cases, don't continue. You have enough tissue. Don't say, okay, I will continue and resect it. It's better to be safe. You resect this part. It is failed. You don't know the ischemia. What will happen? Just resect it. So new, fresh upper part, and this part, don't leave it. Don't say it is okay and I didn't do anything. No, resect it. You are not going to lose anything. You will be more safe. You will be 100% secure. This part, which is a failure. Otherwise, if you look, there is nothing. But it doesn't cost you much more than small stapler, 1 centimeter distal, and you finish this part. It is, I'm not happy to have it, to be there. So after that, you can see, you resect the pouch, be careful, and the same technique, you have to go posterior, suturing from, I start from both sides, you have to select the proper lung, removal of band, again the same thing. The only thing I would show you here is technique is a little bit different. Don't remove you see the adhesion between the liver. You have to see the fundus and angle of Hess carefully and clearly. Otherwise, you will, I always keep the band in the place because this will help me in traction, in anatomy, and I will recognize. After we finish the removal of band, you continue, and this, you have to remove it. Okay, liver retractor, I use a stitch and using the liver retractor in these cases. Please try your best, but don't be heroic. Don't do it too much. You don't have to remove it all circular because it's like a band. If you can remove it all, fair enough. If you don't have to do until, and you end up by perforation of the stomach because it's very thin. And our technique is the same thing. We go and angle of Hess, you have always to be away from the scar tissue. This is a standard. You do your pouch, not a big deal. The same thing distally. You can see we use the same size of the stapler, either blue or the tan, the new. Sometimes you use purple here for the face, but the rest of it, you use tan. You go, the most important thing is the last stapler. In the mini gastric bypass, you don't have to be meticulous with upper part. A little bit bigger size, distally is not a big deal. You be careful about the scarring tissue. When you put, it's not a problem if you to go to a little bit away. You see, you have to be careful. This is the most important tricks in the upper part. Otherwise, the rest of the procedure is the same. You have a long tube, little bit, 18 centimeter, even more than 18. And the key point for weight loss is not the pouch alone. It is the size of the biliary limb here. I always, for revisional cases, do it longer than the normal. As I said, just add 10 centimeter, you will be fine. So thank you, because no time. This is just a few presentations.
Our next speaker, thank you so much, Dr. Khalid, for the nice demonstration of this nice video. Our next speaker, Dr. Salman Al-Sabah. Dr. Salman, he is the chairman of surgery in Jaber Hospital and the president of the Gulf Obesity Society of Surgery. Dr. Salman contributed in several international presentations and as a speaker, as a moderator, and he has a lot of publication, and he's very interested in the balloon and intragastric modality of weight loss, and he will talk to us about the balloon complication lessons we learned.
Thank you for the great introduction. First of all, I'd like to thank Dr. Ali Tashrif and the organizing committee for the invitation. Assalamu alaikum. We'll start with, I'll make this presentation as short as I can because of the time. And these are my disclosures. From the SASMBS data, you can see that the balloon in the US started to gain popular, and from 0.3% to 2.8, but then went back to 2%. And I think this is an interesting effect why it dropped down, but we will see in the future. Now, from business point of view, and if you think about business and what is happening in the Middle East, you can see we are this area is one of the highest prevalence of doing gastric balloons. And the most common is the fluid balloons, and basically one balloon instead of multiple balloons. So these are the balloons that are in the market. The one in red are the FDA approved balloons. I'm sure some of those will be FDA with time. In terms of weight loss, this is a meta-analysis. You can see that it's around 25% excess weight loss. Some of them less, some of them more, but 25%. My own practice, I do Orbera, O-balloon, SPATS 3, and Ellipse, as well as I tried also the Helisphere, the air fluid balloon. We have done quite a number of publications regarding that. And in our practice, we use BMI 27 to 40 in Kuwait. But you have to know that in FDA is approved in the US, only 30 to 40. In the US, you cannot use it as a bridge as well. So if you have higher BMI than 40, you cannot use the balloon. We use it as a balloon, as a bridge, and as a rescue procedure in my practice. So this is an example of a balloon. So I went in for this patient to do a sleeve, but because of the liver is so fat, and you can see you cannot lift it even with 2 retractors. So if I don't see the GE junction, I prefer to have less risk and do a balloon. You can see the balloon is done in the same patient. And I consent those patients, especially with a high BMI, either I quit the procedure, do a balloon, or try with weight loss. You can see the difference now, 6 months after I removed the balloon and did the sleeve. It would be a straightforward sleeve. So in my practice, consent is very important. So the patient should know what they expect from the balloon. Medication to reduce nausea and vomiting, endoscopy, body measurement. Some of those patients, if their weight doesn't drop much, but the body measurement changes, and that will make them encouraged to do more weight loss. You can also do balloon plus, where you can use GLP-1 medication, for example, Saxenda or other medications that helps. You have to have an MDT, and most of those procedures done in centers, but you have to make sure they have emergency services, because the first week of their balloon, most of those patients come back. These are our medication. We use Iman for 3 days, PPI, and Zofran, and so on. And why we're using that? Because we know from the literature, if we use Iman, we can see less vomiting and nausea. GLP-1 plus our balloon are also helpful, but we don't have enough data yet. Our own practice, we see that 35% of balloons, 6 months after the balloon, they will regain weight. So it's important to understand those patients, 35% of them in Kuwait gain weight. Balloon after balloon also is another trick you can use, but I tell my patient, there's not much data, but I tell my patient that the second balloon will help you to maintain your weight more than losing weight. Balloon removal is very important because there's incidence of mortality. Because if you don't, especially with the fluid balloons, and the stomach is full of fluid, and you remove them without intubation, you might cause aspiration, and patient might have serious complications. Side effects, so early removal, 7.5%, they will have balloon removal early, and there is rest of complications such as listed in this table. Mortality could happen, it's very low, but it could happen. Now, FDA brought this sentence, it's talking about that balloons could cause pancreatitis, perforation, obstruction, and this is a warning that balloons could cause that. Now, this is some examples of different balloons with different complications. So you can see on the left video, this is a balloon that's been done. It's an intragastric balloon, fluid balloon. You can see it causes bowel obstruction and also congested, almost close, very close to ischemia of the terminal ileum. So basically, we do a transverse incision, and then we remove the balloon through that. So different balloons, they have different ways of removing them from the bowel. So I'm going to show you different balloons. So this is one of the fluid balloons. Those of you who does balloons, they know what kind of balloon this is. And we repair it this way. There's other balloons that came new in the market as well, and these are the swallowable balloons. Okay, the first version of the swallowable balloons we had few incidents of that, but now the latest one, we didn't see any issues with migration. So again, when you do fluid balloons, it's better to cut it because most of the time there might be fluid inside them. So you can see there is fluid. That's why it did not pass through. So this is a trick it's important to do. And basically, once you suction all the fluid, it's the easiest balloon to be removed because it's very thin compared to the other balloon. Now, be careful when you remove those balloons, you will have spillage of bowel content. So in our other experiences, we use a bag to prevent or to minimize spillage. You can see there's a lot of spillage that happen. And so it's a laparoscopy, but you have to know that you have a high risk of infection, peritonitis post. So make sure that you have a bag inside and all that. Early intervention is important because we've seen ischemia happening to bowel if you leave the balloon for a long time. Now, this is another kind of balloon. And basically, you can see that this balloon is called SPATS balloon. It has a reservoir or a tubing system where you can adjust. You can see the balloon by the CT scan. It's stuck in the terminal ileum, but the end of it in the cecum. So basically, this is 2 months after the balloon insertion. This happened. So what we do, we put a laparoscopy in to see that, and you can see the reservoir is in the cecum. It's obvious down there. And there's some fluid there, but the patient presented with signs of obstruction. And again, early intervention is important. You can see the bowel is congested, the small bowel, and that's the balloon in the cecum. And so I showed you all kinds of balloons that could cause that, right? And so they have different way of doing it. When you remove them, you have to think differently because they're different shape. So this one I tried to remove by colonoscopy because since it's in the cecum, we said maybe we can pull it through the cecum. But when I pull it, you can see that it came down to the transverse, but because the tubing, it get elongated, so we could not. It went out from the rectum, but the balloon was still in the terminal ileum. It pulled everything down. So again, when we remove the balloon, we go above it. So it's like any obstruction, you go to the areas less inflamed, like here. See, in this case, we show you the suctions all the time there to prevent spillage. We divide again to make sure if there is no fluid inside that we can suction. But this kind of balloon is thicker. You can see how much torque we need to remove it from the bowel. You can see like
everybody knows that, so we're gonna fly. Protein deficiencies, vitamin and mineral deficiencies, failure of optimal weight loss, gallstones, low blood sugar, dumping syndrome, renal problems, depression, death at the end. Other complications related to each specific type of surgery, for example, band erosions, slippage in case of gastric band or Forbes band or minimizer band, we have seen it all. Preoperative problems, stroker position and their problems. The presence of hepatomegaly is a major problem. The bleeding, intraluminal, intra-abdominal, everybody knows about it. Case number 1. During difficult revision surgery, sudden active bleeding with hemodynamic instability managed by immediate splenectomy. And the film, please, can we put it on? Yeah, okay, here we go. Okay, this is removing the band. Most probably it was a superior pole large artery, because the patient lost a lot of blood and we could not remove the band, we could not see. The decision was to do an immediate splenectomy, especially when the blood loss exceeded 2.5 liters. And it was done. Till then, I could not see the light at the end of the tunnel. But after we completed the resection of the upper part of the connections between the stomach and the spleen, we hit the jackpot, and I just want to show that the bleeding have stopped. It stopped. Until now, not yet, still bleeding. But now it stopped. Finish. And this is, right. So no more bleeding, gone. Post-operative leakage. My favorite, post-reversal of sleep to mini bypass complicated by kinking and leak at the anastomosis site, converted to Roux-en-Y gastric bypass. This is a mini bypass. When we've seen a lot of that. And this patient did not show, actually, CRP was almost normal, was a bit elevated. Leukocytic count was a bit elevated. And when she started running fever, and the CT scan, which we did, showed uphold of dye. It didn't show leak. So this is the VLOC that have created it. And I was wondering, why did it happen? Usually I freshen up the edges when something like that happens, freshen up the edges till the bleeding occurs. And then I would make a decision either to pursue the same procedure or convert. In this case, as we showed that we tried to pass the bougie, there was a total twist. So the decision was made to dismantle the whole thing. And again, in those cases, you see there is no space, but that is no reason why you should proceed with the laparoscopy. I agree it needs expertise, it needs a good cameraman, but at the end of the day, it always works. Post-gastric sleeve herniation and twist of the stomach, duration 1 year, repeated vomiting, malnourishment. This is a case where a patient had a sleeve gastrectomy, and this one of the case that proves not every stomach would jump and sling up in the thorax, but I believe different tissue types, different muscle status of the stomach plays a role in that too, and the presence of a large hiatus hernia that is missed by the primary surgeon might have played a role. This patient reached a BMI of 16, She was day in, day out of the emergency, taking potassium, taking minerals, iron, and so on. And the chronicity, for 1 year she suffered. You know, even the stomach got attached to the pleura. The pleura became solo and we opened it. Again, there is no big deal. Close the pleura and continue dissection till you free the stomach totally from up. The endoscopy have shown that the stomach they reached the Z line at level of almost 34 centimeter, and they could not pass it because it was an S-shaped stomach in the thorax. So 2/3 of the stomach were up. The duodenum is here. It was almost at the hiatus before we passed the bougie. So we passed the bougie, and you could see the left gastric artery, and you could see even now closure of this defect with non-absorbable stitches, Proline might it be, or Ethibond. Very important, anterior and posterior. And then the most vital and important thing that made me very adamant about fixing the stomach is fixing the stomach to the colopancreatic ligament. And in every case I would do that. Sometimes the ligament is fatty, sometimes the ligament is paper thin, but still it holds the stomach down. This patient, when she woke up from anesthesia, she said, "Can I drink water?" And it was only 1.5 hours after the surgery. I said, "You promise you don't regurgitate it?" She said, "Yeah." She drank half a bottle of water and she didn't, and she was very ecstatic. Small bowel obstruction. Of course, this is 0.6 to 8.6%. We're going to run quickly. Internal herniation can lead, and we've seen people, the colleagues saying that the transmesocolic is the highest, not like we thought Peterson's space is the highest number, and they lead to gangrene sometime. Post-bypass intestinal obstruction, phytobizarre. Patient who is post-bypass with less than 1 month. She ate 2 big tamis, and she came with symptoms and signs of intestinal obstruction, severe pain. And we tried to wait, we tried to give her enemas, we tried to help her, give her oils to drink, gastrografin she drank, she vomits it. So at the end of the day, I decided to go in. Couldn't clear up this, it would have created a mess. I measured the length, it was almost 1.2 meters, and the total bowel length was 11 meters, so I decided to resect it. I just want to show you the content of the bowel. Tamis. Jejunostomy and closure. Okay. Huh? Bypass. Thromboembolism, portal vein thrombosis. This is a 50-year-old male, BMI of 53, 3 weeks post routine gastric sleeve, developed portal vein thrombosis. Treatment started immediately, anticoagulation, history of recurrent, unexplained pain after each meal for 3 months. When he doesn't eat, he have no problem. When he eats, he gets severe bouts of cramps. Presented with acute abdomen after 3 months, we found that he perforated small bowel with ischemic stricture. So he had ischemia, stricture of small bowel, and that perforated. The cluster of bowel that have been there, you know, this is very important, is not to jump to conclusion. Find out the primary pathology, speculate, anticipate, and act. See, bowels were clustered there, and you had to release them to be able to reach to your diagnosis. And here we reach the stenosis, and posteriorly is the hole. So resection and side-to-side anastomosis was done. That's the ischemic part. Fine. Okay. Good surgeons operate well. Great surgeons know how to manage their own complications. Thank you. Questions, or I go home?
Any questions, please?
Thank you, Professor Walid, for great videos and experience. So with that, I'd like to thank you for being here with us today. I'd like to thank our co-moderators.
بعد الصلاة نصلي المغرب ولا قبل الصلاة ولا ايش اللي تشور فيه يا عمي؟ كل ما كان أبدر. طيب على أساس بس اجتماع اللي هو أعضاء الجمعية السعودية للجراحة وجراحة السمنة والمناظير. إن شاء الله بإذن الله بعد الصلاة، إذا قبل الصلاة حاضر. خلاص 10 دقائق، ما ناخذ من وقتكم إن شاء الله كثير. خمسة دقائق بس اجتماع الجمعية.
Pediatric surgery member, please stay in the hall. السادة أعضاء الجمعية، الأعضاء الجمعية، البروفيسور عدنان مفتي، بروفيسور عايض القحطاني.